session, Dr. K. Chandra from Ramgarh, Dr. Govind Sharma, he was somewhere. Dr. K. Chandra sir, आ जाइए. Dr. Govind Sharma, Dr. Purvi Chawla. Where is Dr. Virmani? Sir, phone मार दीजिए ना इन लोगों को. They are here only. Dr. चावला को और इसको गोविंद शर्मा. हाँ? Dr. Purvi Chawla, please. So the chairperson for next session is Dr. K. Chandra, Dr. Purvi Chawla and Dr. Govind Sharma sir. I think he will join us. Madam. Okay, so the chairpersons, Dr. Purvi Chawla and Dr. K. Chandra to please take over. And here comes Dr. Govind Sharma to join us. Please. No. Madam, you can call the first speaker. Dr. Govind Sharma to join you.
Good afternoon, everyone. Thank you, Dr. Virmani sir, and the entire fantastic team of Japicon 2023. Welcome to the state-of-the-art lectures, and we have three very eloquent and very good speakers today. Without much ado, let me invite Dr. Ujjwal Roy sir from Ranchi for his talk. Really looking forward to this. Immuno-inflammatory diseases of the nervous system.
A very young and bright, promising neurophysician from Ranchi, Dr. Ujjwal Roy. Long association with him, and most of his cases we see his sharpness, brightness, and he's a very good singer also. We will be privileged if he honors us with one of his songs in the evening session. Thank you.
Thank you, sir. Thank you for the kind introduction. Sir has been always very kind and blessing, and we have been learning from you, sir. From your prescriptions, we have been learning from, and we have been following you very keenly. I mean, and because we are just 45 kilometers away, so I think we are. First of all, at the onset, I'd like to thank the organizers of this conference, the API, the whole team of API, and I really am enthralled with the hospitality, the atmosphere that is prevailing here, that is present here, and special thanks to Dr. A.K. Virmani who called me and to told that you have to speak something after post-lunch. So it is a very difficult task after post-lunch because the whole blood is diverted into the gut. So with this talk, I would like to, I would try to, divert some of the blood into the brain so that there is some thoughts that if you can initiate after this talk, then I think my talk will be successful. So when we talk of immunoinflammatory diseases, it's why this topic is important. Because currently what is the concept? Every disease, the other disease is actually inflammatory. There is some inflammation that is going on in each and every disease that we have. If we talk of, suppose we talk of stroke, suppose we talk of CAD, everything, we have the inflammatory thing that prevails. So what is inflammatory disease? So it is either infective inflammatory or it is non-infective inflammatory. So we will concentrate to non-infective inflammatory here. And in that we have direct antibody mediated things, which can be either CNS or PNS disorders, that is central nervous system disorders or peripheral nervous system disorders. Or we may have systemic disorders like autoimmune disorders like SLE, Sjogren's syndrome, blah, blah. And we may have secondary involvement of the central nervous system and peripheral nervous system. Last but not the least, is very important, we talk of vasculitis. So vasculitis may be either primary or maybe secondary. Primary CNS vasculitis, as we know, it presents with very symptoms and is different from the vasculitis that we see in patients who have systemic disorders like lupus and other autoimmune disorders. But for the sake of this talk, we will concentrate on the direct antibody mediated disorders and that too just with involvement of the primary CNS or the peripheral nervous system. It's not moving. Next slide is not moving. It's hang ho gaya hai. Yeah, okay, thank you. So when we talk of the central nervous system and peripheral nervous system, so I will start with what is peripheral nervous system. So peripheral nervous system starts from anterior horn cell. Now when we talk of anterior horn cell, the first thing that comes into our mind is ALS. Now there are recent concepts that even in ALS there have been things like autoimmune things that have been playing, and there has been a recent paper in 2017 by the Japanese group where they have focused that at least some percentage of ALS patients may have autoimmune phenomena or autoimmune etiology. Spinal muscular atrophy, again we know it's a genetic disease. We know about SMA 1, 2, 3, 4 depending upon the age. But then again there have been papers where they have shown that if the inflammation is decreased, the progression of this disease may actually halt. Then we may have root actually. Everyone knows about radiculopathy, GBS, that is Guillain-Barré syndrome that we have, and other radiculopathies, other immune-mediated radiculopathies, the GBS variants that we have. And then about nerves. So then we have nerves. So we have things like autoimmune neuropathy and things like vasculitis, which may affect the nerve. And then we have neuromuscular junction. Now here we know about myasthenia gravis, and we also know about Lambert-Eaton syndrome, where we may have fluctuating weakness and diurnal variation and blah blah things like that. And then we have muscle. So in muscles we may have inflammatory myopathy. So inflammatory myopathy, again an immune mediated condition. When we talk of the central nervous system, so we start from the encephalon. So we have encephalitis. So we may have autoimmune encephalitis, we may have things like paraneoplastic encephalitis, and then we have things like EDEM, acute disseminated encephalomyelitis. That's again an immune mediated thing that we have. And then may have things in the spinal cord. Again, there may be transverse myelitis, things like primary NMO, that is neuromyelitis optica, where we may have just the spinal cord involvement. And then new things coming up like anti-MOG disease and sometimes childhood MS that may actually present as edema. That may also be there present in this array of disorders. So around 4.5% of the individuals, the immune system attacks the same individual, and abnormal immune responses are responsible for more than 80 autoimmune disorders, including 30 in the nervous system. So we have central nervous demyelinating disorders, as well as I showed in the diagram. So we have multiple sclerosis, NMO, paraneoplastic and other autoimmune encephalomyelitis that I discussed. And we may have things like autoimmune inflammatory myositis and demyelinating autoimmune neuropathies. And so what are the factors behind breakdown of tolerance in some individuals? So there may be several factors. So first, the foremost important is genetic susceptibility. And we may have around monozygotic twins of around 25%. So in monozygotic twins, it may be 25%, that is 5 times more as if compared to dizygotic twins. And then we have myasthenia gravis, with 35% of monozygotic twins as compared to 5%. Also females, as we know, in all of the autoimmune disorders, just barring a few, females are more susceptible for autoimmune disorders. And we may attribute this to the X chromosome factors in genetic susceptibility actually. And also the MSC locus, which has been a very important area of research, and people have stress upon the MSC in last around maybe 20 years or so. And then we have HLA associations like LGI encephalitis, anti-IGLNO5, MuSK myasthenia, early onset AChR, that is acetylcholine receptor myasthenia gravis, and late onset myasthenia gravis also. We have different, HLA associations, DRB1, DRB107, like I'm not going into that details. Now, single nucleotide polymorphism. This is variation in the genome at the single nucleotide levels, which also increases the risk of developing autoimmune disease. What's very interesting here is that many of these single nucleotide polymorphisms are in the non-coding regions. So if we are testing for, suppose we suspect autoimmune disorders, and we are going to send sample for a genetic test. So it's not just the clinical exome that will suffice, but then you have to send the whole thing actually. The clinical exome will not suffice. So we need to send the whole genome sequencing for that matter, because many of these SNPs are in the non-coding regions. Now, all of us know about immune triggers, and we have learned more that in the COVID era. But here we may have infections, viral infection like Epstein-Barr virus or CMV, and then we all classically know about Campylobacter jejuni in Guillain-Barré. I'm just giving 1 or 2 examples just to illustrate. Now, there is a very important concept of microbiota. Now, what is microbiota? It's basically ecosystem of trillions of microorganisms that reside on mucosal surfaces like gut and skin in beneficial coexistence with the host. Now, recently what has happened is surprising connection with the disordered intestinal microbiota and brain autoimmunity. That is called brain-gut axis actually. So, gut-brain axis actually. So, gut-brain axis has been a very important topic nowadays, and there's one hypothesis is that CD4 positive T cells could be activated again in the gut against microbial gut GTP-L fucose synthetase, which actually travel to the CNS and cross-react. So many of these autoimmune disorders may have some relation to this gut-brain axis. And last but not the least, just a few more. After the initial, like epitope spreading is also something which is very important. After the initial CNS inflammation induced by a specific CNS antigen, it results in actually release of cryptic antigens, and they actually provoke the secondary CD4 T cell response. This is a very important concept nowadays, and especially in multiple sclerosis and other demyelinating disorders, epitope spreading has come up like a very important turn in the pathogenesis. Now, sometimes tumors. So tumors may present some antigen which may cross-react with the antibodies, and which may have antibody which may cross-react with the normal cells of the body like CNS. The simple example is the NNDA encephalitis, and especially young females come to us with psychiatric manifestations and intractable seizures, and then when investigated, these patients have autoimmune encephalitis, and actually they have ovarian teratoma sitting in their ovaries. Vitamin D, all of us know it has got varied links with different diseases, but then immune and inflammation, again vitamin D has a role. And people have seen, especially in the multiple sclerosis. So where the exposure is more, the multiple sclerosis is less. So we see in the equatorial region, multiple sclerosis is less. So it's more in the things like America and where there is less sun exposure. So that's the role where of vitamin D. Now it's a huge topic, so I'll just shortly try to cover the disorders and what may be the hallmarks of these. So first, starting with CNS autoimmune syndrome. So what presentation will be there and how you will think that it may be an autoimmune disorder. So first, starting from the very common NMDA receptor encephalitis, now when these antibodies are available in our labs, we see very often these kind of disorders. I think I see around maybe one case in 2 months, maybe even one per month also. NMDA encephalitis is a very common. Patient presents with psychiatric manifestation. They just go from here to there with psychiatrist. If by good luck or bad luck they turn up to us, so we investigate for the NMDA encephalitis, and there may be things like hallucinations, delusions, memory loss, and it's a very basic thing that the patient may land to actually psychiatrist, because these things, catatonia also may be there. And then seizures. Now the seizures also are frontal lobe seizures. So frontal lobe seizures actually may present like pseudo seizures because they have bizarre symptoms like pelvic upthrusting. So everyone will think that it's a functional or psychotic disorder, but actually it's a seizure. And then patient may have orofacial limb dyskinesias, choreoathetosis, dystonic posturing, autonomic dysfunction, things like that. And tumor association is around 60%. So 60% actually may harbor an ovarian teratoma. And then we have a very interesting another syndrome that is called LGI1 syndrome. In an elderly individual, if patient is presenting with some deranged mental function and patient has hyponatremia and you are not finding a cause, suppose patient is not on a diuretic, or you don't think that there is any other cause which is attributing to the hyponatremia, definitely think for LGI1 encephalitis. I have seen at least dozen of cases now, and this responds very, very well to immunotherapy, to the IV methylprednisolone and IVIG also. Now the important thing is that people do not think about autoimmune in elderly individuals. We generally think at the last. We will think other things like metabolic things, like we'll think that okay, this hyponatremia. So patient will have just borderline hyponatremia 127, 120, but the patient will have a very fulminant encephalitis. So if the patient is 127 hyponatremia, how can you think about the encephalitis? People diagnose 127 sodium height, it may be, but then if it is there, definitely think, especially in elderly, definitely think about this disorder, LGI1 encephalitis. And patient again may have faciobrachial or crural dystonic seizures. A patient came to me with a diagnosis from West Bengal, hyponatremia, symptomatic seizures, and things like that. But then when I carefully examine, because we are physicians, our job is like to first examine the whole reports very carefully. That is the first most thing that my teacher used to teach me. If you have a patient, okay, you examine the patient, but get the reports which report was done, and carefully examine what's happening to the patient. That's the basic thing to be done. So when the patient had florid seizures, the report was telling it's 128 only. So I could not believe that this patient has just this hyponatremia and seizures due to that. So we evaluated for autoimmune encephalitis, and this patient had LGI1 encephalitis, and patients respond very well to IV methylprednisolone. But we went ahead for IVIG also, as the relatives were very conscious, and they were his son were actually residing abroad. They had come back, and the patient just went to home walking, and they cut also the cake. He was there in the hospital for 1 month or so. So that patient cut the cake and then he went out. So things like this are very rewarding actually. And things like AMPA receptor encephalitis, we have some cases, but not that common. But if there is AMPA receptor encephalitis, there's more chances that the patient has non-small cell lung carcinoma and thymic carcinoma. Then we have things like GABA receptor encephalitis and alpha-1 receptor of the GABA, alpha-1 subunit of the GABA receptor. These are less common. Now there is one very important syndrome here, that is glycine receptors against the glycine receptor subunit, and this is called progressive encephalitis with rigidity and myoclonus. as we have been reading in our Bible, the Harrison, there is a stiff person syndrome. So stiff person syndrome, now they have told that it's like, you have to label it as progressive encephalitis with rigidity and myoclonus. So there may be muscle stiffness, painful spasm, hyperplexia and brainstem encephalitis in this glycine receptor encephalitis. And then we have things like Casper-2 encephalitis, where we may have neuromyotonia, Moravan syndrome actually. Moravan syndrome may also present with glycine receptor thing, but it's more common in the Casper. A very, very interesting syndrome I'll just mention here is IgLNO5. This patient actually have obesity. I have seen couple of cases now of this syndrome. So the patient will present to you with severe obesity, and the patient will have like sleep apnea, parasomnias, disturbed sleep, gait instability, chorea. So you will think that this patient is just a OSA patient, obese patient. He has some maybe endocrine disorders. So initially the patient will be evaluated for cortisol, things like that. All the endocrine things will be done, thyroid, things like that, TSH and things like that. But everything will come normal. If this patient comes to you, if the patient has like, one thing that is very important, the patient has gait instability. Please, if the patient is an obese patient coming with you with snoring, the history of any parasomnias, please examine for gait. If there is gait instability, this is the marker. If the patient has supranuclear palsy, this is the marker. The patient may have actually IgLNO5 encephalitis. I have seen at least couple of cases now from the last 10 years around, but very interesting actually. Another syndrome that one case I had seen when I was in the institute, and it is DPPX, anti-DPPX encephalitis. Patient presents with prodromal diarrhea, weight loss, and then patient has encephalitis. So it looks like patient had maybe diarrhea, so hyponatremia, things like that, metabolic problems, and then patient has encephalitis, but it's not true. Actually, patient has anti-DPPX encephalitis. Now coming on to some syndromes which actually may push you to a paraneoplastic thing. But very good thing is that these paraneoplastic, especially CNS ones, may present very early, maybe just even 2 years prior to the frank presentation of the tumor or the carcinoma. So that may be actually very rewarding. The patient may have some subtle signs and come to you, and if you can diagnose that disorder, it can be treated early with interventions. Now the oncology is a very vast and very rapidly evolving field. So you may actually save the life of the patient actually. So Ma encephalitis may actually present with testicular, actually is there in the testicular carcinoma, and it may present with diencephalic syndrome. Again, the patient may have drowsiness, thalamic syndrome actually. So patient may have drowsiness, narcolepsy, things like that. And limbic encephalitis, excessive daytime sleepiness, things like that. And then we may have anti-Hue encephalitis, where we may have sensory neuronopathy, limbic encephalitis, encephalomyelitis, gastroparesis, things like that. There are other things, but I'm not going to detail because there will be a long list. So I'm just concentrating on what things I have seen in clinical practice. Now MP5 again, the stiff person syndrome that already I have discussed. Now it's interchangeably like progressive encephalomyelitis with rigidity and myoclonus. Now it's interchangeability used with this stiff person syndrome. And then we have things like CRMP5, GAD65, all of us know, a stiff person spectrum disorder, cerebral ataxia, limb encephalitis. Already I have discussed this, but just one minute I'll take. Seizures occur most commonly in autoimmune encephalitis with NMDA receptor encephalitis, LGI1 and GABA receptor. And faciobrachial dystonic seizures and hyponatremia, already I have talked about LGI1 encephalitis, sleep disorders like LGNO5, and movement disorders like chorea, dyskinesia, hyperkinetic disorders with NMDA receptor encephalitis, Casper-2 encephalitis. And then we have neuromyotonia and Casper-2 or LGI encephalitis and stiff person syndromes in GAD65. Sorry. And autonomic disturbance is very important, especially in NMDA receptor encephalitis and anti-Hue encephalitis. And sensory neuronopathy, again very important, in anti-Hue encephalitis and in CV2 and CRMP5 also. Already I have discussed that in multifocal encephalitic presentation actually looking like edema actually may present in in children especially, then they have the MOG antibody actually. So that is something, our childhood MS earlier it was called, but now they are seeing that it's actually anti-MOG disease actually. And we know about multiple sclerosis. I'm not going to detail. This topic is very vast, so I'm just going to enumerate things. So MS, NMO, EDEM, and then MOG-associated antibody, and then GFAP antibody disease. Now coming on to just peripheral nervous system, I'll just enumerate. So it is AIDP, AMSAN, Miller-Fisher syndrome. These are all variety. These are all atypical GB syndromes, and then we have CIDP. Multifocal motor neuropathy. Now this, just one note about this disease. Many patients actually, they actually are diagnosed with anterior horn cell. The presentation is one and the same. If you see the clinically, patient will have atrophy, patient will have fibrillation, these fasciculations will be there. So only thing that you need to understand is in the NCV, if there is block, you can save his life. You can give IVIG to this patient, and now I think I have dozen of patients with multifocal motor neuropathy who were earlier diagnosed as ALS. But now diagnosed, we have diagnosed them as actually multifocal motor neuropathy, and unko जीवन दान मिल गया, because they were told that you have some disease that you are going to die after 5-7 years. But it was actually multifocal motor neuropathy. It looks clinically बिल्कुल same लगता है. But only thing is that if you do the NCV, you have some blocks at atypical sites. यहाँ पर block नहीं मिलेगा, कहीं इधर block मिल जाएगा. So something like that. So multifocal motor neuropathy, and then we have things like Canomad and paraneoplastic polyneuropathy. Myasthenia gravis already we know, Lambert-Eaton I have discussed. Dermatomyositis, overlap myositis syndromes, polymyositis as we know. Now coming on to treatment, just 1 minute I'll take. I think I have exceeded the time limit, but I'll just take 1 minute, just last. So what is important is that it is very important to understand that which disease we are dealing with. Suppose we are dealing with guidelines of multiple sclerosis and NMO. Now NMO guidelines have been revised recently by Winker-Chu, basically fellow from China. So he has revised basically the diagnostic criteria. So now it is called NMO spectrum disorder. So it's a wide variety of disorders actually, which may actually present with simple diencephalic syndrome. One patient had come to me with intractable vomiting, but he was not referred to me for intractable vomiting. He was referred for me as diagnosis as query functional, referred to the neurologist. So it was something functional, उसको उल्टी हो रहा है, सारा एंडोस्कोपी कर लिया, LFT नॉर्मल है, nothing is coming out. तो एक बार न्यूरोलॉजिस्ट को दिखा लो, because it's happened very commonly that patient is some functional, तो न्यूरोलॉजिस्ट को भेज दीजिए जरा. तो he came to me, तो मैं भी न्यूरोलॉजिस्ट वाला काम कर दिया, मैंने MRI कर दिया उसका, and I saw that there is basically area postrema में there is long segment demyelination. This was a case of area postrema syndrome. Area postrema syndrome is very upcoming this syndrome in NMO, neuromyelitis optica. So neuromyelitis optica spectrum disorder, it has got a whole definition actually. And out of that, patient may just present with some mild ataxia and this intractable vomiting. So that patient may actually, and this was just interesting case. So the patient may have actually area postrema syndrome. That is a part of the NMO spectrum disorder. So it's very important, because if you give this MS drugs to these NMO patients, it's going to like catastrophe होने वाला है. ये तो NMO और MS में diagnosis बहुत important है कि whether it's NMO or it's MS, because बिल्कुल जमीन आसमान का फर्क है. Here the treatment is totally different. यहाँ पे अब हालांकि एक दवा ऐसी है जो दोनों में दी जाती है, रेटोक्सीमैब. So वो दोनों में दे देते हैं. But क्या रेटोक्सीमैब शुरू तो नहीं कर सकते किसी मरीज को. तो we have to start with basic. If unless and until the patient is very aggressive and we think, but still, I mean, in MS also still we will try to start with things like
Sir,
interferon.
can we wind up? We are
Yeah.
over time. Thank you.
Thank you very much. Thank you for patient listening. Yeah.
That was a fantastic overview. Very, very tough topic to complete in 18 to 20 minutes. Sir, can you just wait? We can take at least one question.
It's actually very difficult to talk about this topic in just 20 minutes. I mean, I was wondering, sir has given me very tough, he has been like a master, master job basically. But then I have to listen to him, whatever he has told, I have taken like a prasad and I have started.
I have a query.
Sir.
During the COVID period,
Yes, sir.
has there been any increase in the frequency and severity of this group of diseases?
Very, very important question. So that's a very relevant question. So I had actually seen more of encephalitis, but more than that, I had seen GB syndromes. So there was a like epidemic of GB syndromes in the ICU. just post COVID, I think just 2 or 3 months later. So एक लाइन से, और वो IVIG वाला कंपनी के पास, किसी कंपनी के पास IVIG नहीं मिलता था सर, वो इंटास वाले के पास, उसके पास भी खत्म है, उसके पास भी खत्म है, लोकल कंपनी जैसे वो बिल्कुल मार्केट, वो ब्लैक में मार्केट कर रही हैं, थिंग्स लाइक दैट. जस्ट जीबी के बाद, इसके बाद कोविड सेकेंड फेज के बाद. So 2 months later, I had seen the whole ICU was just filled of, जो stroke वो सब बंद हो गया था, और stroke भी जो होता था वो भी vasculitis से होता था. So you are right actually, that was, so that actually again explanation is that antigen and that cross linkage of the antibodies, things like that.
Thank you very much.
Sir, thank you, sir.
A really wonderful lecture by a very eminent scholar. One more question.
Actually, this topic is so interesting that it can go up to 1 hour, 1.5 hours. It will like, sir.
Yeah.
Please, sir.
I saw the association of these immuno-inflammatory markers
Sir.
with malignancies.
Malignancy, yes,
Yeah.
yes, sir.
Are they actually paraneoplastic or just they're manifestations of the primary occult malignancies or overt malignancies, or what is it? Is it
Yes,
par-
sir, that is very
And
important.
the second question is, you said all these diseases lead to inflammation, right?
Yes, sir.
The pathway is inflammation.
Yeah.
If I revert it and I say all inflammations or inflammation leads to all diseases.
Acha, that is, yeah.
Okay, but first question.
Yeah, this, so first question, for your first question, sir. So suppose there is ovarian teratoma. So ovarian teratoma, what may it may lead to? So there are different, hormones that are ovary releases actually, or it may be local some factors. Local उसको basically some compression हो जा सकती है, ureter में compression हो सकती है, तो hydronephrosis हो सकता है, things like that actually. लेकिन, but what is paraneoplastic syndrome by definition is that it is not the direct cause of the tumor actually. It is not due to direct causative, but so it is the paraneoplastic syndrome जो pathology में सर हम लोग predominance में पढ़ते थे. So it is like, it is not the direct causative from the this. So it is not the direct. So it is actually paraneoplastic syndrome only. These syndromes are paraneoplastic syndrome, not the direct manifestations. But yes, these may be very early, and this may be very rewarding to catch these tumors via that paraneoplastic phenomena. Because then we may actually catch these things early. And then we may start the treatment early. We have, as I said, sir, the oncology field is greatly advancing, and now things like CNS lymphoma, patients are like, वो marathon run कर रहा है sir. There is one patient, my patient, वो marathon run कर रहा है, उसको CNS lymphoma था. उसको किसी ने basically glioma बता दिया था, उसको glioma वो मान के चल रहा था, वो अपना दिन वापस गिन रहा था, but उसकी biopsy हुई तो उसमें lymphoma निकल गया. तो lymphoma तो इतना rewarding आज के डेट में कि he now running a marathon actually. So things like that. So we are like, we can catch these early. And your second question, sir, again that. Okay, yeah. So you are right, sir. So what happens actually? That thing has always a scope actually. So my thesis topic in MD medicine was like periodontitis and CAD and cerebrovascular disorders in chronic kidney disease. Very, very atypical topic. But then I had studied. So what happens actually? It's always a bidirectional things. So actually chronic kidney disease may lead to systemic inflammation, and then inflammation may lead to actually CAD, and CAD may lead to, So again, it's a bidirectional. So again, inflammation may lead to increased CKD. So CKD may lead to increased infection, which again may lead to progression of CKD. So things like that. So if we have inflammation, definitely the things may actually deteriorate. But as far as this topic is concerned and my talk is concerned, it's like the inflammation is there due to these, these tumors, the antigen sharing and the antibody formation, and that inflammation is manifested somewhere else, not in that organ. But yes, you are right, sir, because that inflammation may again actually deteriorate the course of that disease per se also. That is what.
Thank you, Dr. Ujjwal. Very informative. Thank you very much. Big. Our next speaker is famous physician from Bhagalpur, Dr. D.P. Singh. Very dynamic, young at heart, speaker, keen interest in API activities, and a very good speaker. So welcome, sir, Dr. D.P. Singh. And your topic is management of MDR-TB. The world, and especially India, has focused to eradicate TB. The target is 2030. Earlier, the target was 2025. It has now been shifted to 2030. And let us see our able physician, Dr. D.P. Singh, what he has come with newer ideas, how to eradicate it. Thank you very much.
Respected chairpersons, my distinguished delegates and friends, my sincere regards to our mentor, Dr. Professor B.B. Thakur sir and Dr. Kamlesh Tiwari sir. And I am very much thankful to the organizing scientific chairman, very dynamic man, the symbol of API, Dr. Anil Kumar Virmani sir, and who has allotted me to speak on this topic, and that is MDR management. And this is my alma mater from which I have got graduation, post-graduation, diploma, everything. And this is my place of worship, that is Jawaharlal Nehru Medical College, Bhagalpur. And this is my postgraduate department of respiratory medicine, where there is 20-bedded this MDR wards. And for last 1 decade or so, we are seeing the patient, admitting the patient, and most of the patients, they are coming from the eastern Bihar. Every time this ward is flooded, more than 20 patients, 30 patients that are there, other MDR or XDR is there in our wards. And remember this man, Lee B. Richmond. In 2001, he said, the MDR is a ticking time bomb. And this time bomb is made by us. Man-made problem. It is costly, it is deadly, it is debilitating, and the biggest threat to our this management TB control strategy. And what is the situation today? 22 years has elapsed. What is the situation today? And we shall see how the treatment has changed, how the diagnosis has changed, and what is the present situation. And this is the Mycobacterium tuberculosis, discovered by Robert Koch in way back in 1882, 24th March. You can't see whether it is a rifampicin-sensitive Mycobacterium tuberculosis or it is a rifampicin-resistant Mycobacterium tuberculosis. Look are similar, but they can be sensitive. You can cure it, you can kill it, or they may be resistant, where maybe many drugs will not be working. And what is the situation? Just now, 10 million new cases every year we are pouring. Every year 10 million new cases, sir. And after the COVID, 10.6 million people they are pouring. It means that 4.5% increase in the incidence of tuberculosis after COVID. So that whatever gain we have taken from this strategy of the RNTCP or NTEP, that has been again gone back to the pre-COVID periods. And that is the situation today. In 2017, the TB incidence per lakh of population was 211. At present, it is still 229. And the matter is that the TB notification is just 1/3. Suppose the government, we are notifying the TB patients for 1 lakh population 211. It is not true. Because 1.8 patients are missing in the society. They are not diagnosed. Even the doctors are treating, not notifying. So it is just triple of it. So if Jharkhand or Bihar is having 229 per lakh of population, you imagine the maybe 600 per lakh of population. This is the situation. So because the notification is not perfect. What is the HDR today? Per lakh of population is 11. What is the data in 2019? Recent global estimate said almost 0.5 million, half million new cases of MDR cases. And of that, there are confirmed 80%, almost 80% MDR cases are there. And data is 9 per lakh of population. But it is not true again, because the notification is not there. It should be 27 or so. But data is this. And the first National Anti-Tuberculosis Drug Resistance Survey says that 28% of TB patients are resistant to any of the anti-tuberculosis drugs. And you know that the primary resistance is around 2.8 and the secondary resistance is very high. Some of the states it is up to 30% and the average is 11%. So what is the definition of MDR? So MDR definition is that if the patient has got Mycobacterium tuberculosis is resident to the first line of drugs like rifampicin and INH, because that is a very important, potent drug, and they become resistant to it. But new definition says you add the quinolones also. You add the second line injectable also. So it means this combination of this, that has been new definition of MDR now, is that you can add fluoroquinolone and second line injectable. But what is the XTR? XTR means HR resistance plus this quinolones plus injectables, both are combined. And this XDR is that only quinolones are resistant. So these are the different. One of the varieties INH resistance also, that is called monoresistant, but it is not MDR, it is that drug resistant tuberculosis. So how we diagnose this MDR? Whenever you get a patient of either pulmonary or extrapulmonary, a patient having cough more than 2 weeks duration, you do the sputum microscopy. You said that patient is suffering from tuberculosis. You give the 6 months treatment of 2 HRZD plus 4 HRE. Patient usually responds within a week. Patient responds with your treatment. Patient is usually asymptomatic. There is reduction in symptoms. But suppose the patient is not responding, and then you think could be a case of MDR, whether it is pulmonary or extrapulmonary. But nowadays, what we say, whenever you get a case of this tuberculosis, whether it is sputum positive or negative, always send the sample for CBNet. CBNet, that is the molecular diagnosis. CBNet, that gives the early diagnosis. CBNet gives the diagnosis within 90 minutes. So, in any case, whether it is pulmonary or extrapulmonary, you send the sample for the sputum AFB, but also send the sample for CBNet, cartridge-based nucleic acid amplification test, and that will give you the diagnosis whether your patient is rifampicin sensitive or rifampicin resistant. That's the early diagnosis is there. So MDR patients can be diagnosed easily by gene expert. Gene expert will give you diagnosis within 90 minutes. But a case of INH resistant, if it is there, INH resistance, if it is there, line probe assay will say INH and rifampicin resistant will be there. But the gold standard in the diagnosis of tuberculosis is sputum, this culture, liquid culture, Bactet method of liquid culture. That is the gold standard. But it is not available everywhere. But we have got in the laboratory line probe assay that will tell you INH resistant. But the gold standard is again the culture sensitivity. Even the second line, this line probe assay, the first line resistance can also be diagnosed. Second line of drugs can be also diagnosed by this line probe assay. So nowadays, by the molecular diagnosis, even you can know within no time the resistance pattern of not only the rifampicin and INH, but also of the quinolones and second line injectables. So this molecular diagnosis has brought the revolution in the diagnosis of tuberculosis. And these are the gene experts. We have got gene expert Ultra. We have got TrueNet, that is the India made. And that has also helped in the diagnosis of this COVID. In the COVID-19, we have got use of this TrueNet also. We are using it and very useful, not only this pulmonary tuberculosis, but also the extrapulmonary tuberculosis or possibacillary disease, also in the HIV, also in the children, where there is paucity of this tubercle bacilli, and there they can pick up is as good as you can say culture. Maybe that 16 to 100 this bacilli can be picked up per ml of sputum or per ml of samples, then can be picked up by this gene experts Ultra. And we have got also the platform that can give the diagnosis of the second line injectable, second line this quinolones also, that is called expert MTB XDR. So this is very important. So whenever nowadays the dictum is that whenever you get a diagnosis of tuberculosis, universal DST is must. So unless you know that the patient which you are treating, whether it is a rifampicin sensitive patient or rifampicin resistant patient, within 15 days you should get the diagnosis and then you modify the treatment. So that has revolutionized our this diagnosis as well as treatment. Again, we are also taking help of this whole genome sequencing. And then whole genome sequencing, that will give the comprehensive review of entire Mycobacterium tuberculosis genotype. And that can give you 96% concordance with the culture-based sensitivity testing. So that this will be the true diagnosis once we can get this whole genome sequencing. This is not very much available in every center, but yes, if this comes to our laboratory, this will also give the revolution in the diagnosis as well as direction in the treatment of this. This is the age of the artificial intelligence. Whether it can give help in the diagnosis of this MDR? Yes, especially in the difficult reading of line probe assay. This can help us, and that is very helpful in the diagnosis of, or especially the result of line probe assay. So once you diagnose a case of MDR, what is the treatment? Earlier we were very much hopeless because patients were also hopeless. Why? What is the idea? What is the objective of this MDR treatment? Objective is you have to cure the patient, number one. Second is that morbidity is very much high. You have to reduce the morbidity caused by the disease. And third one is that large number of drugs, large number of tablets they have to consume and that they are toxic. So very much this non-compliance is very much high once you give that. So this regime should be such that that is safe, efficacious, tolerable treatment regimen. Initially, all MDR cases were treated by injectable, kanamycin, streptomycin, and amikacin and other. Nowadays, we say no. To say no to injections. We are all night trying to give all oral regimen. No injection is given, even the shorter regimen, no injection in the longer regimen. So injection-free regimen we are offering. So you say, what is the saying that Bob Dolian says? The old roads are changing rapidly. पुरानी सड़कें जो हैं बदल रही हैं, नई सड़कें बन रही हैं. उस तरह की बातें हम लोग we are trying to see, trying to find out whether this old treatment is gone and new treatment is coming in the offing or what is there. And see, even the drug-resistant tuberculosis, when we were treating just now, and that is only 57% efficacious. 57. It means this out of 100 you have got only the 50 or so odd patient that will be cured, but 50 patient, 20 patient will be death, will be die, 20 patient will have failure, and 20 patient, the 10% will be lost to follow-up. So that is the misery of the treatment of this MDR tuberculosis. So this oral regimens and other possible changes, what we are going to see, let us see what is there. So there are now 3 treatments available. One is that 9-month all oral regimen, that is what we are giving. We have started giving that 9-month all oral regimen. Second is that 18 months all oral longer regimen. And in this there is no intensive phase, no continuation phase. All are 16 months, we give the 5-drug regimen, and that we have started it. And then there is new regimen is coming, that is in the operational stage, that is the BPAL regimen. We shall see what is the efficacy of it, what is the treatment of this. So current treatment is complex, but most notably the longer duration of treatment, that is very baffling to the patient. And there is a minor difference between this WHO and this American Thoracic Society. WHO said, no, 4 drugs is enough. But the American Thoracic Society and European Respiratory Society said, no. At least 5 drugs must be given, and we see the reason for that. 93% our success rate is there if you use the 5-drug regimen, and the 4-drug regimen you have got 89%. So difference is significant. So whenever you use any MDR treatment, always use at least 5 drugs in the new regimen. That is the 2 or 3 things are there. So in our earlier days, when we are student, what we were taught, the anti-tuberculosis treatment is the first line drug, second line drug. Now we just try to divide it, first line drug for MDR I say. First line drug, second line drug, and third line drug. So what is that? In the first line drug, we have got 5 drugs, and the best is levofloxacin or moxifloxacin, that is number 1, plus 4 other drugs, bedaquiline, that has got revolution. Bedaquiline is one, linezolid, that was antibiotic, linezolid, clofazimine, and cycloserine, and these are the 4 drugs we add in the first line drugs, especially in the all oral longer regimen. And there are other, all drugs are either second line drugs and third line drugs are there. These are all the drugs that we use in the treatment of, current treatment of tuberculosis, except for the rifampicin. All drugs are being used in the MDR patients also. And we must know what is the toxicity. I have seen many cases of MDR having the severe anemia and found out that it was due to linezolid rather than anything else. We had to give the myelosuppression is one of the side effects. Similarly, you can see this bedaquiline that is known to cause the QT interval prolongation. So every physician or every chest physician, everybody has to be a cardiologist also. You have to do the ECG in the initial stage for 15 days daily and the monthly. So QT interval prolongation, that's a very important side effects of bedaquiline, delamanid, and linezolid also. So nowadays, whenever we make a treatment, so these are the ABC group of drugs that we always see. Whenever we make a regimen, we see the A group contains that levofloxacin, bedaquiline, and linezolid, while the B group contains clofazimine, cycloserine. So these 5 drugs, these are the first line drugs. And usually, if there is no resistance, we give the 5 drugs in the regimen. If it is 5-drug regimen is not made, then we take the C group and take from that 1 or 2 drugs and make the regimen as per the criteria. And so this is the one shorter oral bedaquiline regimen. What is that? The criteria is that if you diagnose a case of MDR and quinolone is sensitive, quinolone must be sensitive, then we can use this 9 months treatment, because what the patient says, 18 mahina, 2 saal mein dawai nahi khaunga. So we want a regimen that is patient friendly, where we can cure just like this sensitive regimen, 6-month regimen. So 9-month regimen is one, and it is just following the this Bangladesh regimen. Bangladesh regimen just modified of this, in which injection was there. But nowadays, we give the bedaquiline for 6 months and other drugs 4 or 5 months, 6 months for the intensive phase, and then again 5 months for the continuation phase, and by 9 to 11 months we complete the regimen. The result is very good. Initial 6-month bedaquiline has been used. But this is the most commonly used drug in majority of the cases, because the quinolone resistance is very, very high. In my laboratory in the Jawaharlal Nehru Medical College, 50% of the patients were primarily resistant to quinolones, because you know the quinolones are used by us right and left in any infections, anything like that. So unless we stop that, the resistance of quinolone is bound to be high, and so that is the problem while you managing this. So these are the 18 months treatment regimen of this, in which the bedaquiline, levofloxacin, linezolid, cycloserine, and clofazimine, these are the 5 drugs that are used for 18 months, and there are electrolytes and QT interval prolongations, anemia, that is all the side effects you have to watch for. This is the wonderful regimen. This is this bedaquiline, pretomionid, linezolid regimen, that is called BPAL regimen. This regimen is, there are a lot of research are going on just now, operational research are there. This can give us result in 6 months. That is what we are opting for, BPAL regimen. And this, and you shall see the results. These are pretomionid dose, bedaquiline, linezolid are there. And 6-month bedaquiline BPAL regimen, who suggests the use of this 6-month treatment, giving these drugs. And the result is that 89% success rate. So in the usual MDR treatment, that in the older regimen used to have just the 50%. Now the BPAL regimen gives us 89% success rate. And many research are going on, results are very optimum. Failure rate and loss to follow-up are also very fewer. In January edition of this Lung India, this Dr. Udavalia from Mumbai, they gave the wish, the past is imperfect, future is brighter. That is a very good article upon this MDR regimen and this. So there are newer treatments, there are newer drugs, and one of the drugs that is this telacibam, that is also coming. There are many drugs, 16 or more drugs promising candidates are there. And if you see this phase 3 trial, delamanid, bedaquiline and pretomanid, last drug in the phase 2, telacibam, again is a very promising drug that can do our rescue and that also can give us help to our MDR patients. Is there any agent that can help us? In the adjunct vitamin D, in the morning you have seen whatever the controversy there. No, there is no supplementation, no effect upon the vitamin D in the tuberculosis. What is this dot therapy is very much talk about. Nowadays we say video observed therapy. That can be helpful in the longer therapy in that. Prevention is also there. That is a very important message that I want to give, because this is a dangerous phenomenon. That is a time bomb that our friend Richman has told us, that prevention, you always diagnose a patient of tuberculosis early, give the treatment, diagnose the MDR also in the earlier stage, and give the treatment, initial treatment. That is the best prevention that we can do. There are other scope also, surgery is also indicated very rarely, and there are prophylaxis also with the quinolones that I will not discuss now. Vaccination, again, there are many vaccinations are in offering. When you see that this TB will be eliminated in 2025, that was the question. That is the dream of our Prime Minister. How? And it was said that in 2017, a vaccine will come. 6 years has elapsed. By that we said that we shall bend this curve by 17%. 17%. Still you are going up 5%. So still this vaccine may come, or some other vaccine may come that can help us. And we have already talked about this. And we have talked about this pandemic. So with the newer regimen, with the zeal, cooperation of each one of you present in the hall, because unless each and every doctor cooperates in the early diagnosis of this, we can not end the TB. We can't have the better treatment of MDR tuberculosis. Thank you very much.
Thank you, sir. Thank you very much for this wonderful lecture. Very precise and concise treatment pattern. Only 1 or 2 questions, please.
It was a wonderful attempt from you. I'm just asking about the slit, because second line injectable drugs, they are not having any place in the this dot regime or this regime, RNTCP regime, RNTEP, whatever you call it. And secondly, this LP3, recently pretomanid and bedaquiline and linezolid. These 3 drugs were very promising, and only by 6 months treatment of this thing, that can be taken care of. And delamanid, as you told it, whether any clinical trial with that is there or not, or any report from that drug, delamanid. So
this delamanid is also, we are now using this, even the clinical trials, they are using the bedaquiline and delamanid jointly, because they both are wonderful drugs. And again, the purpose of all new researches are there to have the safe and non-toxic regimen, plus the duration is very, very important, plus the efficacy. So even that there are many regimens are there, NICS trial and other trials are there, they have combined the bedaquiline and delamanid also. Injectables, because of the pain of the injections, because of the non-compliance, we are trying to make it off. But when making the regimen, if you don't get the any adequate antibiotics or any anti-tuberculosis drugs, we can aid. Because we have to give that 5 drugs regimen for that, and if you cannot get in that first group A and group B, we can opt for the injectable, because life is very important, effective regimen is very important.
Just your opinion from you, do you agree with the NTEP program, the terminology NTEP?
Yeah.
RNTCP?
Yeah.
Going to
This
NTEP.
is now NTEP, yes.
NTEP.
Yeah.
So are you going to eradicate?
Are you?
Going to eradicate tuberculosis?
So that I have already told you that whatever initially the annual incidence of tuberculosis fall was 2 to 3%. During the COVID, it has increased 4 to 5%. So whatever gain we have got during the last 1 decade, that has been damaged. So at present now, this tubercle bacilli is still unbeatable. I hope that it is a dream that we are able to end the tuberculosis by 2020.
Sir,
Thank you, sir. Thank you very much for the wonderful lecture.
just a question, sir. In Man Ki Baat, our Prime Minister talked of a 3 months regime of anti-TB drugs. So can you highlight on that 3 months regime?
So the research are going on. Yes, we want that.
What drugs,
Why,
what
why to
combination?
6 months? Why not to 3 months? But we, as of now, we can't say that the drugs or combination will come and that will have the effective regimen. Not now. Not now.
Thank you. Can we move ahead?
Thank you. Yeah,
Thank you, sir.
thank you very much, sir. For the next talk, I would like to invite Dr. Sanjeev Medhi from Guwahati. He will be speaking on management of severe anemia and heart failure. Both individually, anemia and heart failure are difficult to manage, but when they are combined, let us see what Dr. Medhi has in his armatorium to tackle the issue. Dr. Medhi, please.
Good afternoon, everyone. Respected chairpersons, learned audience, faculties present over here. My special thanks to the organizer, especially Dr. Virbani, for giving me this podium and to share some important thoughts on this topic today. I come from the land of Kamakhya, the blessed land of Kamakhya, and you all are welcome over there. It's a very renowned temple. Many of you must have gone there. After listening to very complicated topics, the previous two, I must say, my topic is little simple but very pertinent because it deals with anemia in heart failure. Appears simple but very important, especially for the patients who are really in need of it. We all know the important role of iron in the physiology of the body. It's a very essential micronutrient which is required by the mitochondria, starting from for the energy production as well as for the synthesis of hemoglobin. And iron deficiency is very prevalent. It is prevalent to a tune of almost 50 to 70 to 80%, but we always miss it. And by doing two very simple tests, the total serum iron and the serum ferritin, we can diagnose the situation. We will just keep it in mind that this problem can coexist in a particular patient, and it is very simple to treat also. So this slide carries a lot of weight, as apart from smoking, dyslipidemia, diabetes and hypertension, anemia is nowadays considered as the 5th major treatable cardiovascular risk factor. Mind the word treatable, means we can treat it. You can't, to treat, as compared to the other risk factors, to treat anemia is far easier. So it's a very important treatable 5th major cardiovascular risk factor which contributes to the morbidity and mortality of a cardiac patient. So it's very important. And as I've already told, that iron deficiency can be present independent of anemia. The person, if you see simple hemoglobin, it may be normal, but he may be having iron deficiency anemia. That is the importance of it. And the prevalence, as I've told, in chronic heart failure it is to the tune of 50%, and in acute heart failure to the tune of almost 80%. So quite prevalent. And the causes of iron deficiency is multifactorial. I'll be discussing it. And once there's iron deficiency anemia, it impairs the functional capacity of the person, it precipitates circulatory decompensation, promotes skeletal muscle dysfunction, and associated with sterility irrespective of the anemia, of the cause of anemia. So anemia needs to be given some weightage and needs to be treated with the right earnest. Here it can be seen from this slide that iron deficiency affects, if you see the person as a whole, it affects the exercise capacity, it decreases the quality of life, it increases mortality, and increases hospitalization for heart failure. If you come to the organ specific, anemia can give rise to cardiomegaly, there can be cardiac hypertrophy, remodeling, systolic and diastolic dysfunction. If you come on to the cellular aspect, if you see the cardiomyocytes, there can be hypertrophy, there is cardiac remodeling, apoptosis, ventricular dilatation, and all this can happen. And if you come to the subcellular aspect, you see the mitochondria. The basic mitochondria we all know is the powerhouse of the cell, and it affects the ATP production. Iron deficiency can affect the ATP production, and also it affects the heme synthesis or the hemoglobin synthesis in the body. So once the person is having anemia, it can affect each and every structure of the body from the person to the subcellular level. So anemia is very important if you really need to bring down the mortality and morbidity associated with any cardiac disease. Now, how do we define anemia? In men, it is below 13, and in women, non-pregnant, below 12. So marks are quite high, which we all must be thinking that it must be in the range of below 10 or 11. No, it is below 13 and below 12 in non-pregnant women. And 30% of stable ambulatory patients and 50% of patients with acute decompensated heart failure have been found to have this condition, and it is prevalent in both heart failure with reduced ejection fraction as well as heart failure with preserved ejection fraction. Both are having this problem. And we all know the outcomes which can be associated with it. So anemia can be multifactorial. It can be because of iron deficiency, it can be because of vitamin B12 or folate deficiency, neurohormonal or the inflammatory markers, and renal dysfunction. So multifactorial causes of anemia can be there, but iron deficiency is one of the most important cause of anemia in any situation. This is a very busy slide, but very important. Some amount of physiology has been discussed over here. And if you see this slide, the most important is this, the last one over here, which is with cytokines. Means once the person is having heart failure, the cytokines level increases. That is interferon alpha, tumor necrosis factor, interleukin 6, they all increases, and they give rise to the chronic inflammatory state in the body. And once there's chronic inflammatory state, hepcidin is synthesized by the liver. This hepcidin is the block. Means once hepcidin is secreted, iron transportation as well as iron absorption is blocked in the gut. And then there is functional iron deficiency occurs. The person's iron store may be normal, but he is having a functional iron deficiency. So in chronic heart failure, most important cause is these cytokine factors which are there, giving rise to an inflammatory state. Apart from the other factors are there, which needs no, because we all know that in heart failure, fluid retention can be there, which can give rise to hemodilution, and also once the heart failure is there, anorexia will be there, more of GI bleed, and less absorption of iron can be there, plus the renin-angiotensin system is of course there, and the blood flow to the kidneys are hampered, giving rise to reduced erythropoiesis. So in a nutshell, there can be hemodynamic and non-hemodynamic factors, consequence of anemia. The non-hemodynamic, there is increase in the 2,3-diphosphoglucurase, which gives rise to increased release of oxygen from the red blood cells. There can be renal hypoxia, giving us to increase erythropoietin production. This is the body's mechanism, how to overcome it. And then there is this hemodynamic compensatory mechanism, which is again very important. Because once anemia is there, there is systemic, the sympathetic tone of the body is increased, giving rise to increased heart rate, increased systemic vascular resistance, giving rise to this activation of the baroreceptors and the RAS system, and ultimately the LV remodeling and heart failure will be there. So one is, as I've already told, one is absolute iron deficiency and one is functional iron deficiency. In absolute iron deficiency, we all know that our body's iron store is less. There will be less than 100, serum ferritin will be less than 100, and transferrin saturation will be below 20. But if there is functional iron deficiency, the iron store will be high. It can be in the tune of 100 to 300, plus this transferrin saturation also will be high, above 40. So by doing these two simple tests, we can find out whether the person is having a absolute iron deficiency or a functional iron deficiency. And the causes of iron deficiency in chronic heart failure has been highlighted, we all know it. Aspirin and angiotensin receptor, ARB blockers which we are using also has been highlighted as one of the most important cause for anemia in this class of patients. So this slide tells us that the iron store can be depleted, but the person may not be having anemia, and we can be foxed by it. So we have to keep it in mind that in spite of having a normal hemoglobin, he may be having an iron deficiency anemia. Now, iron deficiency remained an independent predictor of mortality in anemic and non-anemic patients. This has been highlighted in this slide, that whether there is anemia, whether there is the mortality rate always increases with anemia, and whether there is no iron deficiency or iron deficiency, means whatever anemia is there, mortality is bound to increase. And also it has been highlighted also over in this slide where anemia is associated with increased mortality, both CV as well as non-CV death. Now, how do we manage these patients? This is the 2021 ESC guideline, which recommends that all patients with heart failure should be periodically screened for anemia and iron deficiency with full blood count, serum ferritin concentration, and transferrin saturation. That is a class 1 indication. And also they say that intravenous iron supplementation with ferric carboxymaltose should be considered in symptomatic patients with ejection fraction below 45 and iron deficiency defined as ferritin below 100 and transferrin saturation below 20. And this is level 2A indication, and they also say that iron intravenous supplementation with ferric carboxymaltose should be considered in symptomatic heart failure patients hospitalized for heart failure with ejection fraction below 50 and iron deficiency. So once you are coming across a patient who is in heart failure and who has got ejection fraction below 50 and 45, always check his iron status by doing the serum ferritin level and the transferrin saturation. If these two are abnormal, this person should be given an iron injectable therapy because it is associated with lesser mortality, as has been highlighted in my next slides. So this is also a busy slide. I'll just go into a few important aspects of it. If there is acute anemia, we all know that we need to give a judicious packed red blood cells and injection Lasix can be added. If there is chronic anemia, but the anemia is very severe, below 7 to 8 hemoglobin, then of course packed blood cell needs to be given. And if the anemia is not that severe, we must always check the serum ferritin and transferrin saturation. If it is below 100 and transferrin saturation also below 20, he is having plus. If his ejection fraction is below 45, he needs to be given an iron infusion. Whereas in preserved ejection fraction, there is no data as of now. Studies are going on, so they have remained silent on this aspect. But in reduced ejection fraction below 50 to 45, the person should be given, and if he is having iron deficiency, he should be given an IV iron dose. And they are preferably carboxymaltose. This is also a very important slide. These patients should not be given oral iron because oral iron will simply not work in them. As I've already told before, that hepcidin is secreted. Hepcidin is a protein which is secreted from the liver in a chronic inflammatory state. And we all know that heart failure is a chronic inflammatory state. So hepcidin, once it is secreted, it will block the absorption of iron from the gut. So there is no point giving an oral iron therapy to patients who are in any inflammatory condition is there. Any inflammatory condition, not only heart failure, any inflammatory state if the body is in an inflammatory state and hepcidin is being secreted, oral iron is not going to work in them. So there is no point giving an oral iron therapy to these class of patients. These are some trials who support the use of, these trials have shown that they do not support the use of oral iron in patients with heart failure with reduced ejection fraction. Ferric carboxymaltose can be given either in a single dose or it can be given in 2 doses. It works wonderfully in correcting the anemia associated with heart failure. It is generally well tolerated with very low risks of hypersensitivity reaction, and the patient's quality of life and NYHA classification also improves. These are the various trials which has boosted our courage on this particular molecule, and it has been seen that after giving iron therapy, the ejection fraction of the heart also improves in 30 days. The results are quite dramatic. In 30 days, the ejection fraction starts improving. So here lies the importance of iron. Maybe the iron is also improving the myocyte function. Maybe the iron is also improving the functioning of the cardiac myocytes, because of which this cardiac contractility and ejection fraction also improves. So this is a EPHRIM acute heart failure study. This is on acute heart failure, and here also this study has shown that patients who were in acute heart failure, as I've already told before, that 80% of patients with acute heart failure may be having an iron deficiency anemia. So these trials were done on those class of patients, and the results were very, quite surprising. That 21% reduction in the primary composite endpoint of hospitalization and cardiovascular death was found. Once the person is treated with iron, the improvement was there. Only, the statistical significance relative risk reduction in hospitalization of 26% was achieved by only 1 to 2 injection of iron. Also, this is the first study which is demonstrating the benefit of iron supplementation initiated in stabilized patients hospitalized for acute heart failure. So in any patient who comes to us in acute heart failure, his iron indices must be checked. And if we are finding him to be iron deficient, he or she at a time of discharge or hospitalization should be given at least 1 to 2 injections of iron, so that the cardiac myocytes, the contractility of the heart, the hemoglobin, they all increase, and the associated with increase in the quality of life of the patient, also in the ejection fraction of the patient also increases. So what is the pros of using the intravenous iron? It can be administered in 1 or few doses, rapidly restores the iron store, lesser gastrointestinal side effects. It does not depend on patient's adherence and compliance. The cons are, it can be sometimes associated with hypersensitivity reactions, so that has to be kept in mind, and always keep the possibility of iron overload. So never give iron unless you check up his serum iron and this transfer in saturation. So these are the newer therapies in which hepcidin, they are targeting hepcidin to target so that hepcidin does not increase in inflammatory state. So newer studies, and in the future we are looking to molecules which will stabilize the hepcidin and the hypoxia inducing factors, which is also very important in chronic anemia. So in the summary, I would say that iron is a very important micronutrient which is essential for mitochondrial function and energy production of the body. Iron deficiency has deleterious effect on contractile function of the myocytes. It is not just a hemoglobin, it is, after all, it matters with the cardiac myocytes, the functioning of the myocytes, the ejection fraction, the heart failure, the quality of life, everything improves once you are giving iron. Prevalence of anemia is almost 70 to 50 to 80%, as I have told. Iron deficiency can be reversed. It's a very treatable condition, which I have already told in my first slide, that iron deficiency only has to be kept in mind, and it's a very treatable condition which affects the mortality of the patient. And intravenous iron supplementation should be considered in symptomatic heart failure patients recently hospitalized for heart failure with less ejection fraction. So thank you everyone for giving me a patient hearing.
Thank you, Dr. Mehdi, for a very wonderful and exhaustive talk. And there are one or few questions or comments from the audience. Yeah.
Yeah, Dr. Mahmood.
Thank you, Dr. Mehdi. Simple question, how safe are these injections to be given in a non-hospital setting?
See, you can always do a blood skin sensitivity test. And these newer iron preparations, we have the older irons, which was very prone for hypersensitivity reaction. But then came the iron sucrose. The iron sucrose was better in that aspect. And now this iron ferric carboxymaltose. You can, what they say, but we don't practice it. You can even give it by IV, what they are saying. But I always say that better be careful, do a hypersensitivity test, let's go slow, and always try to give it mixed with saline.
In heart failure
Tell you, there a case happened in one of the nursing homes where IV iron was being given and the patient went into severe anaphylaxis, and she had to be rushed to TMH for ventilatory support. So it's a bit difficult job.
Yeah, that has to be kept in mind, sir. That has to be kept in mind.
In heart failure patient, it is the anemia of chronic disease or it is iron deficiency anemia? Because the only differentiating point between the two is
Sir, you are not clear, sir. Can you repeat the question?
In heart failure patients, generally it is the anemia of chronic disease. So only differentiating point between the iron deficiency anemia and anemia of chronic disease is total iron binding capacity.
Yes.
Yeah.
So as I've told, in heart failure, mainly it is anemia of chronic disease.
Yeah.
But in anemia of chronic disease also can be treated by giving IV iron because it overcomes the hepcidin block. And if the iron indices are between not exact low, say between 100 to 300, then also this IV iron can be given to this class of
ferritin
patients.
is the acute phase reactant. So ferritin can increase in case of any inflammatory process, the ferritin can rise.
Yes, sir, that possibility is always there.
Yeah.
That possibility is
So
always there.
total iron binding capacity should be done in
Yes, sir.
Continuing from previous speakers, how safe is IV iron in pregnant patients? Because
Pregnant
there have been reports of fetal deaths by giving IV iron in certain cases.
So that a gynae doctor can say better. But what I think that we are prescribing iron to pregnant lady. In fact, in hospital setting nowadays, once the person is having severe anemia, he is given a bolus dose of iron, again called after a few days, again given the next dose of iron. But apart from that, I am not aware in pregnancy exactly
But
what
there have
happens.
been reports of few fetal deaths.
Okay, sir.
Yes.
That I am not aware.
Okay. Thank you very much.
Thank you, sir, and I'm sure all of you would agree that sir deserves a loud round of applause and one more clapping for all the speakers. Thank you. May I request all the speakers to please come on the dais? Dr. Ujjwal, Dr. D.P. Singh, sir, and may I request the chairpersons to please hand over the mementos. Can you please give the mementos? So the first memento would go to Dr. Ujjwal Roy from Dr. K. Chandra sir. Dr. Ujjwal Roy. मैडम आप लोग भी आगे आ जाइए join them. Thank you. Memento for Dr. D.P. Singh, sir, from Dr. Sharma. Thank you, Dr. Ujjwal. Doctor, you will have to come here, join me, please. And next memento from Dr. Purvi Chawla to our speaker, Dr. Sanjeev Mehdi. Now I would request all the speakers to hand over the mementos to the chairpersons. Okay. So the first from Dr. Ujjwal to Dr. K. Chandra sir. थोड़ा देख लीजिए. Dr. DP Singh sirs to Dr. Sharma, Govind Sharma. भाई तालियां बजनी चाहिए चेयरपर्सन्स के लिए. Thank you, Dr. Nivedita. And to our madam, Dr. Purvi Chawla, mementos from Dr. Mehdi. Thank you so much. Before we move on to another important session, Dr. B. Prasad oration, there is an important announcement. All the participants, please collect your participating certificate from the registration counter. I repeat, all the delegates, please collect your certificates from the registration counter, which is outside. Okay, moving ahead. May I request the chairperson for this session, Dr. J.K. Mitra sir and Dr. S.K. Paul, both from Ranchi, to please come on the dais. A very important Professor Dr. B. Prasad oration to be delivered by none other than very senior Dr. Kamlesh Tiwari sir. Please come on the dais. Dr. Mitra sir and Dr. Paul sir, I think you will have to first do the felicitation. Dr. Mitra sir, felicitation of sir. So chairpersons, all yours. Thank you. Slides.
May I have the slides, please? So now we are going to have the most prestigious oration, which was started right from the very beginning, right from the first Japicon. We are having Professor B. Prasad oration. Professor B. Prasad oration. We think in this hall, everybody knows about Professor B. Prasad. He was the teacher of the teachers and master of the masters, you can say this. And उनके बारे में कुछ बोलना सूरज को दीपक दिखाने के बराबर है. He was a stalwart, he was the so our tribute and sadar naman to the legend. And can I hear the biodata? This is given, and the photograph also, please. Yeah, right. So इनको हमारा सादर नमन और श्रद्धांजलि. This is just a tribute to our legend professor, Professor B. Prasad, and this prestigious oration is being given by our Professor Dr. Kamlesh Tiwari, the past president. So the biodata can I have? Biodata is simple. Slide I have already given. Yeah, next please. Right. So he was born on 7 January 1925 at Buxar. He was second in line among 6 brothers and 3 sisters. In 1939, he passed matriculation examination in first division, admitted to Science College, Patna. 1941, he passed intermediate science in first division, admitted to Prince of Wales Medical College, Patna. 1947 secured MBBS degree, second position in the university with physiology, pathology, midwifery, and ophthalmology honors. appointed to service without doing house job due to brilliant record. As he was having very brilliant record, no need of doing house job at the time, and he was directly appointed as a medical service. First appointment as personal physician to the then Chief Minister of Bihar, Sri S.K. Singh. Appointed as second medical officer at Muzaffarpur Sadar Hospital. 1948, appointed as demonstrator in Department of Pathology, Prince of Wales Medical College, Patna. So he started his career from pathology, because pathology and medicine, as you know, very correlated, both the things are there. Then, in 1950, he set off for England on 7 September, secured his MRCP degree in a few months' time. And as the time was there, he did DTMH also from London in 1952. Returned back to India, appointed tutor in the Department of Medicine at Darbhanga Medical College and Hospital, Darbhanga. In 1954, got his MD degree from DMCH, Darbhanga, in first batch, promoted as lecturer, Department of Medicine. In 1962, when the medical college just started the Ranchi, he was the first HOD of medicine at the time and joined Rajendra Medical College and Hospital Ranchi as founder professor of medicine. In 1967, appointed as a member of the Senate, Ranchi University, Ranchi. 1969, conferred the degree of FRCP. In 1970, conferred the degree of FCCP. 1981, elected president of the Indian Medical Association, Ranchi branch. 1981, 12 September. So that was the black day, you can see in the medical history. And there, on that day, he suffered a massive heart attack at 3 p.m., taken to the intensive cardiac care unit on 13 September. On 15 September, 1981, he breathed his last at 6:45 p.m. He leaves behind a widow and 7 children. And I'm very sorry to say that our friend, my junior, the HOD, previous HOD of medicine, while he was in service, his son, Dr. Umesh Prasad, he expired on 14th of August in 2021. So, to present him as a oration, this is just our Shraddhanjali to him, and Dr. Kamlesh Tiwari will be presented.
Thank you very much, Jivan. I have got the proud privilege to introduce Dr. Kamlesh Tiwari, professor, ex-professor, who does not need any introduction, but it is customary to give an introduction. So he was the past president of API. He was the ex-professor and HOD of Muzaffarpur College, and now presently is the organizing secretary of 2026 Japicon in Patna. So thank you very much, sir. Thank you.
Thank you, chairpersons, for giving a good introduction of Dr. Professor B. Prasad. We called him Parmeshwar Babu. Things which you have already said is less for him. He was more than that. There is a proverb in villages that Suraj ko Deepak dikhana. That is like that. We can't say anything more than this. Parmeshwar Babu was very intelligent. He was my teacher. I started learning medicine from him because we both were in Rajendra Medical College, Ranchi. This was his alma mater as well as this was his first appointment as professor and head, and this was my alma mater. And he is sitting with us in a group photograph in my batch. So I must pay tribute to my professor, Dr. Parmeshwar Prasad, in this meeting. And his 2 sons, one was Suresh, who was my friend, who was head of department in MGM Medical College, Jamshedpur, and I was in SK Medical College, Muzaffarpur, so we were close friends. And second son, Umesh, who was head of department of medicine at Rajendra Medical College, Ranchi, died unfortunately, as you have learned already from Mitra. Now, giving his oration to me, I must thank Dr. Birmani and organizing team, because this is the real thing which they have done. Because oration should be given by his student, that is a good thing. Now, my topic is hypertensive emergencies. Well, not a difficult topic, but it is a rare topic. Hypertension is the most common modifiable risk factor for cardiovascular disease. Most common indication for adults to visit a physician. Its prevalence will continue to increase both among the young because increasing obesity and among old people due to increasing age. It is going automatic. It is going automatic. Now, before hypertensive emergency, there is one word, hypertensive crisis. So it is a more generalized form, not defined by a specific blood pressure reading. Rather than it is a clinical syndrome that is associated with acute elevation of blood pressure, usually 180 by 120 or more than that. And it includes hypertensive emergency as well as hypertensive urgency. Epidemiology, approximately 1% of hypertensive patients may develop hypertensive crisis during their lifetime. Annual incidence of hypertensive emergency being 1 to 2 per lakhs. High rates have been reported in African Indians, low social economic group, and in developing countries, and it is 2 times more common in male than females. This is the prevalence of hypertensive crisis, urgency and emergency seen during 12-month study in which hypertensive crisis was 27.5, urgency was 20.8, and emergency was 6.4%. So emergency is very, very less. Now, what is hypertensive emergency? It is characterized by severe increase in systolic or diastolic blood pressure associated with signs and symptoms of acute end organ damage. So that is must. Acute end organ damage is must in this condition. No blood pressure threshold for diagnosis. Usually systolic is more than 180 to 20. Diastolic is more than 220 to 130. And MAP is more than 180 millimeter of mercury. It requires an immediate BP reduction in a few minutes to few hours, and requires an ICU setup for treatment, and requires IV drug as a continuous infusion to the patient. So these are the criteria for hypertensive emergency. MAP you already know, it is very simple. 2 diastolic plus systolic divided by 3, that is MAP. Now it is going to damage the organs. Which organs are susceptible in hypertensive emergency? So most important is brain, arteries, retina, kidney and heart. In brain it may be a stroke, either ischemic or hemorrhagic or hypertensive encephalopathy. In arteries may be aortic dissection or preeclampsia in the females. In retina, 2 grades of retinopathy, kidney acute renal failure and acute heart failure or myocardial infarction or ischemia. So these organs are at risk in hypertensive emergency. What is the most important cause? Most important cause is non-adherence to the antihypertensive treatments. Patients are not taking their drugs regularly. There are other causes as well, but this is the most important cause. Other causes, renovascular cause, pheochromocytoma and hyperaldosteronism, these are the causes. But patient not taking regular medication is the most common cause. Now, another word, hypertensive urgency. What is that? It is severe elevation of blood pressure, usually 180 by 120 millimeter of mercury, without symptom or sign of acute target organ damage. Adequate treatment of these conditions of BP lowering within 24 hours by administration of oral drugs. These can be treated by oral drugs only. And ICU admission is usually not required. And common examples of this hypertensive urgency are severe uncomplicated essential hypertension, severe uncomplicated secondary hypertension, postoperative hypertension, hypertension associated with severe epistaxis, drug-induced hypertension, rebound hypertension, sudden withdrawal of drugs like clonidine, cessation of prior antihypertensive therapy, and anxiety, panic disorder attacks, or severe pain can cause secondary hypertension. Now, in these two conditions, BP reduction is must, but it should not be reduced very fastly. I will come to the topic later on. As you know, eye is the most common organ which is involved in the hypertension, and if there is retinopathy in which exudates and hemorrhage is there, that is called accelerated hypertension. And if papilledema is there, that is called malignant hypertension. So these are two other hypertension which are related with retinopathy. So physicians must take ophthalmoscope with them. This practice is vanishing day by day. So I will remind you again that you must see the retina when you are seeing a patient of hypertension, because that may give clue to the organ damage then and there. Acute target organ damage in hypertension. So these are the signs and symptoms: brain in hypertension, encephalopathy, cerebral infarction, cerebral hemorrhage, and advancing retinopathy can be there. In heart, acute coronary syndrome or acute heart failure may be there. In aorta, there may be aortic dissection. In kidney, acute renal failure. In placenta, eclampsia may be there. So what is the relative frequency of end organ involvement? Actually, most commonly cerebral infarction, that is the most common thing, roughly 24.5%. And second is acute pulmonary edema, that is 22.5%. Besides that, hypertensive encephalopathy is important, acute congestive heart failure is present, and others are not that very serious, but they can also occur, like eclampsia, aortic dissection, acute myocardial infarction, and so on. So these are the percentages. We already know cessation of drugs, not taking drugs in proper time, or not taking drugs at all. These are the most common cause for hypertensive emergency or urgency. Other causes are renal, eclampsia, preeclampsia, renal, pheochromocytoma, head injury, renin-secreting tumors, and so on. Now, pathophysiology, high blood pressure ultimately leads to ischemia and target organ damage, in which the prothrombotic stage and RAS activation is there. So all these factors contribute and ultimately causing ischemia and target organ damage to the vital organs, and that is the main thing. Clinical assessment, nothing much. As we do clinical assessment in each case, we have to do here also complete history, detailed physical examination, duration and degree of pre-existing hypertension, evidence of target organ damage, details of antihypertensive therapy, compliance with medications, use of over-counter drugs, and illicit drug usage. So as usual things, symptoms we have already seen. Examination, just like an usual examination in a normal routine way, we examine the patient with all parameters for hypertension. The frequency of signs and symptoms in hypertensive crisis, urgency and emergency. There is a comparative chart here, and what we can see that epistaxis and arrhythmia is not there in case of hypertensive emergency. Other things are there in crisis as well as urgency, but these two things are not there. As I've told that retinopathy is the good indication for elevated blood pressure. So this retinopathy can be divided into 4 parts. We are forgetting these things. We are not seeing the retina in a proper way in all hypertensive patients. But hypertensive patients can develop mild narrowing of arterioles, that is copper wire appearance. In grade 2, moderate narrowing, that is copper wire with heavy nipping. Severe narrowing with silver wire changes, hemorrhage, cotton spots and hard exudates. And grade 4, that is papilledema. So if grade 3 and grade 4 is there, that is a sign of target organ damage. This is the picture, normal retina, grade 1 retinopathy, copper wire appearance, copper wire with nipping, grade 2, hemorrhage and exudates, grade 3, and papilledema, that is grade 4. Investigation, nothing new, as usual we do, blood urea electrolytes, urea nitrogen, cell count, ECG, chest X-ray, CT brain and CT chest and MRI, as we do in each and every case of heart or blood pressure. So we do the investigation in a similar manner. The most important thing is management, how we are going to manage. First thing, normalization if BP is usually not recommended. So don't bring down the BP to normal level. That is a dangerous thing. How fast and how much BP to be lowered is given prime importance. You have to decide, clinicians have to decide that how fast should we bring it down and how lower should I go. So decision, entire decision will be of clinician. But don't bring BP normal straight away. It will harm the patient. The sudden fall in BP may cause acute hypoperfusion of the vital organs and result in myocardial ischemia or infarction, hemiplegia or acute renal failure. Older patients with long-lasting hypertension and preclinical organ involvement like left ventricular hypertrophy, atherosclerosis, and arterial remodeling are at risk of these complications as the lower limit of autoregulation shifts towards right side. This is the autoregulation curve. Actually, MAP, which is between 70 to 100 or 110 is normal. But it is a straight line up to 150 to 160. So if my pressure is in between 70 and 160, the vital organs are stable. So try to keep the auto-regulatory line in the straight line. I mean in between 70 to 140 or 60 millimeter of MAP. Don't bring it down because it will cause hypoperfusion and damage of the organ. And bring it below or near 160. So appropriate treatment in the dictated more by the features of acute syndrome and by the patient's characteristic than by a body of scientific evidence. So there is a proverb that treat the patient there, don't treat the number. Number does not matter because patient has more complications, other complications as well. So treat the patient as a whole, not only blood pressure of 200 by 120. No, that is not the thing. So what we are going to treat, hypertensive emergency, mostly 4 organs are involved, heart, CNS, kidney and arteries. So what is the guidelines for this treatment? Guideline is in hypertensive emergency, BP should almost never be rapidly lowered. So don't bring it down to normal as I have already said. Goal of 10 to 20% reduction of MAP in the first hour and then 5 to 15% further in next 23 hours usually results in acute target of 180 by 120 in first hour, then 160 to 110 in next 23 hours. So this should be the ideal goal for lowering of blood pressure. There are certain things more aggressive and rapid BP reduction required in acute pulmonary edema and aortic dissection. More slow for acute cerebrovascular damages with monitoring of neurological symptoms and constant infusion of intravenous agent required. No intermittent or IV bolus should be given to the patient. So give a constant infusion. So what may be the ideal drug? It should be fast-acting, should be easily titrable and rapidly reversible and safe. And unfortunately, there is no drug which fulfills the criteria of an ideal drug to treat hypertension, emergency or urgency. But there are drugs which can be given, though they are not ideal. And according to the conditions, we may give certain drugs, like in pulmonary edema, myocardial infarction, nitroglycerin, nicardipine, or nitroprusside can be given. Acute renal failure, clevidipine, phenelpam, and nicardipine can be given. So basically, there are three types of drug. One is vasodilators. In vasodilators, hydrogen, nitroglycerin and nitroprusside. These are the vasodilators which can be used to reduce the blood pressure. Calcium channel blockers can be given IV to reduce the blood pressure. And adrenergic blocking drugs like levodopa, esmol can be given to reduce the blood pressure. So these are the drugs. And here is the list which can be given in a specific condition, but it will depend upon the persons involved, because everybody actually don't get these type of patients. And person has got fixed idea about drugs. So the drug which he likes, prefers that drug mostly. I don't know what neurologist likes, what cardiologist likes, but everybody likes drug according to his choice or her choice. But I am giving the common things here. This is the common drug, nitroglycerin, used in myocardial infarction, cardiovascular diseases, and acute hypertension causing heart trouble. Give IV. It is a potent vasodilator, usually venodilator drug, and mix it in normal saline and infuse it slowly. Dose, I will leave up to you. Sodium nitroprusside is another drug which is not available nowadays most of the places, but it was used in the previous days. It has got some side effects like cyanide poisoning, and it can cause even myocardial infarction and cerebral hemorrhage as well. So this drug is not very common nowadays, but still it is there. This is clevidipine. It is third generation IV calcium channel blocker, FDA approved in 2008, potent arterial vasodilator. No effect on venous side. It works by relaxing muscles of heart and blood vessels. Cleviprex is used to treat high blood pressure in people who can't take oral medicine. Doses, I will leave. Another drug is nicardipine, that is second generation calcium channel blocker. It is also available in IV form and can be used in cardiac cases as well as neurological cases. Phenelpam is a dopamine agonist drug. It is 10 times more potent than dopamine, and it is basically useful in the renal hypertension. Short-term management of hypertension, a dopamine receptor agonist that is used as an antihypertensive agent. It lowers blood pressure through arterial vasodilatation. Levodopa, most common used drugs, alpha and beta blockers. Most of the people are used with this drug, and it is safe as well. So in cerebral pregnancy and neurological problem, labetalol is used. Similarly, esmolol, another beta blocker, that is also useful for the reduction of blood pressure. Not to use sublingual nifedipine. That is coming for a long time. Don't use sublingual nifedipine because drug is poorly soluble, not absorbed through buccal mucosa. Sudden, uncontrolled and severe reduction in BP may precipitate cerebral, renal and myocardial ischemic events. Lack of clinical documentation, testing to a benefit from use. The Cardio-Renal Advisory Committee of the FDA has concluded that the practice of administering sublingual oral nifedipine should be abandoned because this agent is not safe nor efficacious. Don't use at all. Take home message, most common cause for hypertension crisis is undiagnosed, untreated, inadequately treated hypertension. Differentiation of emergency for urgency is absence of target organ damage in the latter. Clevidipine is a new drug approved for hypertensive emergency. IV nicardipine, IV labetalol are preferred for most of the emergency situation, and sublingual oral nifedipine can't be used. Thank you. These are the dose charts which I have given. One thing more, when I was a student, I was taught that if you are going to use anti-cancer drug or any emergency drug, must read the leaflet before use it. So don't remember the dose outside. It should be seen when you are going to administer that drug. And that is a good practice. Must read the leaflet when you are going to use. Thank you. Thank you very much.
Just like Professor B. Prasad Orison. You have kept this and this. We must say that we are all three sitting here are from RIMS. And he has been, Professor B. Prasad has been our teacher. And Dr. Kamlesh Tiwari was our teacher. So, as I told, teacher of teachers. So, that was nice. Very nice of you, sir. Thank you.
Thank you, sir. And as a mark of respect for Dr. Professor B. Prasad Oration, and very nicely delivered by Dr. Kamlesh Tiwari, sir, I think we all agree that he deserves a very rightly standing ovation. As a mark of respect for Dr. Kamlesh Tiwari, sir, in respect to Dr. B. Prasad Oration. Thank you so much. May I request the chairpersons to please hand over the memento to our speaker, Dr. Kamlesh Tiwari. Thank you, sir. May I request Dr. Kamlesh Tiwari, sir, to please hand over the memento to our chairpersons, Dr. Paul and Dr. J.K. Mitra, sir. कोई भी एक दे दो ना, कोई बात नहीं, आगे पीछे हो जाएगा. To Dr. Paul, sir. Dr. S.K. Paul. Sir. हाँ. क्विज तो सर 5:30-6 होना चाहिए, थोड़ा सेशन लेट चल रहा है. नहीं लेट चल रहा है. सर हम 5 मिनट में फ़ोन करते हैं आपको. करते हैं. Okay, so thank you so much. Moving ahead to another very firing session, and this is debate 5. May I request the moderator for this session, Madam Vijaya Bharat, to please come on the dais. And the two firing speakers, Dr. Arvinda from Bangalore, please come on the dais, and our very own Dr. Virmani sir, to please come on the dais. The topic is the future of medical profession appears bleak. Dr. Arvinda is going to speak in favor and Dr. Virmani is going to speak against. Madam Vijay Bharat, to please start the proceedings. Thank you so much.
Ladies and gentlemen, you will agree with me that all the sessions have been very carefully selected and it kept us glued to our chairs and listening attentively. But the next topic, the next debate, is an existential crisis. It deals with whether the future of medical profession appears bleak or not. So to discuss this very pertinent issue in the current times, we have got two speakers, and both are star speakers, I would say. We have Dr. Arvinda Jagdisha, who has come all the way from Bengaluru, and he is going to speak in favor of that subject, the future of medical profession appears bleak. And defending the topic, speaking against that, will be our own Dr. Anil Kumar Virmani. So I'm very keen to listen to this debate. I'm all ears. Dr. Arvinda, you can take the mic now.
So good evening everybody. At the outset I thank Dr. Virmani sir for making me a part of this wonderfully organized Japicon. So he has given me a wonderful debate actually. It's an interesting debate actually. My opponent actually was different, but last moment Dr. Virmani has kindly agreed to debate against me. That is one thing is there. But I'm requesting all of you not to get biased because he is the local person. So debate is nothing much like you should enjoy the debate. There is nothing science in this. It's only a practical aspect how we discuss in a day-to-day activities. Now my first disclaimer is this does not apply to all of us, okay? It applies to the person joining medical college now. So keep that in mind and listen to my talk. So future of medical profession appears bleak. My topic is, yes, I'll be talking in favor of it. The future of medical profession is bleak. So greetings to all of you from Bangalore. So before we start, where are we? In India, we are considered as God, isn't it? Especially in last 2 to 3 years, we are all considered as God. After that, what happens? The God has become a demon in matter of second. So the God is the one thing we all be proud. Moment we say Dr. Bhagwanu, we get elated. We get elated from our side. But when you say your consultation fees is 1,000 rupees or 500 rupees, they say, Doctor Sahab, aap to Bhagwan hai, paise nahi lete. So this is the situation what we have got. So let's catch on with the journey of this Indian God without any supernatural power. So you can see in this slide, the journey starts when Indian parents say, Mera beta doctor banega. So this is where it starts. From the childhood, the parents have got, grandparents have got, their son and grandson should become a doctor. So at the time of admission, so this is what you can see on the right hand side. Dr. Virmani's grandson will be looking like that. After 6 years, why 6 years? 5 years of MBBS, then 1 year of compulsory rural posting. All over India, compulsory rural posting, that is become 6 years. Then after passing out from MBBS, look how smart he has become. He is very proud that he has become a doctor. So at the time of PG admission, once again you see, and at total 4 years. What is 4 years? 3 years for PG preparation, getting seat, 3 years. Then once again rural service. That is, the government is doing the new rules and regulation. I'm damn sure that is going to come. Then you can see here, after passing the PG, how he has become. Then, at the time of super specialty admission, is like this. Then once again, total 3 years. So it's a DM or MCH or whatever it is, he has selected his super specialty. Then finally he said, I am finished, and he will be, after passing out from super specialty, this will be the situation like this. Totally, if you calculate how many years, it will be roughly not less than 15 years. That too, if the things go smoothly, is 15 years is guaranteed. That is 12 plus is 18 years, 15 years is 33 years. 33 years, he will be proud doctor with all the quality and ready to see the patient. So meanwhile, building up your career doctors, he needs to manage. He needs to manage. What he will manage is the marriage. So in these 32 years, you'll be struggling, getting PG, super specialty and all these things. In between, somewhere he should accidentally get married. Somewhere the parents would have searched, or you would have searched, or somebody would have searched somewhere. Invariably, the doctors marries a doctor lady. So what happens? She will be doing somewhere PG. Accidentally, the children should happen. Somewhere they meet in the conference like this. At last, we got a room together. Let's have a party, and next she should become pregnant. So this is the situation. Accidentally, the children should be born. Then the family planning. So they should really plan what else they have to do. Then comes the social anxiety. With all these things, the pressure from the peers and all those things, the social anxiety comes. So how doctors' marriage is different from other professional. Marriages, you get doctors, perfectionism, compulsiveness and workaholism. He is a good doctor, but there is always a problematic spouse. Isn't it? You always want everything to be neat. The spouse may not be neat. You want to wash your hand, she may not wash your hand. She may do it perfectly, the husband may not be perfect. So many married to profession, there is no time to cultivate intimacy with the spouse. Everybody is attending every weekend over the conference. And everybody is attending the day-to-day activity. Evening practice, come home at night, 10 o'clock, have food and sleep. There is no intimacy at all. The issues threatening marriage is money and financial arrangements, infidelity, boredom, career crisis, empty nest syndrome, and retirement finally. There is no retirement actually. Coming to the son preparing for need, then what is the problem? There is always a medical fee issues problem. So if he gets a merit seats, well and good. Looking at the situation all over India regarding the reservation, getting a medical seat is not so easy. But the big question is, what next after getting in the medical school? That is a big question. So you can see here, the son in the medical college is 24 hours, he is studying. When the whole building, whole apartment light is off, his light is on because he is studying. So this is what the students in the engineering college, they are enjoying their life. What medical college does to you? Data transfer from Chaurasia, Grey's Anatomy, Harrison, what else? The data transfer goes on. The son will be struggling, thinking that he will become a famous doctor. So its use is gone. Kindly note, we have all enjoyed and we have come across that. We are lucky people. I am telling you once again, this is for the newly joining people. So love is always impossible. But we do some interesting cases wherein during MBBS time only they get love and they get married. Those people are very lucky. Very few people are there, but still they are lucky. After his prime years of youth gone, the journey doesn't end here. So next step after MBBS is NEET PG. So if he doesn't get the NEET PG, he will open MBBS Kuller Choi. So Choi is there, MBBS Kuller Choi, it is a better business than the MBBS. So after PG, if lucky doctors might get married, that is one thing. You can see on the right hand side, just two medical students getting together after finishing their academic and getting settled. This will be the situation in future. What are the sacrifices during MBBS, PG and super specialty education? Many of us not attended marriages or functions of relatives, not celebrated any festivals with family, only WhatsApp festival we do. Always surrounded by people who are not in good state of their mind or body. Coming to the income status of the doctor, doctors start earning late. So he finishes all the exams, ready to practice by 33 years. He should start his life. He doesn't end there because he is just starting. Dhoni gets retired at 38, we are starting practice at 33 years. So this is the situation is here. After PG, real struggle is clinic setup. What to do, how to set up the clinic. Dr. Virmani is a busy practitioner here. How to compete against him, how do we start this practice? This is a big headache. You can see in this slide, when one brother is an engineer, one is a lawyer, and the middle one is a doctor. This will be the situation at 33 years. After that, now we are most of you are running in Benz or BMW. This is our situation. Future situation will be not even Maruti Omni. So clinic setup. So this is the setup. You have set up, made a posh clinic, then patient is not there. So we will struggle again. A wife is asking, let us take a Innova. There is no money to take Innova. So no patients. So then what happens? At last few patient comes to you, and when you start getting patient, they don't adhere to treatment because you are a new doctor. You are looking very fresh and your advice is not going into their mind. So they spend luxury on the other items but not ready to spend on your treatment. Its funniest thing is you have been a doctor for 17 years but still you can't get your mom to trust your advice. Your family members only don't believe. You ask your seniors and tell me, why do you want to take risk? So this is what happens to most of the doctors. Finally, the son has a question. I thought medicine is all about studying for 5 years. No, son, it's 50, that is 50 years. Means it goes on, goes on. You keep on studying. Every day you keep on studying, keep on studying. So just a healthy reminder that the accessibility to doctors is in India is much easier in comparison to foreign countries. Patients don't have to go through any insurance policies, book a formal appointment, get the appointment instantly, not months later. So anybody can approach anybody immediately. It's not like US, UK, where appointment has to fix and they come see with respect and all. Yeah, tomorrow you want to get an appointment with a doctor, you will get. So employment issues in India, if you see, there are approximately 13 lakh allopathic doctors are there in India. But the question is, are they handsomely paid? No. Also, you can see that 70% of the doctors under obligation to the corporate hospital. Then comes the rules and regulation. Doctors bind by all the rules and regulation. Patient can also sue doctor easily, no rules against. Any other profession is very difficult. Only in doctor's profession, it can be sued very easily. Not to mention how doctors are controlled by politicians. All of us know how we are easily bound to them because you can see the recent condition, what happened in Rajasthan, Right to Health Act, how the things can change suddenly. You think that you are doing well and suddenly some rules and regulation, the politician wants to try to impress the public and they want to issue notice to the doctor, it's very easy. And if the doctors community fight against them, no public will not accept to it. The God will definitely become a demon because see, this doctor is money minded and he loots the people. That word will come. The doctor's expectation versus reality, what my family thinks I do, what I think I do, what society thinks I do, and what I really do. This is the situation. The people will think like that, but actually doctors are not like that. So Indian healthcare is missing out on talents not inclined to join medical profession. This is an article in 2021. Doctors' problem, struggle to attract patient, rampant prevalence of unethical malpractices because we have got so many babas around. Ramdev Baba, Somyo Baba, suddenly some Baba arises in Jamshedpur, suddenly in Bangalore, suddenly in Chennai, somewhere they come rampantly without any notices. And there is a declining social status and there is always a threat of litigation and doctors have to answer to patients, hospital trustees and even to courts. So carrying burden of expectation, doctors, what is the definition of success? Having lots of patients, new car, plot, every year, lots of money, publishing paper in journal, teaching student. This is what we think success. But facts, one of the every 3 dissatisfied due to lack of time for themselves or their families. Average life 10 years is lesser, kindly note this. Depression 4 times higher than the general population. Physician suicide is 3 times than the general population. 10% develop drug addiction as well. You can see last couple of years, this one particular rule came into the system, that is the NMC. All the doctors opposed, but still they introduced bridge course. I don't know what is the situation of the bridge course now. On the right hand side, you can see here what he says. पहले मैं जोल छाप डॉक्टर था, फिर एक दिन मौसी ने ब्रिज कोर्स के बारे में बताया. आज 6 months के बाद मैं क्वालिफाइड डॉक्टर हूँ. Thank you NMC. So this is the situation of the bridge course. Anybody can become a doctor over a period of 6 months to 1 year. In future, I am not sure what the things are going to come. So why we are against NMC? Once again, if you take the new things is next is coming up. It's not NEET anymore. Next is coming up. What is coming in the next next generation only should know. That the things are going to be very, very tough. So Rajasthan doctors call of stir. You can see the massive doctors rally. These things has to be done regularly to safeguard ourselves from the new rules and regulation. This will be the situation on and off in the future. Now another important thing is corporate hospital always sucks the doctor. If you see biggest hospital chain, they employ the doctors, they treat them like a pawn. So you give me the target, what is your, I am giving you a retention fees, why, where is the income, do investigation, do that thing, this thing, they are ruled by, they'll rule us. So corporate hospital has become a business, but don't blame us. Doctors always keep saying, so life in corporate hospital, what happens to a doctor who resists becoming a revenue generating medicine? Now the new thing is artificial intelligence in coming up, chat GPT is coming up, the patients are more cleverer, they want to have something, they want to know about diabetes, they'll ask chat GPT. Chat GPT, tell me about diabetic mellitus. Everything will come. Everything will come. In Bangalore, few of my patient comes with the printout. So this is the things. Instead of taking my advice, I have to clarify their doubts. They already know whatever the things are there. Last few slides. So why there is only, another important thing is why there is only term called medical negligence, we don't know. Why can't there be a judicial negligence, administrative negligence, political negligence, banking negligence, police negligence, nothing. Only doctors are the scapegoat. Because we are the poor people. Because we are not the vote bank for the politician. So they don't care for us. So they always tell, go get lost, do whatever we say. That is the situation we are in. So when you ask the kids to write essay, what do you want to be when you grow up? You can see, study for 10 to 15 years to be a doctor, draconian laws and act, no family life, harassment by police and politician, attacks by the patient relatives. The son will say, anybody except doctor. So this is not for us, for the future generation. Repeatedly I am telling. So doctor, see these are the problems. Administrations, patients, expectation, demands, duty hours, studies, society. So do you love medical profession? Dr. Anil Virmani will say, हम जान भी दे देंगे इसके लिए. आप क्या बात कर रहे हो? He is asking me now. But this is the true fact. You can see almost Misha is looking like our Virmani sir, isn't it? After all this, please ask yourself, isn't the future of medical profession bleak? So to all the doctors and medicos present here, dear doctors and medicos, your life does not start after getting PG seat, not after completing PG, not after joining as a consultant, not after marriage, not after earning a decent salary, not after retirement. Your life is happening now. All you have to do is pay attention to it. So thank you for your patience hearing.
Thank you very much, Dr. Arvinda, for putting your point across. I really dread the future generation of doctors to be. To speak against this motion, we've got Dr. Anil Kumar Virmani. Let us see what he has to say.
Madam Moderator, my not opponent, a very good friend, Avinda. First of all, let me thank you for making me the most powerful man in the country. You showed me as Amit Shah. Secondly, let me assure you, you have come to Jamshedpur, and Jamshedpur is renowned for its hospitality. We love and we give a lot of respect to our guests. There will be no biasment from the audience. With these few words, let me tell you one thing. The future of medical profession is bleak. My answer is no. And why it is no? First of all, I am proud to be a doctor. Today, 46 years after my entry into this profession, started my practice in 1977. I can say in this last 46 years, there was not a single day when I thought I should leave this medical profession. My friend is very farsighted. He can predict the future. But unfortunately, he is myopic. He is looking only at the present. That's the problem, Arvinda. Now, you talked about not these doctors sitting here, but the new medical professionals who are going to come. And you belong to the category. I agree with you, there are certain drawbacks. We are in turbulent waters, but that is not the end of life. Now, this is a wonderful survey that was conducted by the US with the US healthcare workers to find out what advice they would like to give to the incoming medical professionals depending on their experience. 43% were with you. Don't do it unless you have a death wish. It is a tough industry, and that alone will make it a lot more difficult to get through the tough times you face on that path. It's a business. He talked about corporate. Compassion fatigue is real. It greatly affects people who have very high empathy. Patients are becoming increasingly violent and rude. Doctors are getting beaten up. Be prepared for extremely long hours and a stressful work environment. Like they say, show me a good doctor and I'll show you a troubled wife. Your first few years are going to be trial by fire. But this was 43%, and that is not majority. 9% who are on the borderline agreed, yes, it's an extremely rewarding career for people that care about others and want to make a difference. Healthcare will not be able to save a patient. It is not a way to get rich. Work in a hospital or similar place before you decide. Working in a corporate hospital is your choice. If you want to be bound by the rules and regulations of corporate hospital, nobody stops you. It's a vital and worthwhile field, but do not enter it if you cannot handle stress, cannot think of others beyond yourself. You need to be flexible. It's going to be a very tough industry with more downs than up. But if you have a lot of self-motivation, then you'll do well. Be careful and get vaccinated. But look what the majority said. Find a way to connect with your passion. Keep patience at the focus of your practice. Follow the science. You will be happy. The opportunities for young people is immense due to technological advances. We are rapidly advancing. It's a great career if you find the specialty that works for you and found an outlet from work. Be dedicated and do not let the bumps in the road send you off course. Hang in there, protect yourself and your loved ones and do your best. No matter what happens, we will always need doctors and nurses. My dear friend, working hard for something we don't care is what leads to stress. Working hard for something we love is a passion. So if you want to enjoy the medical profession, you have to love it as a passion. And this is a wonderful story I'll talk about, the bridge on the river Choluteca. Now, Choluteca is a river in Central America, and it is notorious for hurricanes and floods. So they thought that whenever the hurricane and floods came, the whole town was devastated and there was a lot of flooding.
So they called the Japanese and said, we want to build a wonderful, very strong bridge. So the Japanese came and built a wonderful, very strong bridge. Unfortunately, and that bridge was 484 meters. Unfortunately, in October the same year, this is a true story, there was a huge hurricane. The whole town was devastated. There was a lot of flooding. But the bridge stood. Bridge was solid, it stood. The river changed its course. What does it mean? What does it tell you? My dear friend, the challenge for us is that we get focused in creating the best solution for a given problem. We forget that the problem will vanish and it will be a different problem tomorrow. Earlier we used to talk of build to last, but now it is build to adapt. We must learn to change with changing times. That is very important. So what the future holds for the medical profession? He very rightly said, technology is coming in, artificial intelligence is going to be there. We have to adapt ourselves to the changing circumstances. And let me tell you, the artificial intelligence can never replace doctors. What it will do, it will keep documentation for you, it will keep data collection for you, it will make decisions from the data for you, it will be a virtual assistant, but ultimately it will be you who will take care of the patient. Remember that AI will never replace doctors, but doctors who do not use AI will be replaced by doctors who use artificial intelligence. And there are the multiple things that are going to come. We already have a lot of them. We are using the CGM, we are using the smartphone. We are already into technology. And if you tell somebody to look at the sideways, if you ask them to align, they are not going to work. Ask them to be leaders of change. You determine the future for yourself and they will rise to the challenge. So it is important we look at technology, that we will be the leaders tomorrow to accept technology in our. It is not the strongest of species that survives, not the most intelligent, but the one most responsive to change. Medicine is more than a career, it's a love for humanity. My friend suffers from type D personality. He is worried, sad, gloomy, fear of rejection, negative self-talk, lack of self-confidence, hopelessness, getting married late, can't talk to his wife properly, all that. Don't worry. If our focus is only on the storm, we will not get beyond it. But if we focus and hope for a sunnier day, then our attitude can become one of the moving forward, getting beyond what we are now. Hold your head high, Arvinda, hold your head high. Stick out your chest, 56 inch ki chhati. You can make it. It gets dark sometimes, but morning comes. Keep hope alive. I am good enough to bring change. We doctors can shape our own future. And the example was the RTH in Rajasthan you talked about. The whole doctors were troubled because of the RTH. But look, the entire medical fraternity of Rajasthan stood as one, and government had to take back the bill. That is how we can shape our future. The whole thrust of science and the medical profession is to try and prevent it from happening, to try to prolong life, to keep you from dying, to keep you from getting older, to rejuvenate you. I mean, that's everybody's wish. The fountain of youth is everybody's sought after thing. Who doesn't want to live a healthy life? So said Woody Allen. And who can give it? जीवन से प्यार करना तो एक डॉक्टर ही सिखा सकता है. Remember, it is only a doctor who can make the patient love his life. And then let me end with a beautiful quote from the Fellowship of the Ring. All that is gold does not glitter, not all those who wander are lost. He is not lost. The old that is strong does not wither like me. Deep roots are not reached by the frost. From the ashes, a fire shall be woken. A light from the shadows shall spring. Renewed shall be blade that was broken. The crownless again shall be king. The doctors will again be God tomorrow. Thank you.
Gentlemen, both of you have spoken convincingly. When I listened to Arvinda, I was with him. I was hesitating whether I should tell my grandson to become a doctor. When I listened to Anil Vedmani, I'm with you. So you got a minute too for rebuttal.
I repeatedly said, this is not for all of us. This is for the future generation. Madam, grandson wants to become a medical student, still you should think, because see, it's not like a Shakespeare's dialogue, some words, we can't use it here. Because we all doctors get emotional with all these quotes. I'm sure if somebody is a doctor of Bhagavane, if somebody says we get emotional and your chest is high and we very become very like more confident, positive, and all those things happens. But in the future generation, the doctor, the patients are not like past generation or our generation. In the future, it will be a tough one. Dr. Virmani sir showed the data of 2021. If you have noticed that, it is a 2021 poll. Now 2 years over, post-COVID, if you take that poll, it will be exactly opposite. That was before, during COVID, you take the poll, everybody say, I am a doctor, I want to this, I am a noble profession, I am great doctor. All those things will fine. Post-COVID, once all the doctors have seen these nightmares, if you take a poll, I am sure that will be exact. See, the poll is correct. So the music is coming, doctor, you are right. So it is telling like that. And nowadays, if you see, there is too many medical colleges across India, and everywhere in any metro cities, you can, every road there is a cardiologist, every city, every street has got an nephrologist. It has become a situation like that. Yesterday, I was seeing an ad in the newspaper, DM, post-DM, the salary is 60,000. At the age of 35 years, he receives 60,000. The same person, 22 years, a computer engineer or any other profession, he'll be earning minimum 1 lakh. This is the present situation of the our profession. He tell the wife talking and all those things. At 35 years, Dr. Virmani sir, if I go and tell I am earning 60,000, forget about me talking. She'll never talk to me. Because you are getting 60,000, I thought you are a good doctor, that's why I married you, but you get just 60,000. One party you go, you will spend 20,000. How can we run the family? So this is the situation. With all due respect, thank you, Dr. Virmani sir.
Thank you, Arvinda. Time changes. When I was doing my PG, we were not paid a single paisa. Today, the residents are paid 50,000, 60,000. Tomorrow, they'll be paid much more. But you see this senior doctor sitting here. They have dedicated their life in the service of medical fraternity and service to their patients. Please do not let them down. You see those youngsters sitting in the back.
These are all our people, sir. Next generation.
I'm coming to that. You see those youngsters on that. Some of them are medical students. They are looking at you. You are an icon. I know you. You are an icon of not only Karnataka, but the whole country. People love you and respect you. They should follow you and me. And what I am saying is, my dear friend, you are young. हम तो मुसाफिर हैं, कोई सफ़र हो, हम तो गुजर जाएंगे ही, लेकिन लगाया है जो दाव हमने, वो जीत के जाएंगे.
Oh, super.
So, and you hear this clapping?
Yes.
It's not for me. They are convinced that the future is not bleak.
So debate is always a fun. I know there is a plus and minus points always. So when he gave me the topic, I thought it's a big challenge. Because whatever the things are happening, it is very tough. But it all depends. As Dr. Virmani sir said, if you have the passion, you should do it.
Thank you very much, Dr. Virmani. Both of you have done the topic very well. And as the saying goes, when the going gets tough, the tough get going. And I would like to have a show of hands from the audience. How many of you think that the future of medicine is not bleak? Yeah, there is hope. Thank you very much.
Okay.
So thank you, and for us all present here, I think both the speakers are winners. So we clap for both of them. No matter, we all agree that it won't be that bleak, and if given an opportunity, Dr. Arvinda would be very happy to make his children another doctor. All said and done, thank you so much. May I request our chairperson, madam, to please hand over the memento to both the speakers. First memento for Dr. Arvinda, all the way from Bangalore. Welcome to Jamshedpur once again. Thank you. Memento for Dr. A.K. Virmani. Thank you again. And memento from speakers to Dr. Vijaya Bharat. Thank you so much. Okay, moving ahead for another very interesting and very happening topic of this evening. May I request the chairpersons for this session, Dr. R.K. Mishra and Dr. Ram Kumar, to please come on the dais. May we have Dr. Ram Kumar here? And Dr. R.K. Mishra, sir, on the dais. And also, may I request Dr. Manoj Chawla, sir, to please come on the dais. Okay. Sir, please join. Okay. So we have got chairpersons Dr. R.K. Mishra and Dr. Ram Kumar. Speaker Dr. Manoj Chawla, all the from Mumbai. Welcome to Jamshedpur, Dr. Chawla. The topic is CGM and update. I would request the chairpersons to please take over the session.
Good afternoon. To organize, first let me thank the organizers who has given me this topic to chair this session. I know Dr. Manoj Chawla is a very good speaker. I've heard him many times in diabetic conferences and diabetic meets. In fact, we have shared the stage also many times. We'll be speaking on CGMS. CGMS is also one of my favorite topic, because you know that diabetes is no more control of fasting blood sugar or PP blood sugar. Even HbA1c, you have to have give credit or rather due attention to the fourth dimension of diabetes control, that is 24 hours control. And for that there are various devices for controlling this. One of them is this CGMS. Then we can have LibrePro or many others, so that it is not only a one-day control of blood sugar or two-day control of blood sugar. It has to be continuous blood sugar control. With this introduction, Dr. Manoj Chawla, all the way from Bangalore, he has come to speak. Mumbai. He all the way come from Mumbai to deliver his talk on CGMS and give importance why it is such important to have 24 hours regular control of blood sugar. Please.
Good evening, everyone. Thank you, Chairperson Sirs, Dr. Virmani and Japicon for having me here. After that interesting debate, I'm now going to be again showing some different quotes and different figures, and I'm going to be talking about CGM. Dr. Virmani did mention to me today that maybe CGM or continuous glucose monitoring is still not used much in this part, and hence I'm here to try and explain further why this should be used and how it shows us the nuances. So we all understand today about the limitations to HbA1c, and our chairperson introduced the topic so beautifully that we need to see the larger picture. Gone are the days that we can rely on one fasting and post-lunch from the laboratory or some few SMBG readings or just an HbA1c, because it does not tell us about excursions, it does not tell us about glycemic variability. More importantly, an HbA1c does not tell us anything about time in range, which is the new mantra or metric in diabetes management. So there has been evolution to glycemic targets. There's need to move beyond A1C. And when we say move beyond A1C, it does not mean HbA1c is not the gold standard. It still is. But you need other metrics and other monitoring tools to see the larger picture. So time in range today is believed to provide more accurate assessment of glycemic stability and hypoglycemia. The international consensus endorses the incorporation of CGM and CGM data in your standard of care for diabetes management. The guidelines provide the time in range thresholds. It also says that extrapolation of these global guidelines does not always apply to regional differences. And because we in India or in Asia are different, there is also a need for Indian guidelines, and which I will come to. What are the different continuous glucose monitoring systems that are predominantly used across the world? You have the Medtronic Guardian Connect. Medtronic was the first one that they got their CGM systems to India. You then have the Abbott systems, the Freestyle Libre, whether it is the professional blinded model or the open real-time continuous glucose monitoring model. You then have the Dexcom company CGM, and those who are interested in knowing more, Dexcom is soon launching their G1 system, which is far more affordable in India. And then you have the implantable sensors called the Eversense from a company called Sensionics, which will be marketed here by your Essentia, those who sell the Contour brand of glucose meter, in which you have a small sensor which is implanted in the arm. You have the transmitter on the top, which will continuously relay the sugars onto the app on the phone. And this is valid for 6 months. So once you put that small sensor in the arm, a little small procedure, it will make all of us into interventional diabetologists. We will finally have a procedure to do, and this will be valid for 6 months. So this led to the recent expert consensus on time in range by the group, and this was published in Diabetes Therapy a few months ago. The reason that we did this is that clearly the fact remains that the current guidelines recommend your time in range to be between 70 to 180. So for a lot of you who are hearing these concepts earlier, even if the takeaway is certain numbers, it's good enough. Like you know, HbA1c should be less than 7%. The time in range is 70 to 180, and we want our patients to be spending at least 70% of the time within the range of 70 to 180. There is a strong correlation between HbA1c and CGM, which is at 84%. Now, if you look at the ambulatory glucose profile, which is a software derivation of the CGM endpoints, and I'll show you how the AGP is derived, but an AGP report, and I want to clarify this because some confusion exists in terms of the words we use. CGM stands for continuous glucose monitoring. FGM or flash glucose monitoring is just a word used by Abbott for its continuous glucose monitoring. I again say continuous glucose monitoring can either be blinded or professional, where the patient comes to the doctor's office, you put it up, patient doesn't see it, they come back after a week or 2 weeks and you download the data. Or CGM is for personal use, patients apply it to themselves and keep seeing the sugars continuously, largely used by patients who are using insulin and of course type 1 patients. For any of these devices, including a well-done SMBG, you can actually derive the ambulatory glucose profile. So ambulatory glucose profile is a graph which is derived from a special software to make more sense of all the data that you put out there. So this is the AGP report that many of us are now seeing. You get the recommendation targets. So on the top front, you're getting how much you are in the range. So the green is the time that person is spending in range. Your yellow and orange is the one which is level 1 and level 2 hyperglycemia. That means between 180 to 250 and more than 250 is the orange one. And the two red portions below are again level 1 and level 2 hypoglycemia. What is level 1 hypoglycemia? Less than 70 but more than 54. If you are less than 54, that's more severe hypoglycemia called as level 2. And then you are seeing the AGP profile, the graph, and I will spend some time on that with the cases. But what do you want your patients to have? Your graph, you want them to have a graph which is FNIR. The F stands for we want it to be flat, we want it to be narrow, and then we want it to be predominantly within the range of 70 to 180, which would mean that the patient has very good control and less variability. And then you are also in the report seeing the individual daily graphs telling us what is happening on a day-to-day basis across a 24-hour period, how the sugars are behaving through the day. Some even say, oh, when you explain that, so this is like Holter for blood pressure. Yes, it's like Holter for blood pressure, which is for 24 or 48 hours. This is giving you a larger picture for multiple number of days. So the Indian recommendation has made certain observations and recommendations. Why? Because we have a high carbohydrate diet. There are ethnic differences in the glucose variability. There are different cultural and religious practices across India. Within India, there is geographic variation. Right? And South Asians will have an increased risk of diabetes. There is also difference between the north and the south of India and so on. Psychosocial behavior with altered dietary habits is also extremely challenging in the Indian population. And we do have a unique cluster. The newer cluster subclassification lets us know that you could be severe autoimmune diabetes, or you could be severe insulin deficient diabetes, or severe insulin resistant, or MOD or MARD as per the new classification. So let me come back and introduce the AGP, which is constructed from a model day. Now if you see on the top, each colored line is the sugar profile across 24 hours, from 12 a.m. to 12 a.m. on one particular day. In the past, when we used to do CGMs, and we would download that data, we would get these graphs on the top, which would be difficult to interpret and explain to the patient also, because they could be all over the place. To make sense of that, this special software is used, which gives you the AGP graph, which is at the bottom. And that AGP graph, this AGP graph, for us to understand that better, the center of the graph, the blue line, is what the median is. So when you start seeing an AGP, which comes from largely from the CGM, you first look at the center line, because your AGP is based on percentile. So 50% of all your sugar values, when they fall at a particular point, that is your center median line. The blue shaded portion next to it, which is called the interquartile range, has all the other data between the 25th and the 75th percentile. Still beyond that, when you look at the light shaded part, the entire range there is called the interdocile range, which means what? That your maximum importance goes to the center median line, where most of the sugar values lie, and you're able to appreciate across a 24-hour period how the sugars have behaved. But there is going to be variation on a day-to-day basis, which is where you look at the width of the graph to find out how variable the person is from a day-to-day places. The person also varies from morning to night, and that is what you are able to see in this movement from the left of the graph to the right, which is across a 24-hour period. Today, when you start seeing CGMs and AGPs and you want to help a patient, I remember Professor Tiwari's words when he spoke on the oration, and he said the blood pressure, when your blood pressure is high, please do not reduce the blood pressure rapidly. That can have consequences. And let me draw parallels to the same aspect on sugars. If you find somebody's sugars are high and the sugars are variable, the last thing you should do is try and reduce the hyperglycemia. Why do I say that? For such an individual, if I try and reduce the hyperglycemia, you will be able to appreciate that this patient also, the pointer isn't working, otherwise I would have been able to show, but if you see between the 7 and 9 a.m.s, can I have a new pointer please? Between the 7 to 9 a.m. this patient is experiencing some hypoglycemia on some days. So if I try and reduce the sugars, this patient will go further into hypoglycemia. So how do you treat a patient when you start seeing CGMs now? And it's extremely important for especially the younger physicians and diabetologists who will be using a lot more of technology that understand the principle. So the first principle is you want to reduce, thank you, you want to reduce the variability. That means the width of this is so variable, you want to reduce the variability. So you will use means of changing patient's behavior, dietary habits. That's first most important, so that you are able to reduce the patient's variability. And from that large, wide graph, you're trying to make it narrower. This is called as reduction of variability, which refers to the day-to-day variability. At one point, if this person, if I go back, you can see how wide this is. That means if I take 12 o'clock in the afternoon, patient on one day the sugars were 150, on another day the sugars were 350. I want to reduce that variability. So first aspect is to reduce the variability. I want to make the graph narrower. The second is to improve stability, which means as across the 24-hour period I am going from one level to high, then coming down, I want to try and flatten the graph. Remember the earlier mantra, FNIR. So I'm going to try and use means of reducing medications, maybe adjusting the time, etc., to try and make it more stable. Once I have reduced the variability and made the profile of sugar more stable, only then should I use means to reduce hyperglycemia, which is called as reduce the exposure. Now this, if you get it, is the new mantra of how you treat hyperglycemia and diabetes. In HbA1c, it was blind. We would again just use means of increasing medications. But you see the larger picture, see how the patient is varying, and then make the changes. Well, multiple efforts. This was the first study more than a decade back when we used the first original CGM system and showed purely by using CGM, you could bring down the HbA1c to the tune of 0.7%. There have been many such reports. This is the report between, along with Purvi and myself and many others, which spoke about gender disparity. So even now in India, there is gender disparity because of the cost of CGM. The female patients are not offered, and that's sad, and we hope that changes. Now let me show some clinical utility of the AGPs. Now these are two different patients with the same A1C of 7.2, and you can appreciate their sugar profile. If I ask all of you sitting here, which profile would you prefer for your patient? The profile on the left or the profile on the right? On the right. Both the HbA1cs are 7.2. So unless you see the larger picture, you would be lost there. Also, an important aspect of doing CGM is picking up hypoglycemia. Our conventional thinking is if patient has HbA1c of 7, 6.5, 7.3, they may have hypoglycemia. Today, we see patients with an A1c of 10%. If they are more variable, there are higher chances of hypoglycemia. And this is what you can see in somebody with a high A1c, but still having a lot of hypoglycemia in the nocturnal period. So high HbA1c, please don't assume that your patient is not having hypoglycemia, and you may be making a mistake by just increasing the dose of medication. This is the Indian consensus and recommendations where we promote the use of CGM in all with type 1 and in all those conditions even in type 2 where possible. This is the latest publication in Indian Journal of Diabetes and Technology where we've again highlighted the fact that time below range or hypoglycemia picked up through CGM is extremely common. You know, when patients, or if we did a survey and we had to ask you how many of your patients experience hypoglycemia, maybe we will say 20%, 15%. But the fact is, when you start seeing CGM randomly for your patients, you will see that more than 50% of your patients, even with high HbA1c, have some time spent in hypoglycemia, which we've been missing all these years. We can also use CGM and AGP as a tool to monitor the impact of lifestyle modification and medication. This is the same patient who did CGM at every 6 monthly intervals. In the beginning, the time in target is only 41%. You make lifestyle and therapeutic changes. Over a period of time, patient has improved to 65%, but the hypoglycemia has also increased, which is not what we want. You again make changes in the treatment, and eventually you see a profile which is flatter, 74% in target, but yet having some hypoglycemia occasionally, which we can further improve on. Again, these are the publications, and I'll skip that. Also interestingly, now this is something that we've been seeing very commonly when we are doing CGM. How many of you give the morning medication, whether it is sulfonylurea, metformin, DPP-4, insulin, SGLT2, with your patient's tea and biscuit, and how many of you give it before breakfast? How many for tea and biscuit, if I ask? Does anybody here give medication before tea and biscuit, or conventionally you say to take it before the actual breakfast? Breakfast, right? That's the conventional thinking. Now, when you start seeing CGM profiles, you realize that whether it is the early counter-regulatory release in the morning, or that we were underestimating what a cup of tea and 2 biscuits or toast or rusk, whatever we have in our culture, how much sugars can go up with that. And in most patients, we are seeing that by the time they are into the breakfast zone, their sugars are 180, 200, whereas in the morning fastings were 110, 120. Now, when you see that, so for these are similar profiles, the sugars are starting to rise by 7, 7:30. By the time patient is having breakfast at 9 o'clock, the sugars are already in the 180, 190 zone. Once you see this, you get the courage to tell the patient to take some, either part or whole of their morning medications. Even with tea and breakfast, they will not go into hypoglycemia, because that will save them the excursion before breakfast. This is an example of freestyle CGM, which our patients with type 1 diabetes use. Again, an example, and you will have a lot of patients come and ask you, those who can afford are using freestyle CGM almost continuously. Of course, in countries like UK and a lot of parts of Europe, it is given by the government, and every patient with type 1 is using a continuous CGM. Here, some of our patients who can afford it are doing that. And this is an example where the patient's profile, this is the initial profile, starts using freestyle CGM continuously, and over a period of time, we can see the improvement in the profile, though a lot more improvement is still required. There are case studies, but I'm not sure I have the time for that. If somebody can tell me how much time I have? 2 minutes. So in the end of 2 minutes, I want to rather skip the cases and leave it for another day, but I want to show you the future of what's coming. And I'm going to play a video for 2 minutes, which is going to be the latest CGM which is coming to our country. And we all get to understand this better. Can I have the volume? So friends, I'm extremely happy to share that one, I'm not contracted by anybody for today's talk, and that's my disclaimer. This introduction of the latest CGM, for the first time, even this video and the product has been shown at Japicon 2023. Nobody in India has yet had the privilege to know about this. So all of you should be happy that you are witnessing something which is going to be coming to India real soon. We are, of course, talking more about it at DTechCon next week in Delhi, but I thought I'll take the privilege of showing it here. So let me conclude, Chairperson Sir, by saying time in range through CGM has multiple utility and practical applications. It does simplify life for our patients, increase patients' understanding about their own diabetes when they see the picture. It makes the patient feel more involved and increases their onus in their own care. It, of course, helps reduce HbA1c and reduce the complications and manage the diabetes better. And it helps us reach more targeted, allows us to give them a more targeted treatment option. I can't imagine how we were doing things in the blind days, but today we need to open the eyes. So CGM should be the standard of care for all with type 1 and most, if not all, with type 2. Yes, affordability is an issue. It was an issue with HbA1c in the past. It was also an issue with SMBG a decade and a half back. The more we use, the technology gets more and more affordable. The discrete CGM metrics and AGP should be available more commonly, reducing the work and time spent accessing data. So when the first time I have shown, a lot of you have seen this the first time, may think this is too complicated, this is too hi-fi. It's not. It's the same emotion we went through when we saw an ECG for the first time. You learn it. Today, most of you will not take 20 seconds or 10 seconds to interpret an ECG. That's where I am with the CGM. Very soon, that's where all of you will be while seeing an AGP and a CGM data. So thank you so much for having me here, and would like to welcome most of you to attend the Technology Congress, though I'm again extremely happy and proud as the scientific chair to say that we are overwhelmed with the response and probably closing the registrations for this year's Diabetes Technology Congress, but we also invite you to 3rd to 5th May, Cochin 2024 for the next one. Thank you for having me here, sir.
Thank you. You have given a very good insight of diabetic technology and particularly CGMS. CGMS is definitely important in the sense that you'll agree that we have the highest number of diabetic patients in the world. It may not be useful to all the patients because of the various regions, but even then, some of the very large number of patients, this technology can be applied and it can be used further for the betterment of the diabetic treatment. For that, I am with you that really the CGMS and particularly the glycemic variability part is extremely important for controlling the various complications of diabetes, but not only type 1, but type 2 as well. Because so far as I know, particularly in diabetic neuropathy, in heart cases, diabetic cardiomyopathy patients, it has lot of benefits. Otherwise, patient will not be, they will die suddenly or death in bed syndrome, something like that.
True.
I think Dr. Ramkumar.
Sir, thank you for such a nice deliberations. I think the most important thing you discussed about the variability issues, the issues of stability, following that correction of hyperglycemia. So this is a lesson to be learned to all of us to manage, and whenever it is indicated with then this device should be applied, and it will give a wonderful results to the patients. So thank you, sir.
Thank you.
Any question if there?
Because of the problem of battery of the sensor. What is the status in our country?
So that's true. And I'll repeat, Dr. Virmani said there was a warning in between that the flash sensors have a battery inside. And there were reports of some of those lithium batteries malfunctioning or the fear of a explosion of fire. And as a result, till the stock was not re-verified and validated, they had asked to hold. As a result, even in India, last 1 month, we had very poor availability of the Libre Pro. This was an issue with Libre Pro, which we use here more in India and not the Libre Freestyle. Fortunately, that inspection by the FDA was passed because all of this is made probably in their San Diego plant. And now the new stock 4 days back has come back into the Indian market. So you're well informed that there was this concern. And this is extremely true, sir. As technology comes in, devices, sensors, monitors, all of us need to be vigilant also. Probably in terms of pharmacovigilance, I don't know how good we have been over the years. But this is a term that I learned from Purvi, that mechnovigilance, which is being vigilant when you're using sensors, devices, other things, is extremely important. Something that even the government is not yet pursuing. It's an open market, people are getting their devices. We need to know about the strengths, and we also need to be aware as physicians about the limitations of each of these products to be able to offer the best to our patients. So mechnovigilance is another new word that I'm leaving you, all of you, with today. Thanks.
Manoj, what's the difference between the Medtronic real-time and the one coming up?
So good. What Arvinda's question is good. So we have two basic times of real-time, Arvinda. One in Medtronic, when you use it, you're using where you still have to do the calibration. So Medtronic has still not been able to overcome the need to do finger stick calibration. So Medtronic one requires calibration, and it will then transfer the data from there to the phone. The new one is actually a mix between how the Abbott CGM works and how the Medtronic works. The problem with the Abbott one is it is still called as intermittent flash glucose monitoring because it still requires you to scan. This one will directly transfer. There is no loss of data. So, so many times we see our patients are not scanning enough and they are losing the data. The GlucoRx does not require calibration, unlike Medtronic, but at the same time does not require flashing and will directly be transferring data to the smartphone. So you don't require separate scanner, you don't lose data, you're not doing that, and it's working for 14 days.
Sir, I have just got one query. In reference to CGM, we have heard reports that the reading varies from fingers. Your comment, please.
Yes, so let's understand that CGM gives us interstitial fluid glucose. Your finger stick is giving you your plasma glucose, your whole blood glucose, capillary blood glucose. Sorry. There is a lag period between the interstitial glucose and your capillary blood glucose. This lag period is about 10 to 15 minutes. So that is where you will find a difference, especially soon after having a meal. When the sugars are rising or rapidly coming down, you will see a difference. Having said that, so I repeat myself, after having a meal, when the sugars are rising rapidly, or after 2 hours when the sugars are coming down, you will see this difference to be more predominant. But at most other times, the difference will not be much less than 10%, and that is what is called as MARD value. MARD is a value which is used for all diagnostic tools, whether it is SMBG or your point of care for HbA1c or your CGM. All the new CGMs have a MARD of less than 10%. So the mean of variability is less than 10%. But yes, the FDA still says that if you're seeing hypoglycemia and you do not have symptoms, it's at the end of the day technology which can falter. It's better to verify with a glucose meter or an SMBG reading only if there is a mismatch. But this new sensors, as compared to before when they came 3-4 years back, have much improved in their accuracy and stability. Right?
Just a comment. I think just to look at the benefit of this technology, like when we do a SMBG or a glucometric reading, it's like the photo where like Manoj showed, they're always smiling. But CGMS AGP is a video of what is happening over a period of time, maybe 2 weeks till. So in between those two smiles, there could be a lot of grimaces and wincing or whatever. So that could be the difference in the Alcor trial and the VADT trial, where intensive glycemic control had more problems.
Absolutely right, and
So if
well
we had
said.
CGMS, we
It
would have
be.
known what
So
exactly
I think that's
would have
beautifully
transpired.
put, Manohar, and I'll use it next time. We all know what
Patented.
happened with Accord. Till Accord, we thought lower the better. Patients were being put till 6% with multiple drugs, and we know one of the reasons there was hypoglycemia and cardiac arrhythmias as cause of that. So probably if there was real-time CGM at that time, this would not have happened. True, right? Thank you. Thank you, sir.
Thank you, sir.
Sir, please. Thank you. Again, put your hands together and loud round of applause for the speaker and the chairpersons. Very interesting. May I request the chairpersons to hand over the memento to our speaker, Dr. Chawla. Ramkumar, ले लीजिए वहाँ से लीजिए. Let the speaker come in the center. आप इधर आ जाइए एक. Okay. That looks better. Thank you. May I now request our speaker, Dr. Chawla, to please hand over memento to both the speakers. So the first memento for Dr. R.K. Mishra. And next to Dr. Ram Kumar. Thank you, sir. Well, moving ahead to the last session of today before the quiz, medical quiz. May I request the chairperson, very dear and very dynamic and very happening, Dr. Ajay Kumar from Patna. We have got two speakers, Dr. Anil Samaria from Ajmer and Dr. K. Manohar from Bangalore to please come on the dais. And it is again debate number 6. The topic is, does timing of medication really matter? Dr. Anil would be speaking in favor and Dr. Manohar would be speaking against. Moderator, sir, Dr. Ajay Kumar, keep the ball rolling. Thank you.
Ladies and gentlemen, the topic is known. The rules of the debate are known. Time is running out. We are 1 hour late. So without much ado, the timing of medication is important or not. It's basically a science called chronomedicine. And today we are going to learn the importance of chronomedicine. All of us as medical students know that the entire human physiology has a circadian rhythm. Most of our hormonal productions are going through circadian rhythm. Our everyday activity goes through a circadian rhythm. But how important is the timing of medication will be dealt with by very eminent speakers. First, Dr. Anil Samaria from Ajmer in favor. He is going to tell you that indeed timing of medication really matters. Over to Dr. Samaria.
Thank you, Dr. Ajay. First of all, I thank you, Dr. Anil Virmani, sir, to invite me as a faculty. And thank you, Japicon 23. As the topic is, there is a non-actual and potent conflict of interest. Does timing of the medication really matters? Yes. As we know, the time is very important. Dr. Manoj says the time with range is a very important part. Similarly, time of every medicine is important in our day-to-day practice, also for the patient and doctor also. So, just like the certain prescriptions should be taken with food or with a full glass of water for the best results, the timing also matters when it comes to taking your daily medications. The best time is to take the medicines may vary depending on the drugs. Also, diseases also matters. In some cases, the time of the day patient take his or her medicine can help patient to have the maximum benefits with the least side effects. The CDC showed that 50% of disease treatment failure with the not taking medicine on time. The taking medicine on time as prescribed is essential to making sure body has an effective amount of drug all the time. If not, This can cause the disease to develop a resistance to medicine or prolong the time it takes to cure the disease. The medication adherence. How well a person follows the doctor and pharmacist's instruction about when or how to take medicine. This might include the medication timing. This improves the medicine efficacy, least side effects, and the patient feels better. Now, Dr. Ajay says the circadian rhythm is important part of this chronotherapy. The circadian is go over the 24 hours. There is an oscillation in biological, physiological, behavioral function of an organism within a periodicity of 24 hours. The circadian rhythm are particularly important in medicine. With the circadian clock in the brain coordinate with daily physiological cycle like sleep and waking, the digestion, temperature and hormones show the various circadian rhythms. The physiological day is about 24 hours and biological clock is always reset daily depending on the environmental factor, day and night, and social schedules of a person. Here is a table showing the various hormones and daily biological products that show the circadian rhythms like gastric acid secretion, white blood cell counts, calcitonin gene-related protein, atrial natriuretic peptides, peaks at the late night or early during the sleep. Similarly, the growth hormone, thyroid-stimulating hormone, melatonin, prolactin, FSH, ACTH, all peaks during the sleep. Cortisol, renin, angiotensin, vascular resistance, platelet aggregation, blood viscosity show the peaks during the morning hours, and the hemoglobin and insulin peaks at the noon. The triglyceride and cholesterol and urinary diuresis are more during the evening hours. Similarly, the disease also shows the circadian rhythms. The peptic ulcer exacerbation are seen in the night times, congestive heart failure, apnea in the middle of the night, premenstrual angina, asthma in the early morning hours. Epilepsy seizures are more common in the day and night activities. Here the migraine, allergic and infectious rhinitis, rheumatoid arthritis, also the early morning eye rising show the maximum worsening effect in the early morning. Angina, acute myocardial infarction, sudden cardiac death, hemorrhagic and thrombotic storm more common after 1 or 2 from the rising period. Sickle cell crisis and hemorrhagic and perforated peptic ulcer crisis are more in the afternoon. And the osteoarthritis, dermatosis, chronic pains are more common in the evening hours. This is chronokinetics, deals with the study of temporal change in the pharmacokinetic parameters of absorption, distribution, metabolism, and excretion of drug due to changes in the time of administration. Why study of chronopharmacokinetics are needed? Pharmacokinetics and pharmacodynamic vary with the time. Gastric motility is double in the daytime than in the night. Plasma protein concentration are higher in the day than in the night. Hepatic blood flow has been shown to be greatest at morning hours, and while hepatic metabolism are reduced in the night times. Some symptoms of the disease are circadian phase dependent like nocturnal asthma, angina pectoris, myocardial infarctions, ulcer disease, all show the various circadian rhythm symptoms. Drug toxicity can be avoided and minimized by the administering at a particular time. Now, pharmacokinetics of the absorption show that it depends on the pH, gastric emptying, the motility, and gastric intestinal blood flow. Lipophilic drugs are better absorbed in the morning hours as compared to faster gastric emptying or higher GI perfusion in the morning. Similarly, valproic acid, indomethacin, ketoprofen are better absorbed in the early hours, while the skin penetration are more in the afternoon because the blood flow in the skin is more. The lidocaine and prilocaine is better in the evening. Now, pharmacokinetics of distribution. The blood flow depends on several regulatory factors, including sympathetic and parasympathetic systems, whose activities are known to be circadian time dependent, with a prominent diurnal effect of the sympathetic activity. A diurnal increase or nocturnal decrease of blood flow and local tissue blood flow may explain a possible difference in drug distribution depending on dosing time. Plasma concentration of a albumin alpha-1 glycoprotein is a circadian dependent and show the peak around the noon. Therefore, drug beyond to the plasma protein like bound to the plasma proteins like valproic acid, carbamazepine, diazepam, prednisolone, All show the increase in the free fraction in the night times. Chronopharmacokinetic of metabolism. It depends on liver enzymes, activity and blood flow of the liver hepatic blood flow. High extraction ratio of metabolism depend on the blood flow. Low extraction ratio of metabolism depend on the enzymatic activity. Hepatic flow high in the morning hours, metabolism reduces in the night. The chronopharmacokinetic of elimination. The renal physiological functions such as glomerular filtration, renal blood flow, urinary pH, renal tubular absorption show a circadian time dependent difference with the higher values during the daytimes. Some drugs showing the pharmacokinetics or chronokinetics, they show the different time, they will show the different action. Like the aminoglycan antibiotics have the maximum reduced drug toxicity if they are giving in the activity times in the daytime. The antihypertensive drug have the maximum concentration higher and the T maximum, that is time to reach a maximum, shorter after the morning than evening dosing depending on the lipophilic drugs, just like nifedipine, oral nitrates, propranolol are the maximum effect seen in when we are giving in the morning hours. Like the antitenolol is a hydrophilic drug, is not absorbed rapidly after the morning administration. AC inhibitors were found to be safe and effective when administered at the bedtime when compared to the morning. Taking blood pressure during going to the bed rather than in the morning can prevent more heart attack and strokes. However, there are still a variety of factors that may come into play. Older patients may be advised to take their blood pressure medication in the morning hours to prevent the fractures or fall during the night time as a result of sudden drop in the blood pressure. Anti-epileptic drug valproic acid show the C maximum tended to be higher and T maximum was shorter, and the constant K tended to be larger in the morning hour than compared with the evening. Similarly, anti-inflammatory drugs showing the maximum effect in the morning hours as compared to evening hours. Anti-migraine drugs also showing the circadian rhythm. The maximum concentration of better results in the morning hour drugs as compared with the evening hours dose. Anti-cancer drugs like the dihydropyridine dehydrogen enzyme in the human mononuclear cells increase by 40% around in the midnight. So this enzyme brings about the intracellular catabolism of fluoric acid or contribute to improved tolerability of the drug between the midnight to 4 a.m. Anti-hyperlipidemic drugs. More cholesterol synthesis takes place in the evening hours than in the morning with the involvement of the enzyme HMG coenzyme reductase. This enzyme is competitively inhibited by HMG coenzyme reductase statins. Hence, the statin should be administered in the evening hours rather than the morning. But there is an exception of the atorvastatin and rosuvastatin because they have the longer half-life. Opioids are better tolerated in the morning, so it is prescribed in the morning hours. Antipsychotic drugs also would be most effective producing sedative and antipsychotic effect when administered in the midnight and immediately after rising respectively. For haloperidol, administration in the evening hours would be best for obtaining the sedative and antipsychotic effects. Now, application and use of chronotherapy. These time-sensitive medications are used for treating the conditions like the oncology, bronchial asthma, hypertension, stroke, MI, sleep apnea, GI disorders, allergies, diabetes, Parkinson's, thyroid disorders, and for birth control. The few diseases like asthma are more in the morning hours because there is an exogenous factor like allergen exposures, dust and pollution, temperature changes during the day, position during the sleep. Endogenous factor also play in the role. Adrenergic blocking beta receptors, dominance of the alpha adrenergic pathway and cholinergic dominance, smallest concentration of IgE antibodies, highest concentration of histamine around 4 a.m., significantly small the bronchi diameter because of these effects. The blood pressure play important role in the stroke and MI because the BP rises about 20% immediately after awakening and least during the sleep. The first 2 hours after rising from the peaks hours for the MI are the more, hemorrhagic strokes are more, thrombotic infarction are also. Because there is an increased physical activity after awakening, increased catecholamines levels, increased platelet aggregation, in the vascular tone is increased. Viscosity is more in the morning hours. Here is some example that favor the drugs to be used in on time. The coir verapamil used in hypertension. It is formulated as a pill with a shell that dissolves slowly, taken at bedtime. It exerts peak effect at early morning hours and noon, no midnight dip in the BP. Similarly, the peptic ulcer also show the time-dependent treatment because the H. pylori and H. iron secreted in the stomach are more in the evening hours. So once daily doses of evening hours, ranitidine, cimetidine, famotidine are given in the evening time, reduce the chances of acidity and the peptic ulcer disorders. Allergic rhinitis are more in the morning hours and the evening. So once daily non-sedating drugs can be given, or in the night time dose can be prevent the early morning allergic rhinitis and infectious rhinitis. The conclusion of my today is, does timing of the medication really matters? Yes. The medication to be effective as possible as a taken drug at a particular time of the day. Timing may improve the potency of medicine. Timing help you to cope with the side effects. Timing reduce the drug-to-drug interaction or drug-to-food interaction. Timing improve the medicine adherence. Timing of the medicine relieve the symptoms and patient feels better. Timing increase the cure rates and patient will be disease-free timely. And timing reduce the drug resistance also. Thank you very much.
Thank you, Dr. Anil Samaria. You have defended your proposition extremely well. Now it is time for Dr. K. Manohar from Bengaluru, who is going to speak against the concept of timing of administration's importance. Dr. Manohar.
Thank you. Well, thanks to Dr. Anil Virmani, sir, for inviting me over all the way from Bangalore. It was my pleasure to be here. Controversies to consensus, so the number of debates are understandable. And the ultimate winner is the moderator, Ajay, who will say the science discussed by Dr. Anil and the practicality, what I talk, should be combined together for better outcomes. Debates should not confuse the audience. We don't have to tear each other apart. We should create a clear concept when they leave the hall. So that is the main thing what we should understand when we go about this. So how many think this topic itself is debatable? He clearly put forward that chronomedicine is the in thing, which is right. But how many of you think it is debatable? Is it debatable? When the topic was given, oh my God, how do I defend this was the first question which came to my mind. Is it debatable or undebatable? Debatable topic? Nobody thinks. Okay, I'll prove you wrong. Yeah, the timing of medications has always been a topic of debate. The people who argue, beautifully done. They talked about chronomedicine, effectiveness, side effect profile when you give it in the different time of the day without meal could also be minimized. But don't forget the compliance and the convenience. We may do wonderfully well talking science, but I can't follow it, is absolutely useless. He showed that one of the data where that 50% not taking in time led to complications. But if you make this time restrictions and meal restrictions so intense that if more than 50% do not take it, rather than taking some time, would cause more problem is one point what I would like to highlight here. Bookish versus practicality. Yes, theoretically, yes, no defense there, but practically, is it possible? Drugs with wide therapeutic window, you don't have to worry. Drugs with narrow therapeutic window, anti-epileptics, anti-arrhythmics, if I tell you can take whenever you want, I will be a fool. We are not going to defend the indefensible. But in practicality, when you practice effectiveness of the drug, potency, efficacy, all those things has to be kept in mind when we talk about which drug can be slightly lenient, especially when you're talking about chronic care therapy.
Yes, he rightly showed steroids preferable in the morning, maintain the circadian rhythm. Certain drugs are best absorbed, pre-meal, INH, rifampicin, but you club it into the 4 anti-tubercular drugs. Someone who definitely follows science, why should you have all combined in a single pill? But that is science for talking. But if you look at the sales where we prescribe, that is where it happens that it is combined. My professor always tells they should take all the anti-tubercular drug in empty stomach for better absorption. But how many people can tolerate it? Should we not consider that part of it and push it? However, whatever happens, you take it. Certain drugs are useless if you take it, if it's not given in the said way, like alpha-glucosidase inhibitor after the first morsel of meal. But if you are prescribing multiple medications, our list is endless, diabetic, hypertensive, heart disease, and so on. One drug with meal, one drug before meal, one drug after meal, one better at night, and one in the afternoon. So that causes complications. So we need to understand that. And of course, if you look at the number of prescriptions of alpha-glucosidase inhibitor in singular and in combination with the 3 drugs, sulfonylurea, metformin, and alpha-glucosidase inhibitors, which is actually crazy combination, when do you ask the patient to take? But if you allow the patient to take it with the meal, it could be much more effective, and the number of prescriptions and the outcome, A1C reduction. What is the point of using great science, but you don't have great outcomes when it comes to treatment? So that is the point what I'm trying to make it here. But that's what, are they practical? For example, of course, I always emphasize exercise is also a medicine, the most underutilized antidepressant. According to the recent diabetes guidelines, post-lunch exercise is the best for control of glycemia. So how many of us can do exercise post-lunch? If you make it so rigid in time, according to chronotherapy, that's the most important thing. We will fail. Some exercise is better than no exercise. If you can do it at lunch, it is better, but then do it sometime at least. Combinations of medications are the key. As I said, voglibose, metformin, or in many other combinations are available because it improves the compliance and the cost. Try giving patients multiple medications with multiple instructions. Compliance is poor. There are many studies to show that. Single pill with an altered slight deviation from the science will do wonders well and reduce the complications for the patient. Yes, he spoke about it. I don't think I need to talk about chronopharmacology. Timing the administration of drugs to optimize therapeutic effect, which he beautifully showed, and also the minimize the side effect. This also he showed various things happen different time of the day. But what do we do with people who are working in shift, people who are travelers? Nowadays, the new generation of netizens, where they work for different countries, and clinical inertia. When you put so many restrictions on a patient, this has to be done this way, and compliance doesn't come out very well. So this is a point to note for defending. It may not be as important. So what is most important? Yes, science is important, but patient preference is the key to compliance. Compliance is much more important than just timing, is what I'm trying to assert here. So restricted timings, but look at busy lifestyle, extremes of age, young and old, they may require someone to administer. If someone who is administering it or supervising it is not there, what happens to them? Compliance is important, and we all do polypharmacy, multiple drugs in combinations. Then it's all right to deviate from the science if you can improve the outcomes, improving the compliance. And of course, religious practices also should be taken into account. People are fasting or feasting, and nowadays we enforce ourselves with so many fancy fastings also. So in that time we can't definitely follow chronotherapy, but some intake in a slightly gap timing should not be much of a problem. But then science is also to our rescue, isn't it? Extended release formulations, if you look at it, they have minimized such problems. If it has to be taken 3-4 times a day, I would rather use a drug which can be taken once a day or twice a day, which does the work. Chronologically, it may not be the right, but then practically, and what we prescribe is definitely what it has to be there. And these extended release formulations release the drug at a predetermined rate, and they also suit to our convenience to more or less to peak during the maximal effect of the drug. So I think again, the advantage of extended release, I don't have to overemphasize. If you take it multiple, it can also give a peak and trough. And extended release preparations could give the much more flatter output. And we all know in the management of hypertension, short-acting drugs cause much more variations. So we prefer a long-acting drugs to be used in the management of hypertension. So this, by extending release of the drug, we can reduce the frequency, maintain therapeutic concentration, eliminate some of the toxicities, improve the patient's compliance, and minimize the local and systemic side effects also. But on the flip side, we stretch a bit too far also. This is, nowadays, I think one company has released an insulin. They say insulin as part fast acting. How fast is it? It's only 5 minutes faster. So I always joke with them, what happens in 5 minutes in our country? Yeah, they show this graph where it separates in 5 minutes, but what happens later is almost the same. So not every innovation has to be sold it in that way, but if there is an advantage which you can use it, we can use it by taking post-meal also. If you are on the table and you are not eating as much as you should, you can reduce the dose by utilizing this form of insulin as compared to the regular insulins. The bigger controversy which always was there or timing of anti-hypertensive medicine. As just a case, if you look at it, a lot of thoughts have been going through it. Best is to be taken in the night and not so much in the morning as usually people take, was the consensus what people do. But if you look at the data, clinical research material, if you look at it, review it, there is no clear consensus even today whether night is better than the morning. And actually compliance-wise, it can vary. For example, I myself am an hypertensive, and I thought, okay, I read a lot and I should take it at night, but I used to forget it a lot because I am more comfortable taking it in the morning rather than taking in the night. So even the European Society of Cardiology recent 2022 said evening dosing of blood pressure medications not better than the morning dose. But chronopharmacology always pushed towards saying that evening dosing is much better, as some slides shown by my friend there. Putting all these things apart, this is one of the important study, what I would like you to emphasize on, evaluation of medications administrating timing. Means this is a study which was done on almost 70,000 medication administrations in ICU setup and also in the ward setup. Two different types of medications. One is with a narrow timing interval, one with a wide timing interval. Means chronomedicine you are following, you have to give this drug within 30 minutes of what it is scheduled to 2 to 3 hours here and there. So this, what the study found out is, if you look at it, what actually happened, this is what we preach, that you give it on time, but in the hospital what happened, time critical medicines were given in time only in 69% of the cases, but non-time critical medicines were given more often at 84%. Means what happens is, what I am trying to say is, even though you wish and you have a lot of science to say that it has to be given in time, practically, even in the hospital setup, with the nurses, it never happened it that way. And more often they gave non-time critical medicines in time rather than the critical medicines in time. So even though medication administration policies exist, time critical scheduled medications are more commonly administered outside the time. But I'm not encouraging you people to say that don't give it in time. I'm trying to say practicality becomes important. It is better to give some time rather than not giving at all, thinking about the science and so on. So to conclude, medication effectiveness is determined definitely by the pharmacokinetics. Chronomedicine is very important, but chronomedicine with common sense, science with practicality is the way forward. It's not that he is right or I am wrong, and being practical outdoes most of the theoretical talks what we do. Thank you very much. Please come in the center stage. I have 2 more slides to show of the remote problem, if permitted.
I'm sure the entire audience will agree with me that both these speakers have done exceptionally well defending their part of their topic. So please give them a big hand. And now I invite Dr. Anil Samaria to put his rebuttal in 2 minutes.
As very well said, by the practical points is very good, but chrono medicine is very important part of the medicine taking, because most of the drugs, even diseases, are required timings. Because we are on time, your boss is happy. So disease will be cured better and timely. So I suggest taking time or taking medicine on time is very important part of life. And practical is also important, but only the 30% are careless people. Most of the patients are very careful about the diseases. So I recommend on-time medicine is very, very important part of the life, to encourage all the patient to take medicine on time as prescribed by doctor and pharmacist. Thank you.
Thank you, Anil. Now Dr. Manohar to put his rebuttal.
Yeah, chrono medicine is the way forward, but being practical is as important. As I said, chrono medicine, common sense, science, practicality, the verdict by the victor, Dr. Ajay Kumar, is the final.
I'm not going to pass any verdict. All that I can tell you that this kind of debate will go on forever. And I'll end this session by putting an analogy that very proudly I tell in front of my children that I go to bed at 10 o'clock and I'm in the field at 5 o'clock in the morning doing my jogging, and I get the rebuttal from my children, "What the hell are you doing, Dad? The life really starts after 10 p.m. If you are sleeping, you are missing all the funs of the life." And then I tell him, "Sonny, you are increasing the risk of suicide, you are very anxious, you are driving the epidemic of diabetes and heart disease," and they will come back with another rebuttal, "Let that be, but I will continue enjoying the life." So that's the way life goes on. We have to live with this. Thank you very much.
Thank you. Thank you, Dr. Anand.
Thank you, sir.
Thank you, Dr. Manor.
Thank you, sir. With this very, very amazing discussion on a very common topic, I don't have to add anything. I am myself confused. Okay, so may I request the chairperson to hand over the memento to our speakers. So to Dr. Anil from our chairperson. To Dr. Manohar, again from our chairperson, Dr. Ajay Kumar. Thank you. And to our chairperson from our speakers, jointly. Thank you so much. So, we come to an end of regular debates and symposium. Very interesting. We all are waiting for the event of the day, and that is medical quiz. Okay? So, let me add to it. There are 4 teams. One team is from Patna PMCH, Dr. Neha Kumari and Dr. Sumi Gond. Please raise your hand. Good. All the best. Next team is from Ranchi RIMS, Dr. Nilanjan Mai and Dr. Pooja Day. Please raise your hand. Come in the front. Come in the front. Next team is from Tata Motors, Dr. Afzal and Dr. Sarvans. Raise your hand and please come in the front. Push yourself in the front. And the last team is from TMH, Dr. Abhishek and Dr. Alipa. Please come in the front. So we have got 4 teams. We are going to arrange the sitting arrangements. It will be starting from there. Team 1, Team 2, Team 3 and Team 4. We will do a lottery कि कौन कहाँ किस टेबल पे बैठेगा. मैं एक एक करके बुलाऊंगा. You pick up the chit, okay? जो चिट आपका निकलेगा वो आपका सिटिंग अरेंजमेंट होगा. करो, पीछे करो। पहले बैठने का तो अरेंजमेंट।
नहीं सर, यह भी हो जाएगा ना सर, यहाँ देखेगा ना सर, अब लेते आओ, तो 4 चेयर लेते आओ।
एक एक तो Dr. Neha Kumari and Dr. Sumi Gone, please come on the stage. Please come this side. Come this side. Please come this side. There are the chits. Reshuffle it and pick up any one. Pick up any one. Reshuffle कर लो. कर लो. अच्छा anyway. So they are team 3. Dr. Virmani, where are you? Team 3. 3. बैठ जाओ. Dr. Nilanjan and Dr. Pooja Day. Pick up any one slip. Team 4. Put the chair here. Jaji, यहाँ पे 2 chair दीजिए. Sir, they are team 4. Dr. Afzal and Dr. Sarvesh. Pick up slip. Pick any one. Oi. So they are team 1. Dr. Virmani, go and put them. Team 1. And the last, Dr. Abhishek. Obviously, you will be team 2. Team 2.
Good evening, friends. We will start the medical quiz. First of all, please introduce yourselves, names.
I am Dr. Afzal, DNB Medicine resident from Tata Motors Hospital.
Hi, I am Dr. Sarvesh from Tata Motors Hospital, DNB second year.
So team 1 is Tata Motors. Dr. Arya, please write team 1 Tata Motors. Team 2, you got a mic there.
Hello, I am Abhishek Karkwal from TMH.
I am Dr. Alipa Sinha from TMH.
Team 3. Team 3, please.
Dr. Neha from PMCH Patna.
Dr. Sumi from PMCH Patna.
So team 3 is from PMCH Patna. Team 4.
Dr. Nilanjan Mal from RIMS Ranchi.
Dr. Pooja from RIMS Ranchi.
Okay. So we have Tata Motors, TMH, Patna and Muzaffarpur. Now this is just a warm-up. Can you tell me what is this? Anyone? It's open, just a warm-up. What is this?
Caduceus.
Yes? Anybody?
Sir, Caduceus.
Yes, very good. So this is caduceus, symbol of opposing forces in balance. Now can you tell me what is this?
CRTD.
Huh? What is this?
Sir, cardiac desynchronization therapy defibrillator, CRTD.
Anybody from the audience? What pacemaker? What type of pacemaker? Sorry? It is not going to the heart. The wire is not going into the heart. It is not a cardiac pacemaker. कान वाला machine है. Anybody else from the audience?
Vegas.
No, no. Okay. This is an implantable device that normalizes breathing, and basically it's stimulating the phrenic nerve here, and this is the answer for heart failure patients suffering from sleep apnea. So this is not a cardiac pacemaker. This is a phrenic stimulator. Very rarely seen. Okay, we'll start with round 1. Dr. Arya, please note the rules of the round 1. There are 4 questions for each team, 10 points for the right answer, minus 5 points for the wrong answer. But they have to give an answer. Okay? So we'll start with team 1. Team 1, a 9-year-old boy shows signs of early development of masculine characteristics. This is most likely to be secondary to an abnormal level of which hormone? Team 1, fast.
17-hydroxyprogesterone.
Sorry?
17-hydroxyprogesterone.
17-hydroxyprogesterone. You get 10 points. This is adrenogenital syndrome. Excellent, Tata Motors. Second to the TMS, team 2. Most common finding. The wording is most common finding in paroxysmal nocturnal hemoglobinuria is renal failure, hemolytic anemia, thrombosis, or bone marrow failure. In PNH, paroxysmal nocturnal hemoglobinuria.
B. Hemolytic anemia.
B. Hemolytic anemia. Excellent. 10 points to the TMS team. Now this is the most common finding. There are of course other findings. Team 3. In pregnancy, an elevated A1C at the time of conception is associated with all the following complications except A1C, elevated A1C at the time of conception. Which one, which complication you will not see? Yes? PMCH, come on.
Option E, open spina bifida.
Sorry?
Option E, open spina bifida.
Open spina bifida. That's the wrong answer. Chromosomal abnormalities you don't see. So remember, this is A1C at conception. So there will be birth defects, but not chromosomal abnormalities. Team 4. Team 3 minus 5. Team 4. Which of the following is the most common source of ectopic ACTH production in ectopic Cushing's syndrome? Which cancer is the most common source of ectopic ACTH production and it leads to ectopic Cushing syndrome?
Small cell lung cancer. Lung cancer.
Small cell lung cancer. Excellent. 10 marks to team. Second round we'll start with team 2, TMH. Ready? Following conditions usually causes hypokalemia in the absence of hypertension. Mind you, in the absence of hypertension,
It's Barter's syndrome.
excellent. It is Bartter syndrome. This is basically a congenital defect, inability to absorb sodium. There is increased urinary sodium loss, hyperaldosteronism, potassium wasting, and hypokalemic. Excellent. Team 3, a 15-year-old girl is investigated for primary amenorrhea despite having developed secondary sexual characteristics at 11 years of age. She has well-developed breasts, scanty pubic hair, and small bilateral groin swellings. What is the most likely diagnosis? Team 3, PMCH again. Give an answer.
Testicular feminization syndrome.
Testicular feminization syndrome. Is it correct? Excellent. This is X-linked recessive condition due to end organ resistance to testosterone, causing genotypically male children to have female phenotype. So, to them, plus 10. Team 4, upper motor neuron lesion. All of the following are correct, except, Dr. Ujwal, don't prompt. Very easy question. Muzaffarpur?
Fasciculations of muscle commonly seen.
Fasciculations of muscle commonly seen is the correct answer. They are seen in lower motor neuron lesions, not in upper motor neuron. Excellent. Plus 10. Team 4. Oh, rims, sorry, rims. Okay. Team 1, we'll go to team 1 for this round. Coat hanger headache is seen in which condition? Coat hanger headache is seen in which condition? Yes?
Cervical spondylosis.
Cervical spondylosis. Are they correct? What does the audience say? Syringomyelia? Who said syringomyelia? Dr. Das said syringomyelia. You are wrong. The correct answer is orthostatic hypotension. That is, headache is because it affects the neck and shoulder in a coat hanger pattern. That's classical of migraine. Team 3, this is they get minus. So we are starting team 3. Okay. Now team 3, we start with team 3 now. Maltese cross appearance. Maltese cross appearance RBC is seen in which condition? Dr. Jivan Mitra, don't prompt.
Babesiosis.
Huh?
Babesiosis.
Babesiosis. Correct, JK? Absolutely correct. You see this? This is a hemoprotozoan parasite of the rodents, it also is known as human babesiosis, and the Maltese cross form consists of 4 masses in an erythrocyte, and this is the characteristic of the development stage of the B microte. Team 4. What pattern is suggested by the following flow volume loop? Yes? You know what is a flow volume loop? What pattern is suggested?
Sir, restrictive pattern.
Huh?
Restrictive pattern.
Is it obstructive, restrictive, fixed upper airway, or variable interface?
Restrictive disease.
Restrictive disease.
Yes, sir.
Is it restrictive disease? Excellent. Why it is restrictive disease? The shape of the curve is relatively normal, but the size is reduced, so it is restrictive. Next to team 4. Then team 1, Brugada syndrome. Everybody knows about Brugada syndrome, but I want to know is it is linked with mutation of which gene, of which channel? Calcium, sodium, potassium, calcium activated, potassium channel. You must have heard of Brugada syndrome. Even today, Dr. Deepak Das talked about it, but of course they didn't mention which channel is involved. I want you to answer this question. Team 1?
Sodium channel.
Huh?
Sodium channel.
Sodium channel, excellent. This is the most mutation in the sodium channel alpha subunit SCN5A. Team 2, blueberry muffin baby. Blueberry muffin baby is due to what? Decreased platelet, decreased ferritin, extramedullary hematopoiesis, increased serum copper levels. Team 2, TMH, yes. Have you heard of blueberry muffin baby? Madam, don't prompt.
It's D, increased serum copper level.
Decreased ferritin levels, or increased serum copper levels. Increased serum copper levels. Madam, is it correct? Anybody from the audience? Sanjay? Pass. Okay, no, it's a wrong answer. The correct answer is extramedullary hematopoiesis, and this is the classical picture of a blueberry muffin baby. Then we go to, they get minus, team 2 is minus 5. Then we go to team 4. Now this is the last of this first round. We are starting with team 4. Potato nose. Potato nose, called rhinophyma, develops in certain individuals with which disease? Acne vulgaris, nodular acne, acne inversa, or acne rosacea? Yes?
Acne vulgaris.
Acne?
Vulgaris.
Acne vulgaris. Amit gets 10 points and they get minus 5. This is the classical potato nose and it is seen in acne rosacea. Team 1. Inverted champagne bottle appearance is seen in which condition? Now you will say that is not mentioned here. Yes, is it rheumatoid arthritis, lipodermatosclerosis, Derkham's disease, or dermatomyositis? Inverted champagne bottle. Have you seen an inverted champagne bottle? Team 1, Tata Motors. Sanjay, champagne नहीं दिखाया लोग को? Yes? Team 1 answer.
Lipodermatosclerosis.
Lipodermatosclerosis, excellent. This was a confusing because it is commonly known as shortcut Marie-Curie disease, but I didn't put that. This is the classical picture. Team 2, hungry bone syndrome. This is an easy one. Hungry bone syndrome is seen after extensive orthopedic surgery, liver transplant, adrenal surgery, parathyroid surgery.
Sir, it's D, parathyroid surgery.
D, parathyroid surgery, excellent. Mild hypocalcemia is common after partial parathyroidectomy, but some people experience persistently prolonged low calcium levels, and that is known as hungry bone syndrome. Team 3, salicylate poisoning. Salicylate poisoning causes typically which type of acidosis? High anion gap, low anion gap, metabolic or normal anion gap?
High anion gap acidosis.
High anion gap acidosis. Sanjay? No? Sanjay say no. It is the PMCH that is answering. You are right. That is, salicylate poisoning causes high anion gap acidosis, just like diabetic ketoacidosis. Now, this is the end of round 1. Before I go to the audience, scores for the round 1. Harpreet, where is Harpreet? अरे Harpreet
Hello.
को बुलाओ यार, chocolate निकालेगा.
Okay. So here we have got a score.
अरे काहे बाहर भाग जाते
Team 1 Tata Motors 25 points. Team 2 TMH 25 points. Team 3 PMCH 25 points.
Chocolate.
And team 4 RIMS Ranchi 25. So all are in same score. All are in now 25 each. Dr. Virmani sir.
Yes.
All 25. Loud round of applause for the whole team. Very neck to neck fight. Good. All the best. All 25 sir. Same. My God, yes. All the best.
Now, there are prizes for the audience also. So, they will now keep quiet and they will test your knowledge. What is the Birmingham paradox? Anybody from the audience? Birmingham paradox. Okay, I'll give you a hint. It's related to hypertension. Now anybody? I've given a hint. Yes? What J shape? No, no, no. Yes? Yes, go ahead, Joseph. Yes, go ahead. You are right, on the right path. Go ahead. Excellent. It's also called the thrombotic paradox of hypertension. The arterial walls are exposed to the surge of blood under high pressure. Yet the common complications of hypertension, such as MI and stroke, are paradoxically thrombotic rather than hemorrhagic. You get a prize, Jaidev.
He has asked you to collect on his behalf.
No, no, no. Congratulations.
Yes. Nandi, yaad rakhna. Okay.
Another question for the audience. Now, this question, you will not only get a chocolate, but I will pay you 500 rupees from my own pocket. Yes. What is caramel disease? If anybody in the audience can answer, he gets 500 rupees from me. What is caramel disease? Anybody? Okay, let me give you a hint. 500 rupees withdrawn. It is an acronym. Yes? Huh? Diphtheria.
Diphtheria.
Sorry? See, it's an acronym. It's an acronym. I'm giving you a Can you give him a mic, please? I can't hear him. Do you have a mic?
It's an acronym for metabolic diseases. It has been recently coined by some physician from US, United States.
What does it stand for?
Yeah, it stands
What
for,
does it stand for?
I think it's C is for the coronary and R is for renal. M is for metabolic, and L for lipids.
L for?
Lipid anomalies.
Okay, I'll give you the chocolate even though you have given an incorrect answer. Okay. Now, it is an acronym which stands for cardiac, renal, adipometabolic, eye and liver disease called caramel disease. Now, this was highlighted because these are the common complications of diabetes and metabolic syndrome. So this is the latest, you have right, it is in coin, but you forgot what are the exact words. So you lose 500 rupees. Anyway, round 2, clinical case. Now everyone will get one clinical case. 20 points, there are 2 questions to the case. So 10, 10. If they answer both, it's 20, otherwise 10. 10 points for the pass. Here they get pass. And the next you will get 10 points. Okay? Right? No, nothing to do with wrong answer. Now team 1, we start with team 1. This 12-year-old girl presented with a lump situated high in the midline of the neck. She was known hypothyroidism, treated with thyroxine, no signs of infection. Ultrasound showed a solid midline mass. Now the question that I want to ask is, what is this investigation and what is the diagnosis? So 10 marks for each answer. Yes, Tata Motors. What is this investigation? First question.
Investigation is thyroid scintigraphy.
Yes, very good. So they get 10 points for thyroid scintigraphy. What is the diagnosis? Once you know what you are telling.
Thyroglossal cyst. Thyroglossal cyst.
Thyroid is somewhere here. It is in an abnormal position, so what it will become? If thyroid is not in the normal position somewhere else, what do you call it?
Ectopic thyroid.
Absolutely correct. We'll give them both the marks, 20 points. So this is a thyroid scan, 99 mm technician. It's an ectopic thyroid gland. Okay, team 2. Now this 30-year-old female, diabetic, uncontrolled diabetes, hypertension, hyperlipidemia, she has developed these type of rashes. And there is no other history or contact. She is on insulin, labetalol, fenofibrate, fatty acid esters. The lesions are reddish yellow, pruritic, painful, and present in the backs of both legs and on the buttocks and knees. What is the diagnosis? And what is the most likely complication? Number 1, what is the diagnosis? Team 2. TMH, team 2, what is the diagnosis? The hint lies in the history. If you don't know, you can pass.
HSP, Henox colon purpura.
No. You pass. Team 3, would you like to take the risk? There is nothing to lose. If you can answer, you get 10 points. What is the diagnosis? Diabetes, hypertension, hyperlipidemia. Look at the history. What are these?
Edema nodosum or Sweet syndrome.
Erythema nodosum is something else. We'll come to the audience.
Sweet syndrome.
No. Risk? You want to take a chance? What is the diagnosis? No? Okay, now it goes to the audience. Eruptive xanthomatosis. And what is the most likely complication? Acute pancreatitis, excellent. Eruptive xanthomas leading to acute pancreatitis. So both get one chocolate each. Pass Dr. Nirmal, pass it Dr. R.K. Sinha.
Sir, this past question will not come back to them.
Nobody gets any mark. There is no negative marking in this. Okay, team 3. Again, this is a very easy one. 38-year-old male presents with facial paresthesias, upper extremity muscle cramping, progressive symptoms, mild paresthesis. Post-operatively, 1 day later, he had papillary thyroid carcinoma. He has undergone total thyroidectomy. The question is, what are the two signs? See, there are two signs being elicited. And what is the cause? Team 3, what are these two signs known as? In neurology, it's very easy. Team 3.
Sir, first one is the Chauvistic sign.
Yes, you are right. What is the second sign?
Trousseau sign.
Very good. Chauvistic sign and Trousseau sign. And what is the cause? She has undergone total thyroidectomy.
Parafollicular cells secretes calcitonin, which is an important marker, which is an important hormone for regulation of calcium. So because parafollicular cells are not.
So do you get 20 points? Chauvistic and Trousseau sign, post-surgical acquired hypoparathyroidism. Right. Now we go to team 4. A 45-year-old female, long-standing dyspnea when lying down, dysphagia to solid food, known hypothyroid. There is a solid, if you look at this, solid hyperemic spherical mass at the base of the tongue. There is a solid hyperemic spherical mass at the base of the tongue. What is the diagnosis and what is the treatment? Team 4. RIMS. What do you think this is? An arrow is being shown this here. At the base of the tongue, in front of the uvula, there is a mass. Spherical, hyperemic, spherical mass. You want to pass? Team 4? No?
Ectopic salivary gland. Salivary gland.
What gland?
Salivary gland. Salivary gland.
Parietal?
Salivary gland. Salivary gland, sir.
Salivary?
Yes, sir.
Ectopic salivary gland. No? Fast, we are running short of time.
Uvular swelling. Uvular swelling.
Uvular?
Swelling.
No.
Thyroglossal cyst.
No.
Lingual thyroid, sir.
Ectopic
Lingual
thyroid.
thyroid. Lingual thyroid.
And what is the treatment?
Excision. Excision, sir.
This is a case of ectopic thyroid.
Treatment. They have answered lingual thyroid. What is the treatment?
There is the
Sir,
so you resect and give permanent levothyroxine, or you do like replacement of that part of your.
sir, can I answer?
Lingual thyroid. Anybody in the audience? What is the treatment for lingual thyroid?
Sir, can I answer?
Yeah.
Sir, it's relocate the.
No. Anybody? Okay, they get only 10 points because they answered the right first question. It's a lingual thyroid, but the treatment is radioiodine therapy, orally. Not excision, not relocating. So radioiodine therapy is the treatment. Now, question for the audience. Now this 6-year-old boy, type 4 osteogenesis imperfecta. He has fractures here. I am not interested in the fracture of the middle shaft of right tibia. I want to know what are these lines called. You see these lines? What are these lines called and what are the manifestations of? No? You see these lines here? These look like lines on a zebra and they are known as radiographic zebra lines. And what are they due to? They are due to cyclic biphosphonate therapy in children given before closure of the epiphyseal growth plates. That is why you see the zebra lines. So nobody got this for the audience. Right. Next question for the audience. Now you see, I will cut it short. What do you see on a CT scan who has stiffness of both the ears? What does the CT scan show and what is the likely association? I have given you a hint, there is stiffness of the ears. What does it show? Anybody from the audience? Sorry? What is this? Calcified auricular cartilages, right? Excellent. And what is the likely association? No? No. Anybody else? Okay. Only one part of the answer is correct. This is auricular cartilage classification and it hints at Addison's disease, adrenal insufficiency. But I'll give you one chocolate, Dr. Sal.
Okay, at the end of round 2, we have got team 4 with 25 points, team 2 with 35 points, team 1 with 45 and team 3 with 45. So there is a tie with team 1 and team 3 with 45 each.
Team 3. Now this is round 3 spot diagram and you have to answer as fast as possible. 20 points for the right answer, minus 10 for the wrong answer. You have to give an answer and give it immediately. Don't waste time. Team 1, what is this?
Acral cyanosis.
Huh?
Acral cyanosis.
Acrocyanosis, what is it called? And what is it due to? Okay, let me give you a small history. This was 12 hours post PTCA. After the cardiologist did 12 hours post PTCA, patient had this problem in the feet. Okay, these are known as rash feet. It is because of cholesterol crystal embolism, because of the post PTCA. So they don't get any mark. But the wrong answer, they get minus. They get minus 10. Minus 10. 20 for right answer and minus 10 for the wrong. Team 2. What is this? I am pointing out the area also for you.
Koilonychia.
No. Anybody from the audience? Or
Sir,
anybody?
कोयलो नहीं किया.
No. No. Okay, it is known as Darius disease. Now these, you see the parallel white and red longitudinal streaks, these are pathognomonic of Darius disease. This is basically a skin disorder. Team 3.
Sir, they get -10. They get -10.
Minus. Team 3. This is a CT scan. What does it show? CT scan of the brain. Let me give you. A CT scan of the brain. What does it show? And there are two arrows. One white, one yellow. What do the yellow arrows show? What is the white arrow showing?
It shows signs of cerebral edema because of the compression. There's no any sulci prominency you seeing, so that's what it is showing. That's why you have that. What do you call it?
Excellent, excellent. It is cerebral edema, and what you see is
absence of silver.
there is loss of gray-white differentiation, and there is compression of the ventricles. So they get +20. Team 4. What is the diagnosis?
Hypothyroidism. Hyperthyroidism. Hyperthyroidism.
What is it? What are you? The picture is looking as what? What
Sir,
do you see?
sir, thyroid ophthalmopathy.
What is it called? Exophthalmos. Right? So
Exophthalmos.
this is exophthalmos. Now that was easy, but the difficult part is the patient hyperthyroid or is she euthyroid? Can you guess what is she likely to be? Is she euthyroid? Excellent. Pulling said euthyroid because you are seeing the scar here. That gives you a hint patient has undergone thyroidectomy. So the answer is exophthalmos. I'll give you for that +20. And why the answer correct? Because of the scar. Puneet, congratulations. Good observation. Because very few people are going to look at this scar. Everybody is looking here, nobody is looking at this scar. And that is thyroidectomy, post-thyroidectomy. Team 2. What is this? Team 2. What is the diagnosis?
Lupus vulgaris.
Lupus vulgaris. No. Anybody from the audience? Tophi? No. Who said Hansen? Who said Hansen? You're right. JK, congratulations. So it is lepromatous leprosy.
Sir, point kisko? Hey, JK sir,
Team 3. What is the diagnosis? These are the normal RBC and these are the abnormal RBC. Can you tell me the diagnosis?
Peripheral blood smear is showing echinocytes, that is symmetrical spikes, and
What is it called?
I think these are also called Burr cells.
No, you said spurs. No.
Yeah,
Spur cell hemolytic anemia, right?
Also, but I think spur is for acanthocytes, and these are echinocytes.
You see broken RBC also, fragmented RBC here.
Yeah,
here.
Yes,
So this is basically a spur cell with fragmented RBC. So this is spur cell hemolytic anemia. They get 20 points. They said spur cells. Team 4. Diagnosis. What diagnosis? This is very easy. What are you seeing?
Sir, vitamin B12 deficiency. Vitamin B12 deficiency.
Excellent. So do you see hyperpigmentation due to deficiency of vitamin B12 due to autoimmune gastritis. So they get 20 points. Team 4 gets 20 points. This is again a very classical picture of vitamin B12 deficiency. Team 1. What is the diagnosis? Team 1.
Lung abscess. Lung abscess.
Lung abscess. Bilateral. Do you see the shadows bilaterally? And look at the texture of the shadows. What is it? So, this is a wrong answer. I pass it to the audience, minus 10 to them. Anybody? Dr. D.P. Singh? Tubercular, miliary tuberculosis. No. No. Look at the texture. It looks like calcification. This is pulmonary alveolar microlithiasis, not pneumoconiosis. Pulmonary alveolar microlithiasis. Now, this is for the, at the end, what is the final score? Acha, you calculate. By the time I want to know from the audience, let me finish the audience. Just let me finish the audience. Now this is a CT scan in a patient of Wernicke's encephalopathy. What are these two white arrows seen? Pineal body calcification. Okay? It's basically mammillary bodies, but it's also the same thing. So you get a chocolate, Novesh. आपको भी मिल जाएगा ना. Answer this question. What is spot diagnosis and what is related to? You may not be able to tell the exact term what it is called, but tell me what is related. Sorry? No. What carcinoma? Okay. It is basically called erythema gyratum repens. It is a paraneoplastic manifestation of any carcinoma. So you are right, it's paraneoplastic. So JK gets another chocolate. And the last question, what is meant by a conference? We are having a conference for the last 2 days. What is meant by a conference? Dining, whining and enjoying, huh? No. The confusion of one man multiplied by the number present. Well friends, thank you. Give the final score.
Okay. So the moment has come. We have got TMS team, Dr. Abhishek and Alipa with 15 points. They are in the 4th position. We have got Tata Motors team, Dr. Afzal and Dr. Sarvesh with 25 points. They are in the 3rd position. And we have got team 4, RIMS, Dr. Pooja and Nilanjan with 65 points. They are the runners up. And the obvious winner is Dr. Neha and Sumi from PMCH with 85 points. So the winner is team 3. Congratulations. Runners up, team 4. Thank you.
Prizes will be given during the inauguration. And we have the inauguration now. Can you set the stage? Where is Darvesh Jai and Harpreet? Darvesh Jai and Harpreet, please set the stage for the inauguration.
माइक दीजिए तो माइक Hello, 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 hello. Am I audible to the people sitting at the end? Can I please get a feedback? Am I audible here? पीछे मेरी आवाज आ रही है क्या? Hello. Okay, yeah, okay. Thank you. Namaste everyone. And a very, very good evening to all the doctors and ladies and gentlemen assembled here. It is my immense pleasure and honor to be an anchor for this inaugural program. I am Dr. Veena Mundra, and on behalf of the Japicon committee, I extend a cheerful and warm welcome to all of you. Conferences like these are opportunities for like-minded, hard-working, dedicated, and knowledge-hungry doctors to gather together because they are constantly working, incessantly working for upgrading their art. Yes. Addressing patients' maladies and curing them is no less than an art. The organizing team has taken lots of painstaking efforts, numerous meetings, meticulous planning to make Japicon fruitful and engaging for all. And today, Japicon has finally arrived. We hope that this 3-day feast of knowledge turns out to be a good learning experience and lot of fun too. कैसे तारों का हुआ है आगमन आज यहाँ, कैसे तारों का हुआ है आगमन आज यहाँ, जैपिकॉन खींच लाया उन्हें जमशेदपुर आज यहाँ. Yes, ladies and gentlemen, today we have amongst us a galaxy of distinguished guests from the medical profession from all over India. We are grateful to all of you from the bottom of our hearts for accepting our invite and gracing the occasion. Thank you, doctors. ये मंच काफी सूना लग रहा है, तो आइए इस मंच की वीरानगी दूर करने के लिए सर्वप्रथम मैं आमंत्रित करती हूं हमारे चीफ गेस्ट डॉक्टर कमलेश तिवारी जी को, जो कि एपीआई के भूतपूर्व अध्यक्ष रह चुके हैं. उन्हें मंच पर आदरपूर्वक साथ लाने के लिए मैं आग्रह करती हूं झारखंड एपीआई के चेयरमैन डॉक्टर उमेश खान एवं आने वाले सत्र के अध्यक्ष डॉक्टर डी के सिंह जी को. डॉक्टर डी के सिंह जी, कृपया आप भी आएं. वेलकम ऑन द स्टेज सर. इस अहम मोड़ पर आदमी यूं ही नहीं पहुंचता है, और इनकी कड़ी मेहनत के लिए और आज यहाँ ये उपस्थित है उसके लिए जोरदार तालियां तो बनती है भाइयों, जोरदार. मंच की शोभा पुनः बढ़ाने के लिए मैं आमंत्रित करती हूं हमारे गेस्ट ऑफ ऑनर डॉक्टर ज्योतिर्मय पाल, जो कि इंडियन कॉलेज ऑफ फिजिशियंस के डीन हैं. इन्हें स्टेज पर लाने का अनुग्रह करती हूं जैपिकॉन के साइंटिफिक चेयरमैन डॉक्टर अनिल विरमानी जी को. तालियां तालियां. कृपया इन तालियों को अपने हाथों में कैद ना करें, इन्हें आजाद होने दीजिए. एक बार वन राउंड ऑफ बिग अप्लॉज. आई नो आप दिन भर कॉन्फ्रेंस अटेंड करके थक गए, लेकिन तालियां बजाने से आप में भी नई ऊर्जा उत्पन्न हो जाएगी, तो तालियां बजती रहनी चाहिए. अब आह्वान करती हूं अगले गेस्ट ऑफ ऑनर डॉक्टर डीपी सिंह जी का, जो एपीआई की गवर्निंग बॉडी के मेंबर हैं, और इन्हें मानपूर्वक मंच पर लाने के लिए मैं बुलाती हूं झारखंड एपीआई के सेक्रेटरी डॉक्टर विजय मुंद्रा और जैपिकॉन के ऑर्गेनाइजिंग सेक्रेटरी डॉक्टर राम कुमार जी को। देवियों और सज्जनों, आपके सामने मंच पर विराजमान है मेडिकल प्रोफेशन के चुनिंदा सितारे, जिनका मैंने जिक्र किया शुरुआत में, तो जोरदार तालियों से इनकी अगवानी तो बनती है। What better way to express our heartfelt welcome of our guests than with fragrance-full, beautiful flowers? I call upon Dr. Vijaya Bharat. Dr. Vijaya Bharat, please grace the occasion, come to the dais and present our tokens of love, flowers to our guests. Can I have somebody get the flowers, please? Can somebody get the flowers? All have been so busy with the conference. और दिल से तो हम स्वागत कर ही रहे हैं, ये फॉर्मेलिटियां निभा रहे हैं हम लोग। हमारे गेस्ट से मैं बता देती हूँ कि ये सब फॉर्मेलिटी है जो हम कर रहे हैं, दिल से आपका स्वागत हम कर रहे हैं। लेकिन आप मेरे इन शब्दों को फूल रूपी मानकर कृपया आप अनुरोध करें तो हम आगे बढ़ें। कुछ त्रुटियां रह गई हैं तो थोड़ा फूल आने में विलंब हो गया है, क्या हम आगे बढ़ सकते हैं? हम क्षमा प्रार्थी हैं। विद्यादायिनी अरहम मुख कमलवासिनी मां शारदा, शी इज द गॉडेस ऑफ नॉलेज एंड विजडम। I invite Dr. A.K. Pal to please come on stage and render the Saraswati Vandana to invoke her blessings. Dr. A.K. Pal, for you all.
Thank you, madam. सबको प्रणाम, जोहार, नमस्कार, and all our seniors, stage or dignitaries in the dais, सबको नमस्कार and जोहार. Good evening. सरस्वती महाभागे विद्या कौमुदलोचने विश्वरूपे विशालाक्षी विद्यां देहि नमस्तुते। या देवी सर्वभूतेषु विद्यारूपेण संस्थिता नमस्तस्मै 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 नमो नमः। या देवी सर्वभूतेषु ज्ञानरूपेण संस्थिता नमस्तस्मै 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 नमो नमः। या देवी सर्वभूतेषु बुद्धिरूपेण संस्थिता नमस्तस्मै 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 नमो नमः। या देवी सर्वभूतेषु कर्मरूपेण संस्थिता नमस्तस्मै 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 नमो नमः। या देवी सर्वभूतेषु शक्तिरूपेण संस्थिता नमस्तस्मै 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 नमो नमः। या देवी सर्वभूतेषु निद्रारूपेण संस्थिता नमस्तस्मै 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 नमो नमः। या देवी सर्वभूतेषु तुष्टिरूपेण संस्थिता नमस्तस्मै 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 नमो नमः। या देवी सर्वभूतेषु कान्तिरूपेण संस्थिता नमस्तस्मै 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 नमो नमः। या देवी सर्वभूतेषु शान्तिरूपेण संस्थिता नमस्तस्मै 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 नमो नमः। ओम शांति ओम शांति ओम शांति ओम शांति ओम शांति ओम।
Thank you so much, Dr. Pal. That was really very heart-touching. Bless us, Oma, so the pursuit for higher education and intelligence continues. Okay, so we just go one step behind, and I invite again Dr. Vijaya Bharat to please come and bestow the tokens of our love to our dear guests who have come all the way, leaving the comforts of their home to be with us. Ladies and gentlemen, तालियों की बहुत कमी हो रही है भाई. चाय नाश्ता तो सब करके बैठे होंगे मुझे लगता है, तो तालियां बजती रहनी चाहिए। वेलकम सर। Thank you so much, Dr. Vijaya. Taking ahead our agenda, I invite Dr. Umesh Khan, Chairman of API chapter, Jharkhand chapter, to deliver his welcome address. Dr. Umesh Khan.
Dear honorable guests, Dr. Kamlesh Tiwari, immediate past president, API, Dr. Jyotirmay Paul, Dean, Indian College of Physicians, Dr. D.P. Singh, member of governing body, API, my friend, Dr. G.C. Maji, IMA President, Dr. Saurabh Chaudhary, Secretary, IMA Jamshedpur, respected colleagues, ladies and gentlemen. On behalf of whole Japicon Program Committee, I would like to kindly welcome you all to Japicon 2023 being held in a beautiful historic city of steel, Jamshedpur. It is an honor to be here with you today. Purpose of this conference is providing an ideal academic platform for all specialists to disseminate their skill and awareness in their respective field of medical specialties. Before we start the conference, I would like to express my sincere gratitude toward most esteemed personalities who have accepted our invitation and kindly enough to part with us. Our scientific chairman, Dr. A.K. Birmani, has very methodically planned out the scientific program, which I'm sure are highly relevant and all of us shall benefit immensely. A very special warm welcome to all my colleagues, including Dr. H.S. Paul, Dr. Dilip Kumar, Dr. N.C. Singhal, Dr. Nirmal Kumar, Dr. Narendra Kumar Jha, Dr. R.L. Agarwal, Dr. Satish Prasad, Dr. Rajesh Thakur, Dr. A.K. Pal, Dr. Mrs. Nivedita Misra, and more very important is Dr. A.K. Arya, along with Mr. Kumar and all pharma officials. But it is really very important to name our two main force behind success of this conference, Dr. V.K. Mudra, Secretary, API, Jharkhand State, and Dr. Ram Kumar, Organizing Secretary of this API conference. They have worked hard day and night to make it success. I welcome them all. I do hope all my junior colleagues will find the events fruitful for their future career, for the sake of knowledge, and also for the benefit of humanity. Thank you.
हमारे अध्यक्ष लंबे हैं मेरे से, तो मुझे एडजस्ट करना पड़ रहा है. Dr. Umesh Khan, that was really very, very humble. He has accepted efforts of his colleagues and welcomed everybody so warmly, सबका personally नाम लेकर. That is really commendable. Light is considered a symbol of auspiciousness, abundance, and prosperity. Light brings brightness and dispels darkness. I request our revered guests to please begin the program with the auspicious lamp lighting. I request all our dignitaries. शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योति परब्रह्म दीपज्योति जनार्दनः दीपो मे हरतु पापम् दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते. Thank you so much. Memento gifting is just a way of keeping our memories in your minds alive for a very long time to come, dear guests. That's why it is beautifully called Smriti Chin or Pratik Chin in Hindi. I call upon respected Dr. Anil Virmani, sir, to do the honors.
Give the plugs to the rest of the guests. Give the gift to Dr. Mrs. Das.
I call upon Dr. Mrs. Das. Dr. Mrs. Das, can we have you on stage? आपके हाथों से प्लाक वितरण करेंगे. Thank you so much. Thank you so much, ma'am. हमारे मंचासीन अतिथि एवं डॉक्टर्स, आपसे गुजारिश है कि ये जो छोटा सा तोहफा हमने दिल से आपको दिया है, आप उसको एक वेंटेज पॉइंट पे अपने ऑफिस में ऐसी जगह रखिएगा ताकि जब आप देखेंगे आपको जैपिकॉन जमशेदपुर की याद आती रहे, यादें बनी रहे, तरोताज़ा रहे हमेशा। A secretary is the backbone of an organization. He has to organize, take initiative in activities, arrange and organize meetings, prepare the agenda, and keep records of all of this. And I have seen the Secretary of Jharkhand API work really hard to take it to newer heights. I invite the warm and friendly Secretary, Dr. Vijay Mundra, to present his report.
Good evening, dignitaries on the dais and ladies and gentlemen in the hall. When we took office in the month of February 2020, very soon COVID-19 struck and we were forced to stay indoors. So we organized webinars because physical meets were not possible. First of the webinars was held on 30th of August 2020. Theme being pure clinical medicine. It was a full day affair. President and Secretary of API Jharkhand chapter were installed online during the webinar. First wave of COVID-19 had swept the country. Scientific data were pouring in from different countries and different groups, but still there was no clarity on many aspects of the virus. So a webinar was organized on 1st October 2020 on the topic COVID-19, what and how much we know. Infectious disease specialist of national repute, Dr. Suresh Kumar was also one of the speakers. Next in chain of webinars was a 3-hour session on 31st, 2021. Then there was a lull in the activity as many of our colleagues and their family members were down with COVID-19. Then first joint ACP India and API Jharkhand chapter webinar was held on 5th September 2021. Again, it was online. Speakers of national fame enlightened us. Then things started opening up and API Jharkhand invited Dr. Lalit Kapoor, cardiothoracic surgeon, to deliver a talk on aortic stenosis on 14th of April 2022 in Jamshedpur. On 1st May 2022, a scientific session was organized in Jamshedpur on topic of resistant depression and resistant epilepsy. On 29th May 2022, a scientific session was held in Ranchi with support of API Ranchi, and Dr. D.K. Singh took very keen interest in that. Thank you, Dr. D.K. Singh. Then on 5th June 2022, a symposium was held on the topic hypertension and its implication in association with IMA Jamshedpur. On 5th November 2022, CME was organized in Ramgarh in association with Medanta Hospital Ranchi and API Ramgarh. We still remember the hospitality. They gave a very warm hospitality. So thanks to Team Ramgarh. Now our efforts have culminated in this scientific feast, Japicon 2023. Office bearers of Central API, Dr. Kamlesh Tiwari sir, immediate past president API, Dr. Jyotirmay Paul, Dean ICP, Dr. D.P. Singh, member governing body, are gracing the occasion. There is a galaxy of speakers coming from different parts of India. Almost 250 delegates from Jharkhand are attending the conference. Theme of the conference is From Controversies to Consensus. The delegates will go back to their respective places with consensus on different aspects of the disease imprinted on their minds. This will translate into better management of patients in their clinical practice. We had free paper award session for PG students. 15 papers were selected for this. There was 3 oration by 3 stalwarts. There was a quiz competition between 4 teams, each team comprising of 2 members. There are many sessions where learned speakers are enlightening us on diverse topics. Audience is going to enjoy 7 debates, and finally there will be a ECG learning session. So now we'll pass on the baton of API Jharkhand to the new team led by Dr. D.K. Singh. So we wish them all the best, and long live API Jharkhand and long live Central API. Thank you very much.
Thank you so much, Dr. Mundra. So as we all see that Japicon has organized something for everybody. There was space for lectures, there was space for quiz competition, there was space for debates. So this is like, a very proactive session, and I think the budding doctors are in great luck that something like this has been organized here. One of the brightest stars shining on the dais of illustrious prominent speakers is our very own Dr. Anil Virmani. An honored name in the medical circles, he is passionate about academic activities and works hard to propagate updated medical knowledge. His name commands great respect. I appeal to the scientific chairman, Dr. Anil Virmani ji, to deliver his address. Dr. Anil Virmani ji, for you all. He is an inspiring personality, और आपकी तालियों में गरम जोशी चाहिए मुझे, जोरदार तालियां.
Thank you, ma'am. Professor Dr. Kamlesh Tiwari, our chief guest. Dr. Jyotirmay Paul, Dean ICP, our guest of honor. Dr. D.P. Singh, Governing Council member of API, our guest of honor. Dr. Umesh Khan, Chairman API, till another few minutes. Our incoming chairman, Dr. D.K. Singh, Dr. Mundra, secretary, and the very dynamic organizing secretary, Dr. Ram Kumar, respected seniors, friends, ladies and gentlemen. the making of a scientific program is a very stressful job, especially in a conference like this, where you have got one hall, limited time, and huge number of speakers. Unlike the national conferences, where you have got 8 to 10 halls, 4 to 5 days, irrespective of the fact that majority of the halls are empty. But today, this hall was totally full, and that itself speaks of the success of the scientific program. When I was making the scientific program, I was very adamant that it will be nothing but pure science. In fact, I made my organizing secretary, Dr. Ram Kumar, unhappy because I refused to accede to the request of pharma companies to put their sponsored programs. And if you scrutinize the scientific program, this is one of those rare programs where there is not even a single talk which is pharma sponsored. Which means this was nothing but pure science, pure fun, pure knowledge. Whether it be debates, orations, keynote lectures, quiz, anything. The success of the scientific program depends on the attendance, the interaction of the delegates, the quality of speakers. That the quality of speakers was absolutely unsurpassable, there is no doubt. That the delegates who were sitting in the hall were interactive, asking questions, again there was no doubt. And that itself shows that this scientific program, this conference was a huge success. And I would like to inform you, Dr. Kamlesh Tiwari ji, that the success of the Jamshedpur conference is only because Jamshedpur worked as team, as a single team. And if you see, this is just a trailer. In 2026, when Bihar and Jharkhand will stand together, Japicon 26 will touch the sky. There is no limit. With these few words, thank you very much.
Spoken like a true dynamic leader. It's very vibrant, you know, the confidence, the amazing capability, the vision. It's too obvious. You cannot miss it. Thank you. Thank you, sir. Thank you so much. परिवर्तन ही प्रकृति का नियम है. झारखंड एपीआई के चेयरमैन डॉक्टर उमेश खान आज अपने अच्छे सत्र को समाप्त कर रहे हैं. कोविड की चुनौती से घिरे सत्र में भी डट कर रहे एपीआई के कार्य किए और आज एक बेहतरीन जैपिकॉन को अंजाम दिया है जो आप सब हम सब विटनेस कर रहे हैं यहाँ पे. कल से झारखंड एपीआई की नई लीडरशिप के तहत एक नया सत्र, एक नई सुबह, एक नई ऊर्जा के साथ सफर को आगे लेकर चलेंगे हमारे नए लीडरशिप. मैं आमंत्रित करती हूँ दोनों चेयरमैन्स को कि सामने आकर चेंज ऑफ कॉलर को विधिवत संपन्न करें. हमारे नवनिर्वाचित अध्यक्ष डॉक्टर डी.के. सिंह जी और निवर्तमान अध्यक्ष डॉक्टर उमेश खान. ये कुर्सियां बदलना एक तरीका है बताने का कि द जिम्मेदारी का बैटन हैज बीन पास्ड ओवर, इट हैज आगे बढ़ाया गया है. दोनों को ढेरों बधाइयां और नई टीम को ऑल द बेस्ट. उपदेश की अपनी महिमा है और भाषण का अपना सौंदर्य. विवेचना की अपनी शक्ति है और वक्तव्य की अपनी प्रधानता. परंतु जो संवेदना आशीर्वचनों में है वह अतुलनीय है. अपने आशीर्वचनों से हमें प्रोत्साहित करने मैं आमंत्रित करना चाहती हूं हमारे गेस्ट ऑफ ऑनर डॉक्टर डी.पी. सिंह जी को. वर्तमान में ये एपीआई के गवर्निंग बॉडी के मेंबर हैं. वेलकम सर.
धन्यवाद मीना जी। हमारे आदरणीय चीफ गेस्ट Dr. Professor Kamlesh Tiwari sir, who has been the immediate past, national past president of API, our mentor, our guest of honor, Dean of Indian College of Physicians, very dynamic man in the national scene, coming from Bengal, Dr. Jyotirmay Paul. And he had just visited Australia. And from Australia, he directly came to the airport, spent night near the hotel, and came back directly to this Jharkhand or Jamshedpur. Please, hats off to him. Our organizing chairman, come scientific chairman, and whose name is Dr. Anil Kumar Birmani. Hats off to you. From 8 a.m. in the morning to 8 p.m. in the evening, he was on the dash, moving here and there and enjoying, participating, directing each and every activity of today's I say. And 12 hours of this meticulous and then uninterrupted academic activity. Oh, this is really unsurpassable, this is really unparalleled, and every person coming from Mumbai to coming from Patna to coming from every town of India, all our galaxy of stars, they enjoyed this, and we are fortunate to come to this place, which is known as Jamshedpur. Jamshedpur, the dream city of Jamshedji Nasarwanji Tata. A place most beautiful, most organized, rather the third town in eastern India. From Kolkata to Patna to, I think this is the most beautiful city in the eastern India, where we are here and we are witnessing one of the greatest academic fest, that is Jharkhand Japicon 2020-23. And the leading this whole show, the outgoing chairman, our dear friend Umesh Khan, did his wonderful job as a chairman of API. And the incoming chairman of this API, coming from Ranchi, Dr. D.K. Singh, we have seen his activity in the API. He's so much dedicated to the cause of API, and we hope that Jharkhand will do better, and it will scale a new height. And we have given him the task that this API Jharkhand is just 200 API member. We wished it to be the 400 API member, so that we can not only think that Bihar and Jharkhand will flag scale the height, Jharkhand itself as a chapter will show that Jharkhand is also a chapter to be reckoned with in the national scene under the leadership of Dr. A.K. Birmani, Dr. D.K. Singh, and Dr. Umesh Khan, and yes, my dear friend, Dr. B.K. Mudra. Dr. B.K. Mudra, one of my very good friend, Dr. Shantanu Kumar Ghosh, he is heading the Department of Respiratory Medicine there, a very good friend of him. Whenever I thought of this Jamshedpur and an API man from Jamshedpur, so please give me contact. B.A. Kumar Mudra always come to, for 9 years I'm just doing the API job. One person always with me with love, affections and all the dedication. Again, thank you very much, Dr. Vijay Kumar Mudra, to have this mantle of this API Jharkhand chapter very high. When I reached this Jamshedpur town, this very dynamic man that I saw in the hall of this Alcor, one of the most beautiful hotel where we are housed. And we saw this man, organizing secretary of Dr. Ram Kumar. He welcomed me, and it's a very nice occasion. Thank you very much. And we have already seen this so much of this organizing capacity of yours. Congratulations to you. Sir, this Jharkhand town, and the first day itself, I saw this Chandil city. I narrated to Dr. Ajay Kumar sir. It's beautiful. beautiful place where you can do the boating, and that is a fantastic place. That should be as good as international site of attraction. There are a lot of things here in Jamshedpur. It is not only the Subarna Rekha Nadi full of golds. It is not only this different beautiful parks here, but today's scientific meet was superb and everybody enjoyed it, and we congratulate the whole organizing team for getting this scientific extravaganza in such a nice way. And all the activity, including the PGs, all the API members, and we hope that API Bihar and API Jharkhand will come together, and next year we shall arrange API Jharkhand and Bihar chapter in the annual nation state conference. Thank you very much with all the good wishes.
थैंक यू सो मच सर. कहते हैं ना कि जो हाथ गुलाब को तोड़ता है उस हाथ को भी उसकी खुशबू मिलती है. इतने बेहतरीन स्पीकर्स हैं, इतने अच्छे, इतने हम्बल लोग हैं. आप लोगों के साथ में सानिध्य में रहकर मुझे लगता है इंस्पिरेशन मिल रहा है. He has not forgotten to mention, in spite of his post, in spite of his stature, he has remembered each and every person who has made his stay here comfortable. Commendable truly sir. Inimitable style और impressive और सीखने लायक बात है. Thank you so much sir. प्रेरक उद्बोधन के लिए मैं एक ऐसे व्यक्तित्व को आमंत्रित कर रही हूँ जिनमें कार्यों को करने की निपुणता है और नेतृत्व करने की क्षमता भी है, जिनके ओज को देखकर दो पंक्तियां याद आ रही हैं. चांद से फूल से या मेरी जुबान से सुनिए, चांद से फूल से या मेरी जुबान से सुनिए, हर तरफ आपका किस्सा है जहां से सुनिए. आप पहचान तो गए होंगे कि मैं किसकी बात कर रही हूँ. आईसीपी के डीन डॉक्टर ज्योतिर्मय पाल डीन रहते हुए एक ऐसी नस्ल तैयार कर रहे हैं जिनका ध्येय है सेवा. वेलकम सर.
Respected Professor Kamalesh Tiwari, past President API and Chief Guest of today's program, Dr. D.P. Singh, Governing Body Member, Dr. Vibrant Personality, Dr. Birmani, Scientific Chairman, Dr. Ram Kumar, Organizing Secretary, Dr. Umesh Khan, Immediate Past President, Dr. D.K. Singh, Chairman API Jharkhand, Dr. Mundra, Secretary of API Jharkhand chapter, and all my friends, students, ladies and gentlemen. This is really a happy moment that API Jharkhand is successfully organized 8th annual conference at Jamshedpur. I must congratulate organizing team headed by Secretary Chairman of API Jharkhand chapter and organizing secretary, because just now I sent the picture of this full hall in the API West Bengal group. How it is possible at almost 9 p.m. hall is totally full. Even in the central API, Japicon, having 5,000 to 10,000 delegate in inauguration, halls are empty. I must convey 1,000 applause to Dr. Birmani that he has taken no pharma-sponsored program in scientific in the scientific program. Really, it is a challenge, and sir, I must congratulate you for your endeavor. During my speech, I mentioned approach to a geriatric patient, that there is a no demarcation. What age is called the geriatric age, 60 or 65. There is nothing, no demarcation. But in case of Dr. Birmani, I think totally discordance between the biological age and chronological age. It is very difficult to assess his chronological age, but biologically he is young. That age I can mention. Really, it is a proud moment for all of us from the API members of India. I am from the Central Committee. Few issues to inform you that we feel that API is for the academics improvement of the members. Because if you are academically up to date, you can give the best service to the patient. And that is our main aim. Whatever we do, conference, our learning, our teaching, everything for the patient. We are basically dedicated to the patient. That is why we feel center, state branch, city branch, all should work as a single unit. So that is why myself, our Honorable President Dr. Girish Mathur, Secretary General Agam Bhora, along with the governing body member, we started weekly meeting in rotation with the different state branch. First cycle is completed, again we will start the second cycle. So that whatever suggestion you have, you may have grievance, you can communicate with us, you can write to us through the contact us segment of the website, we have make it. And within 48 hours, you will get the reply. Whether we can solve your problem or we cannot solve the problem, or if we cannot solve the problem, why we cannot solve the problem, and what we will do in future with your suggestion. As a center, we are trying to sponsor some of the program planned by center and it will be implemented by the state branches. That we are taking some of the programs. We are publishing the newsletter every 3 months. Your state program, every state's program, even the members, any personal achievement, that will be published in the newsletter. We are trying to make membership, whether API membership or fellowship, online. That will be very easy for new members to apply for the membership. I request, you have so many learned person, and those who have completed 10 years MD and 5 years membership, please apply for the fellowship. And FICP, you be the member of ICP. ICP is the academic wing of the of API, and you enrich the ICP, give your guidance, contribute to the ICP, and academic as the academic wing, ICP will emerge as powerful as the RCP or ACP in the world. That is our dream. And we started to form the global forum of physicians, because India, we feel we should not work alone. We should motivate, and we should take with us our surrounding countries, and we should have an academic collaboration with USA, UK, European countries, Australia, New Zealand, with all the developed countries. And India will lead the global forum in future, and definitely will emerge as a strong regional, not only regional leader, global leader in the field of academic. Jai Hind, Vande Mataram. Need your support. Thank you.
इन बुद्धिजीवी महानुभावों को दिल से शुक्रिया करना चाहती हूँ कि इतने सरल शब्दों में हम सबके दिल को पहुंच जा रहे हैं, और गाइडेंस भी कर रहे हैं, अपना हाथ भी पकड़ रहे हैं, गाइडेंस भी कर रहे हैं, हमें पता भी नहीं चल रहा है कि हमें दिशा दिखा रहे हैं वो लोग. तहे दिल से शुक्रिया सर. अवार्ड, पुरस्कार एक ऐसा शब्द है जो अपने आप में समेटे है एक उत्साहजनक रोमांच, एक सुखद एहसास, मन के अंतर तक को छू जाने वाली अनुभूति. तो जनाब, शुरू होता है वह दौर, शुरू होता है वह दौर, खत्म होगा कहाँ ये मकाम, कि बांटते बांटते ये इनाम ढल न जाए ये सुहानी शाम. तो आगे पुरस्कारों की श्रृंखला का कार्य संभालने के लिए मैं पुनः डॉक्टर अनिल विरमानी जी को आमंत्रित करती हूँ.
Now, this is an award ceremony, and there are a number of awards and felicitations. We will start first. I would like to inform you all that the Public Health Foundation of India, PHFI, is conducting a course, 1-year course in certificate course in evidence-based diabetes management. And fortunately, I have been the faculty for the last 10 years. And Dr. J.K. Mitra will be joining this year from Ranchi as the faculty in Jharkhand. And we have the convocation, we had the exam I think this was the almost 8th or 9th batch that has passed. And I'll request the Dean to come and give the certificates to the successful candidates. Dr. Ajit Kumar Singh, are you here? Dr. Ajit Kumar Singh. Dr. Bijay Kumar Murmu. Dr. Gauri Bahaduri. Dr. Mahesh Kumar Goyal. Dr. Raghvendra Singh. Please come. Dr. Rajan Kumar Banwal. Dr. Santosh Kumar Gupta. Dr. Akash Chandra. Dr. Akash Chandra. Dr. Deepa Ghosh. Dr. Khushbu Rani. Dr. Maninder Kumar. Dr. Maninder Kumar. Dr. Rajan Kumar. Dr. Rashmi Sinha. Dr. Satyendra Prasad Yadav. Okay. So we had this number of candidates. Sir, 1 second. There is another thing. You please give it to USP people. They will distribute it directly. Then we had the free papers. So I think the free paper session was very interesting. We had 15 papers, and I have the results of the free paper awards with me. So I will request the Dean also to give this award to the papers, to the persons who had presented the papers. In the free paper, the first prize goes to Dr. Khushbu Kumari from RIMS. Dr. Khushbu Kumari from RIMS, can I have the free paper award? Dr. Pal, I'll request Dr. A.K. Pal to come here. Now, the prizes are very interesting. The first prize, let me tell you, this free paper was in memory of Bhavani Pal, mother of our senior member, Dr. Amir Pal, and he has contributed the 3 prizes. The first prize is rupees 25,000. Please give a big hand. First prize of rupees 25,000 to Dr. Khushbu Kumari from RIMS. The second prize is again from RIMS, Dr. Shreya Kashyap. Dr. Shreya Kashyap, second prize of rupees 15,000. Please give a big clap. And the third prize of rupees 10,000 goes to Dr. Tauhid Ahmed from Tata Main Hospital. Dr. Tauhid, is he here? No? Nivedita, can you please collect the award and give it to him? Rupees 10,000. Thank you, sir. This was for the academics. Thank you, Dr. Pal. I'll call you later. We had the medical quiz. All of you are witness to it. All of you know the results of the medical quiz. This medical quiz was sponsored by Tata Motors. And just because Dr. Sanjay Kumar Srivastava was the hand behind it, the man behind it, and we have trophy. The first prize for the medical quiz goes to team 3 from PMCH, Dr. Neha and Dr. Sumi. Can you please come, Dr. Neha and Dr. Sumi? I'll request Dr. DP Singh to please give the prizes for the medical quiz. The biggest trophy is for the first prize. There you go. Trophy, first prize to PMC's team. Please give a big clap. Thank you. Well done, girls. The second prize again it goes to Dr. Pooja and Dr. Nilanjan from RIMS. Dr. Pooja and Dr. Nilanjan from RIMS. Since all the teams very enthusiastically took part in this, we thought we'll also give consolation prize to the third and fourth team. So Tata Motors team, Dr. Afjal and Dr. Sarvesh, consolation prize for being in the medical quiz. Knowledge is not knowing everything, knowledge is learning day in and day out. And the last consolation prize to Dr. Abhishek and Dr. Alipa from Tata Main Hospital. Are they there from Tata Main Hospital? No. Again, I think Dr. Nivita will have to, she was in charge of the quiz team. Dr. Nivita, please collect the trophy, consolation prize for them. Thank you, sir. We have a tradition of felicitating our senior doctors who have contributed to the medical fraternity and to their patients in the last so many years in Jharkhand. So we will be felicitating those senior doctors with a shawl and a plaque. Mr. Darvesh Jha, can you be ready with the shawl and plaque? We will start with Dr. J.K. Mitra from Ranchi. And I'll request Dr. Kamlesh Tiwari ji to please felicitate our senior doctors. Dr. J.K. Mitra. On 29th April 2023, API Jharkhand chapter is pleased to confer the honor and felicitate Dr. J.K. Mitra from Ranchi for his outstanding contribution in the field of medicine in Jharkhand as well as India. Next, we'd like to...
Sure. So, thank you. I am overwhelmed. But एक का बात कहूँगा, इसे बहुत जल्दी मुझे इसके लिए आप लोगों ने योग्य समझा. मैं अभी भी कार्यकर्ता हूँ, कार्यकर्ता था, कार्यकर्ता रहूँगा. और एक ही बात कह सकता हूँ, एहसान तेरा दिल पे मेरे है दोस्तों, ये दिल तुम्हारे प्यार का मारा है दोस्तों. Thank you. धन्यवाद.
Thank you, JK. This was not a Lifetime Achievement Award. You will get that later on. So I know you will keep on working. Sir, just excuse me, there are some more doctors. Then Dr. R.K. Sinha from Jamshedpur. Dr. R.K. Sinha, please come, sir. a very senior physician, retired from MGM as the professor and then the principal. Thank you, sir. Now I'll request Dr. H.S. Pal to please come and receive the felicitation. Dr. H.S. Pal, sir. He is also a very senior physician from Tata Main Hospital, and I have worked with him for more than 25 years. Thank you, sir. Next, Dr. Dilip Kumar. Dr. Dilip Kumar, please come. Ready रखिए. Dr. R.L. Agarwal. Dr. R.L. Agarwal, please come for your felicitation. He is also a very senior member, retired from MGM Medical College as associate professor, or was it professor? Thank you, sir. Dr. Nirmal Kumar. He retired as HOD Medicine, MGM Medical College, and even after that, he keeps on going there and teaches. He is so academic minded. Dr. Nirmal Kumar. Lastly, it was Dr. Tamal Dev, but I believe he is out of station. So is Dr. Nandwani here? Dr. Nandwani? No. Okay, we will send it to him when he comes back from out of station. Now, I'll also like to felicitate 3 more doctors. First is Dr. Sanjay Srivastav, who was the mastermind and sponsored the trophies for the quiz. Dr. Sanjay Srivastav, are you here? Dr. Sanjay Srivastav, please come. When we told him that we were having a medical quiz, he immediately said, I will get it sponsored. And when I told him I want first and second prize, he said, no, I'll give you the consolation prizes also, so that every team is happy. Please give him a big hand. Next, I would like to felicitate none other than my good friend Dr. Amia Paul for sponsoring the free papers. See, the first prize was 25,000, second 15,000, third 10,000. He really deserves felicitation.
So kind of you, sir.
Now, since yesterday when we started the conference till today evening, there was one person who was standing very strong on the podium, and he was the star anchor. And I would like to call on Dr. A.K. Arya, who has done a wonderful job as an anchor, and I think he deserves this felicitation and a big hand. And I'm sure that he will be there tomorrow morning again at 8:30 to finish the conference. And for the debate, he has a debate tomorrow, good. And in the end, I would like to felicitate 3 more persons who are working behind the scenes to make this conference a grand success. One is Harpreet Singh from Subme Pharmaceuticals. Please come with the shawl and flag. Please felicitate Harpreet Singh. Right since 2 months, last 2 months, he has been with us, day in, day out. Everything, he said, any problem, I am there to look after. He really deserves a big hand. Then I would like to call upon Mr. Kumar from Tata Motors. Mr. Kumar, is Mr. Kumar there? Yeah. He was in charge of all the secretarial job, the souvenir and whatnot, and he was always there on call, coordinating with all these chief guests, everything. Thank you, Kumar. You have done a wonderful job. Unfortunately, he will be retiring this year and shifting to Bombay, so we will miss him in the next conference. And last but not the least, such a wonderful audio visuals you saw today, the LED screen, absolutely flawless audio visual, and none other than Dravesh Jha to be felicitated for that. And right sitting at Patna, he was in constant touch with me and getting things arranged. Fantastic. Please, a shawl and a block for him. A big hand. And this is the end of the success story, not the end. Maybe tomorrow we'll end, at the end of the conference, we'll say that this conference has really succeeded. Thank you, and that's the end of the award ceremony.
Thank you so much. Okay.
I'm extremely sorry. I did not include the pharma-sponsored papers, but pharma is with me, and we have a prize for the best stall. We had judges from outside who visited all these stalls, and they have given me a decision, okay, which was the best stall. And there is a trophy for the best stall. I will request Dr. D.P. Singh to please give this trophy to the best stall of the pharma industry in this conference. And this prize goes to, are the pharma people there? Please raise your hands. Aristo. Aristo gets the best prize for the best stall. The prize for the best stall. Anybody from Aristo here? Is anybody from Aristo here? They are getting the prize for the best stall. Please come with your team, Aristo. Best stall ka prize? Arpit, best stall ka prize? Please give them a big hand. They are the best stall in the conference.
Heartiest congratulations to all the winners and those who are in the run for the prizes as well. I was watching throughout the hall, जिन्हें प्राइज मिल रहा था वो तो जाहिर है क्यों खुश है, पर उन्हें प्राइज लेते हुए मैक्सिमम लोग यहाँ पे मुस्कुरा रहे थे, बहुत खुश हो रहे थे. That is a very healthy environment. And way to go, women power. I have seen the young brigade of women doctors. Way to go. As I said, prize always boosts confidence. It gives you recognition amongst your peers and gives you respect as well. Publishing a souvenir is always special. It keeps memories of the event alive for a long time to come. It showcases the achievements and the milestones that the Jharkhand API has achieved in this tenure. I request all dignitaries to kindly release the souvenir. Can I have the copies of the souvenirs, please, for all the dignitaries? Yes, thank you so much. Thank you so much, sirs. I think this copy must have been given in the kits. Am I right? Kits में दिया गया है ना? It's a beautiful book, you know. आप यदि किताब खोल करके देखेंगे, it's a beautiful book with beautiful pictures and lot of thought-provoking articles. I just went through the book today. So distinguished and inspiring personality of Dr. Kamlesh Tiwari, who has great experience and expertise in successfully leading the humongous organization of API. His words of benediction shall act like a lighthouse whenever the ship of the organization will be about to be upset by storms within and without. With these words, I invite our chief guest, Dr. Kamlesh Tiwari, to please bless the August gathering.
Chairman of the meeting, Dr. D.K. Singh, outgoing Chairman, Dr. Umesh Khan, towering personality of this conference, and Scientific Chairman, Dr. Birmani, organizing team as a whole, Dr. J. Paul, our Dean, ICP, Dr. D.P. Singh, governing body members, friends sitting in the front row in the audience, Ajay, B.K. Singh, and other friends. Our teacher, Rishikesh Babu, sitting here. I have seen him after a long time. Friends and my students. To speaking on this conference, I should only say it is superb. And why a conference is superb? There are 3 parameters to measure a conference. Number 1 is scientific feast, number 2 hospitality, and number 3 food. And in scientific program, Dr. Birmani has done a tremendous job so that house is full till 9:30 p.m. So 3 cheers to Dr. Birmani for his brilliant, successful scientific feast. Hospitality is superb and food is also very good. So you have scored on all fronts, Dr. Birmani. Second thing I am wondering, this Japicon, Bapicon, these words. What is Japicon? Actually, when I became secretary of this API, I became secretary at Ranchi. I did my conference at Dhanbad. I studied from RMCH and I became the first president of API from Jharkhand. I mean from Ranchi Medical College, Ranchi. So, whether I should be a Jharkhandi or whether I should be Bihari, it is difficult to decide. But major portion of my life in API is in Jharkhand. So I will say that Japicon and Bapicon will combine together and will do a mixed Epicon at Patna in 26. Is it so, Dr. Birmani? So I will congratulate him and bless for this conference because we are passing more time. People must be hungry. So with these words, I will thank for inviting me for this conference and success of this conference. Thank you very much.
Thank you so much, sir. Before I call upon the organizing secretary, Dr. Ram Kumar, to say his vote of thanks, I would like to congratulate the outgoing team of Jharkhand API for organizing such a brilliant Japicon and for its stupendous success too. It's just before before the conference is over, yet I'm taking the liberty to congratulate for tomorrow as well. And I profusely thank all of you for giving me this opportunity to host such a prestigious event. Thank you for your confidence in me. और अपनी वाणी को विराम देने से पहले मैं कहना चाहूंगी, नव सत्र की नई सुबह पर जब पड़ी पहली सूरज की किरण, खुशहाली का भंडार लिए मिले आपको यह अभिनंदन। सुनहरे भविष्य के सुंदर सपने हो आपके सदैव साकार। इन मंगल कामनाओं के साथ आपके सहयोग हेतु मेरा आभार, तहे दिल से शुक्रिया। वोट ऑफ थैंक्स फॉर ऑल ऑफ यू। डॉक्टर राम कुमार।
Thank you, ma'am. Good evening and Johar to all. All of you are hungry as well thirsty now, so I will not take much time of you all. Many of things has already been told by our seniors. So, our chief guest, Dr. Kamlesh Tiwari, immediate past president. Our guest of honor, Dr. Jyotirmay Paul, ICP Dean. Our guest of honor, Dr. DPC, the governing body API member, Dr. Umesh Khan, ongoing chairman, new chairman, Dr. DP Singh, secretary, Dr. Mundra, and Viruda. I told him, call him Viruda, lovely name. He's young and dynamic for his excellent contribution in scientific presentation and topics he selected for controversies to consensus. So today I feel very humbled and honored to extend my vote of thanks in this auspicious occasion of Japicon 23 on the behalf of all the organizing committee without whom this event was not successful. So Dr. Kamlesh Tiwari, our chief guest, our guest of honor, Dr. Paul and Dr. DPC has blessed us by coming here, and they have truly motivated us to do excellent work. I hope every aspect of topics he has discussed is wonderful, especially the aspect of geriatrics medicine, which is very much newly things, and it is upcoming because all the people are growing in India also, average is growing. So thank you, sir. Dr. DPC is masterly presentation on the MDR tuberculosis, and all the dignitaries of the dais, Dr. Ajay, Dr. N.K. Das, Dr. Nirmal sir, Dr. H.S. Paul, I thank you all for coming here. I also thank our junior PG students who has participated wholeheartedly in their presentation in medical quiz. Dr. Paul, who has contributed his part on behalf of the medical quiz and in the name of his mother, and Dr. Sanjay Srivastav, who has given a sponsorship for the medical quiz events. I also at this point I'd like to thank our pharma partners. All of them given generous contributions. Their presence has made me very much confident to organize this event. And the hotel partner, my hospitality partner, Alcor Hotel, Mr. Harjot, whose contribution and help has been immense to make all things feasible. His food is excellent. I hope we will like it. Not but last least, I also want to thank the media partners who has given the good coverage on every aspect of our program beautifully. Mr. Davresh Jha for the audiovisual, Mr. Harpreet for his main help. He is a truly partner with me, a partner in crime. And last but not least, I also thank my wife, my kids, who has spared me in this time. I could not give him the times in this period. So I also thank you all. So I will not take much time. This is the end of this vote of thanks, and food is ready for all of you. So thank you very much for coming.
I would request all to please stand for the national anthem. जन गण मन अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा। विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा। तव शुभ नामे जागे तव शुभ आशीष मागे। गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे। Thank you. Sumptuous food is waiting for all of you. Thank you so much.
One announcement. There is a arrangement of litti chokha and pani puri outside. Please enjoy it. This is one more notice to farmer people. Their dinner will be served at Alcor 1. Please enjoy. Oh, sorry, the litti chokha and pani puri has been inside the